Section 1 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Ann Walden. Anatomy of the Human Body, Part 2, by Henry Gray. Syndesmology, Introduction. The bones of the skeleton are joined to one another at different parts of their surfaces, and such connections are termed joints or articulations. Where the joints are immovable, as in the articulations between practically all the bones of the skull, the adjacent margins of the bones are almost in contact, being separated merely by a thin layer of fibrous membrane named the sutural ligament. In certain regions at the base of the skull this fibrous membrane is replaced by a layer of cartilage. Where slight movement combined with great strength is required, the osseous surfaces are united by tough and elastic fibrocartilages, as in the joints between the vertebral bodies and in the interpubic articulation. In the freely movable joints the surfaces are completely separated. The bones forming the articulation are expanded for greater convenience of mutual connection, covered by cartilage, and enveloped by capsules of fibrous tissue. The cells lining the interior of the fibrous capsule form an imperfect membrane, the synovial membrane, which secretes a lubricating fluid. The joints are strengthened by strong fibrous bands called ligaments, which extend between the bones forming the joint. Bone. Bone constitutes the fundamental element of all the joints. In the long bones, the extremities are the parts which form the articulations. They are generally somewhat enlarged, and consist of spongy cancellous tissue with a thin coating of compact substance. In the flat bones, the articulations usually take place at the edges, and in the short bones, at various parts of their surfaces. The layer of compact bone which forms the joint surface, and to which the articular cartilage is attached, is called the articular lamella. It differs from ordinary bone tissue in that it contains no Haversian canals, and its lacunae are larger and have no canaliculi. The vessels of the cancellous tissue, as they approach the articular lamella, turn back in loops, and do not perforate it. This layer is consequently denser and firmer than ordinary bone, and is evidently designed to form an unyielding support for the articular cartilage. Cartilage. Cartilage is a non-vascular structure which is found in various parts of the body. In adult life, chiefly in the joints, in the parietes of the thorax, and in various tubes, such as the trachea and bronchi, nose, and ears, which require to be kept permanently open. In the fetus, at an early period, the greater part of the skeleton is cartilaginous. As this cartilage is afterward replaced by bone, it is called temporary, in contradistinction to that which remains unossified during the whole of life, and is called permanent. Cartilage is divided, according to its minute structure, into hyaline cartilage, white fibrocartilage, and yellow or elastic fibrocartilage. Hyaline cartilage. Hyaline cartilage consists of a gristly mass of a firm consistence, but of considerable elasticity and pearly bluish color. Except where it coats the articular ends of bones, it is covered externally by a fibrous membrane, the perichondrium, from the vessels of which it imbibes its nutritive fluids, being itself destitute of blood vessels. It contains no nerves. Its intimate structure is very simple. If a thin slice be examined under the microscope, it will be found to consist of cells of a rounded or bluntly angular form, lying in groups of two or more, in a granular or almost homogeneous matrix. The cells, when arranged in groups of two or more, have generally straight outlines when they are in contact with each other, and in the rest of their circumference are rounded. They consist of clear translucent protoplasm, in which fine interlacing filaments and minute granules are sometimes present. Embedded in this are one or two round nuclei, having the usual intranuclear network. The cells are contained in cavities in the matrix, called cartilage lacunae. Around these the matrix is arranged in concentric lines, as if it had been formed in successive portions around the cartilage cells. This constitutes the so-called capsule of the space. Each lacuna is generally occupied by a single cell, but during the division of the cells it may contain 2, 4, or 8 cells. The matrix is transparent, and apparently without structure, or else presents a dimly granular appearance, like ground glass. Some observers have shown that the matrix of hyaline cartilage, and especially of the articular variety, after prolonged maceration, can be broken up into fine fibrils. These fibrils are probably of the same nature, chemically, as the white fibers of connective tissue. It is believed by some histologists that the matrix is permeated by a number of fine channels which connect the lacunae with each other, and that these canals communicate with the lymphatics of the perichondrium, and thus the structure is permeated by a current of nutrient fluid. Articular cartilage, costal cartilage, and temporary cartilage are all of the hyaline variety. They present differences in the size, shape, and arrangement of their cells. In articular cartilage, which shows no tendency to ossification, the matrix is finely granular, the cells and nuclei are small, and are disposed parallel to the surface in the superficial part, while nearer to the bone they are arranged in vertical rows. Articular cartilages have a tendency to split in a vertical direction. In disease this tendency becomes very manifest. The free surface of articular cartilage, where it is exposed to friction, is not covered by perichondrium, although a layer of connective tissue continuous with that of the synovial membrane can be traced in the adult over a small part of its circumference. And here the cartilage cells are more or less branched, and pass insensibly into the branched connective tissue corpuscles of the synovial membrane. Articular cartilage forms a thin incrustation upon the joint surfaces of the bones, and its elasticity enables it to break the force of concussions, while its smoothness affords ease and freedom of movement. It varies in thickness according to the shape of the articular surface on which it lies. Where this is convex, the cartilage is thickest at the center, the reverse being the case on concave articular surfaces. It appears to derive its nutriment partly from the vessels of the neighboring synovial membrane, and partly from those of the bone upon which it is implanted. Toynbee has shown that the minute vessels of the cancellous tissue, as they approach the articular lamella, dilate and form arches, and then return into the substance of the bone. In costal cartilage the cells and nuclei are large, and the matrix has a tendency to fibrous striation, especially in old age. In the thickest parts of the costal cartilages a few large vascular channels may be detected. This appears, at first sight, to be an exception to the statement that cartilage is a non-vascular tissue. But it is not so, really, for the vessels give no branches to the cartilage substance itself, and the channels may rather be looked upon as involutions of the perichondrium. The xiphoid process and the cartilages of the nose, larynx, and trachea, except the epiglottis and corniculate cartilages of the larynx, which are composed of elastic fibrocartilage, resemble the costal cartilages in microscopic characteristics. The arytenoid cartilage of the larynx shows a transition from hyaline cartilage at its base to elastic cartilage at the apex. The hyaline cartilages, especially in adult and advanced life, are prone to calcify, that is to say, to have their matrix permeated by calcium salts without any appearance of true bone. The process of calcification occurs frequently in such cartilages as those of the trachea and in the costal cartilages, where it may be succeeded by conversion into true bone. White fibrocartilage. White fibrocartilage consists of a mixture of white fibrous tissue and cartilaginous tissue in various proportions. To the former of these constituents it owes its flexibility and toughness, and to the latter its elasticity. When examined under the microscope, it is found to be made up of fibrous connective tissue arranged in bundles, with cartilage cells between the bundles. The cells to a certain extent resemble tendon cells, but may be distinguished from them by being surrounded by a concentrically striated area of cartilage matrix, and by being less flattened. The white fibrocartilages admit of arrangement into 4 groups: interarticular, connecting, circumferential, and stratiform. 1. The interarticular fibrocartilages, menisci, are flattened fibrocartilaginous plates of a round, oval, triangular, or sickle-like form, interposed between the articular cartilages of certain joints. They are free on both surfaces, usually thinner toward the center than at the circumference, and held in position by the attachment of their margins and extremities to the surrounding ligaments. The synovial membranes of the joints are prolonged over them. They are found in the temporomandibular, sternoclavicular, acromioclavicular, wrist, and knee joints, that is, in those joints which are most exposed to violent concussion and subject to frequent movement. Their uses are to obliterate the intervals between opposed surfaces in their various motions, to increase the depth of the articular surfaces and give ease to the gliding movements, to moderate the effects of great pressure and deaden the intensity of the shocks to which the parts may be subjected. Humphrey has pointed out that these interarticular fibrocartilages serve an important purpose in increasing the varieties of movement in a joint. Thus in the knee joint there are 2 kinds of motion, that is, angular movement and rotation, although it is a hinge joint, in which, as a rule, only one variety of motion is permitted. The former movement takes place between the condyles of the femur and the interarticular cartilages, the latter between the cartilages and the head of the tibia. So also in the temporomandibular joint, the movements of opening and shutting the mouth take place between the fibrocartilage and the mandible, the grinding movement between the mandibular fossa and the fibrocartilage, the latter moving with the mandible. 2. The connecting fibrocartilages are imposed between the bony surfaces of those joints which admit of only slight mobility, as between the bodies of the vertebrae. They form discs which are closely adherent to the opposed surfaces. Each disc is composed of concentric rings of fibrous tissue, with cartilaginous laminae interposed, the former tissue predominating toward the circumference, the latter toward the center. 3. The circumferential fibrocartilages consist of rims of fibrocartilage which surround the margins of some of the articular cavities, for example, the glenoidal labrum of the hip and of the shoulder. They serve to deepen the articular cavities and to protect their edges. 4. The stratiform fibrocartilages are those which form a thin coating to osseous grooves through which the tendons of certain muscles glide. Small masses of fibrocartilage are also developed in the tendons of some muscles, where they glide over bones, as in the tendons of the peroneus longus and tibialis posterior. The distinguishing feature of cartilage chemically is that it yields on boiling a substance called chondrin, very similar to gelatin, but differing from it in several of its reactions. It is now believed that chondrin is not a simple body, but a mixture of gelatin with mucinoid substances, chief among which, perhaps, is a compound termed chondromucoid. Ligaments. Ligaments are composed mainly of bundles of white fibrous tissue, placed parallel with, or closely interlaced with one another, and present a white, shining, silvery appearance. They are pliant and flexible so as to allow perfect freedom of movement, but strong, tough, and inextensible, so as not to yield readily to applied force. some ligaments consist entirely of yellow elastic tissue, as the ligamenta flava which connect together the laminae of adjacent vertebrae, and the ligamentum nuchae in the lower animals. In these cases the elasticity of the ligament is intended to act as a substitute for muscular power. The articular capsules. The articular capsules form complete envelopes for the freely movable joints. Each capsule consists of two strata, an external, stratum fibrosum, composed of white fibrous tissue, and an internal, stratum synovial, which is a secreting layer, and is usually described separately as the synovial membrane. The fibrous capsule is attached to the whole circumference of the articular end of each bone entering into the joint, and thus entirely surrounds the articulation. The synovial membrane invests the inner surface of the fibrous capsule, and is reflected over any tendons passing through the joint cavity, as the tendon of the popliteus in the knee, and the tendon of the biceps brachii in the shoulder. It is composed of a thin, delicate connective tissue, with branched connective tissue corpuscles. Its secretion is thick, viscid, and glairy, like the white of an egg, and is hence termed synovia. In the fetus this membrane is said, by Toynbee, to be continued over the surfaces of the cartilages, but in the adult such a continuation is wanting, excepting at the circumference of the cartilage, upon which it encroaches for a short distance, and to which it is firmly attached. In some of the joints the synovial membrane is thrown into folds which pass across the cavity. They are especially distinct in the knee. In other joints there are flattened folds, subdivided at their margins into fringe-like processes which contain convoluted vessels. These folds generally project from the synovial membrane near the margin of the cartilage, and lie flat upon its surface. They consist of connective tissue, covered with endothelium, and contain fat cells in variable quantities, and, more rarely, isolated cartilage cells. The larger folds often contain considerable quantities of fat. Closely associated with synovial membrane, and therefore conveniently described in this section, are the mucous sheaths of tendons and the mucous bursae. Mucous sheaths, vaginae mucosae, serve to facilitate the gliding of tendons in fibro-osseous canals. Each sheath is arranged in the form of an elongated closed sac, one layer of which adheres to the wall of the canal, and the other is reflected upon the surface of the enclosed tendon. These sheaths are chiefly found surrounding the tendons of the flexor and extensor muscles of the fingers and toes as they pass through fibro-osseous canals, in or near the hand and foot. Bursae mucosae are interposed between surfaces which glide upon each other. They consist of closed sacs containing a minute quantity of clear viscid fluid, and may be grouped, according to their situations, under the headings subcutaneous, submuscular, subfacial, and subtendinous. End of section 1.
Section 2 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 2, by Henry Gray. Development and classification of joints. Movement admitted in joints. 2. Development of the joints. The mesoderm, from which the different parts of the skeleton are formed, shows at first no differentiation into masses corresponding with the individual bones. Thus continuous cores of mesoderm from the axis of the limb buds, and a continuous column of mesoderm the future vertebral column. The first indications of the bones and joints are circumscribed condensations of the mesoderm. These condensed parts become chondrified and finally ossified to form the bones of the skeleton. The intervening, non-condensed portions consist at first of undifferentiated mesoderm, which may develop in one of three directions. It may be converted into fibrous tissue, as in the case of the skull bones, a synarthroidal joint being the result, or it may become partly cartilaginous, in which case an amphiarthroidal joint is formed. Again, it may become looser in texture and a cavity ultimately appears in its midst. The cells lining the sides of this cavity form a synovial membrane, and thus a diarthroidal joint is developed. The tissue surrounding the original mesodermal core forms fibrous sheaths for the developing bones, i.e. periosteum and perichondrium, which are continued between the ends of the bones over the synovial membrane as the capsules of the joints. These capsules are not of uniform thickness, so that in them may be recognized especially strengthened bands which are described as ligaments. This, however, is not the only method of formation of ligaments. In some cases, by modification of, or derivations from, the tendons surrounding the joint, additional ligamentous bands are provided to further strengthen the articulations. In several of the movable joints, the mesoderm which originally existed between the ends of the bones does not become completely absorbed. A portion of it persists and forms an articular disc. These discs may be intimately associated in their development with the muscles surrounding the joint, e.g. the menisci of the knee joint, or with cartilaginous elements, representatives of skeletal structures which are vestigial in human anatomy, e.g. the articular disc of the sternoclavicular joint. 3. Classification of joints. The articulations are divided into three classes: synarthroses, or immovable, amphiarthroses, or slightly movable, and diarthroses, or freely movable joints. Synarthroses, immovable articulations. Synarthroses include all these articulations in which the surfaces of the bones are in almost direct contact, fastened together by intervening connective tissue or hyaline cartilage, and in which there is no appreciable motion, as in the joints between the bones of the skull, excepting those of the mandible. There are four varieties of synarthrosis: sutura, scindilasis, gomphosis, and synchondrosis. Sutura. Sutura is that form of articulation where the contiguous margins of the bones are united by a thin layer of fibrous tissue. It is met with only in the skull. When the margins of the bones are connected by a series of processes and indentations interlocked together, the articulation is termed a true suture, sutura vera, and of this there are three varieties: sutura dentata, serrata, and limbosa. The margins of the bones are not in direct contact, being separated by a thin layer of fibrous tissue, continuous externally with the pericranium, internally with the dura mater. The sutura dentata is so called from the tooth-like form of the projecting processes, as in the suture between the parietal bones. In the sutura serrata the edges of the bones are serrated like the teeth of a fine saw, as between the two portions of the frontal bone. In the sutura limbosa there is besides the interlocking a certain degree of bevelling of the articular surfaces, so that the bones overlap one another, as in the suture between the parietal and frontal bones. When the articulation is formed by roughened surfaces placed in apposition with one another, it is termed a false suture, sutura notha, of which there are two kinds: the sutura squamosa, formed by the overlapping of contiguous bones by broad bevelled margins, as in the squamosal suture between the temporal and parietal, and the sutura harmonia, where there is simple apposition of contiguous rough surfaces, as in the articulation between the maxillae, or between the horizontal parts of the palatine bones. Scindilasis. Scindilasis is that form of articulation in which a thin plate of bone is received into a cleft or fissure formed by the separation of two laminae in another bone, as in the articulation of the rostrum of the sphenoid and perpendicular plate of the ethmoid with the vomer, or in the reception of the latter in the fissure between the maxillae and between the palatine bones. Gomphosis. Gomphosis is articulation by the insertion of a conical process into a socket. This is not illustrated by any articulation between bones, properly so called, but is seen in the articulations of the roots of the teeth with the alveoli of the mandible and maxillae. Synchondrosis. Where the connecting medium is cartilage, the joint is termed a synchondrosis. This is a temporary form of joint, for the cartilage is converted into bone before adult life. Such joints are found between the epiphyses and bodies of long bones, between the occipital and the sphenoid at, and for some years after, birth, and between the petrous portion of the temporal and the jugular process of the occipital. Amphiarthroses, slightly movable articulations. In these articulations the contiguous bony surfaces are either connected by broad flattened discs of fibrocartilage of a more or less complex structure, as in the articulations between the bodies of the vertebrae, or are united by an interosseous ligament, as in the inferior tibio-fibular articulation. The first form is termed a symphysis, the second a syndesmosis. Diarthrosis, freely movable articulations. This class includes the greater number of the joints in the body. In a diarthrodial joint the contiguous bony surfaces are covered with articular cartilage, and connected by ligaments lined by synovial membrane. The joint may be divided completely or incompletely by an articular disc or meniscus, the periphery of which is continuous with the fibrous capsule while its free surfaces are covered by synovial membrane. The varieties of joints in this class have been determined by the kind of motion permitted in each. There are two varieties in which the movement is uniaxial, that is to say, all movements take place around one axis. In one form, the gynglimus, the axis is, practically speaking, transverse. In the other, the trochoid or pivot joint, it is longitudinal. There are two varieties where the movement is biaxial, or around two horizontal axes at right angles to each other, or at any intervening axis between the two. These are the condyloid and the saddle joint. There is one form where the movement is polyaxial, the enarthrosis or ball and socket joint, and finally there are the arthrodia or gliding joints. Gynglimus or hinge joint. In this form the articular surfaces are moulded to each other in such a manner as to permit motion only in one plane, forward and backward, the extent of motion at the same time being considerable. The direction which the distal bone takes in this motion is seldom in the same plane as that of the axis of the proximal bone. There is usually a certain amount of deviation from the straight line during flexion. The articular surfaces are connected together by strong collateral ligaments, which form their chief bond of union. The best examples of gynglimus are the interphalangeal joints and the joint between the humerus and ulna. The knee and ankle joints are less typical, as they allow a slight degree of rotation or of side-to-side movement in certain positions of the limb. Trochoid or pivot joint. Articulatio trochoidea, rotary joint. Where the movement is limited to rotation, the joint is formed by a pivot-like process turning within a ring, or a ring on a pivot, the ring being formed partly of bone, partly of ligament. In the proximal radioulnar articulation, the ring is formed by the radial notch of the ulna and the annular ligament. Here, the head of the radius rotates within the ring. In the articulation of the odontoid process of the axis with the atlas, the ring is formed in front by the anterior arch, and behind by the transverse ligament of the atlas. Here the ring rotates around the odontoid process. Condyloid articulation. Articulatio ellipsoidea. In this form of joint, an ovoid articular surface or condyle is received into an elliptical cavity in such a manner as to permit of flexion, extension, adduction, abduction, and circumduction, but no axial rotation. The wrist joint is an example of this form of articulation. Articulation by reciprocal reception. articulatio cellaris, saddle joint. In this variety the opposing surfaces are reciprocally concavo-convex. The movements are the same as in the preceding form, that is to say, flexion, extension, adduction, abduction, and circumduction are allowed, but no axial rotation. The best example of this form is the Carpometacarpal joint of the thumb. Enarthrosis, ball and socket joints. Enarthrosis is a joint in which the distal bone is capable of motion around an indefinite number of axes, which have one common centre. It is formed by the reception of a globular head into a cup-like cavity, hence the name ball and socket. Examples of this form of articulation are found in the hip and shoulder. Arthrodia, gliding joints, is a joint which admits of only gliding movement. It is formed by the apposition of plane surfaces, or one slightly concave, the other slightly convex, the amount of motion between them being limited by the ligaments or osseous processes surrounding the articulation. It is the form present in the joints between the articular processes of the vertebrae, the carpal joints, except that of the capitate. Section 3 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 2, by Henry Gray. Articulations of the Vertebral Column. 5. Articulations of the Trunk. A. Articulations of the Vertebral Column. These may be divided into the following groups, viz. 1. Of the vertebral column. 2. Of the atlas with the axis. 3. Of the vertebral column with the cranium. 4. Of the mandible. 5. Of the ribs with the vertebrae. 6. Of the cartilages of the ribs with the sternum and with each other. 7. Of the sternum. 8. Of the vertebral column with the pelvis. 9. Of the pelvis. Articulations of the vertebral column. The articulations of the vertebral column consist of 1. A series of amphiarthroidal joints between the vertebral bodies, and 2. A series of diarthroidal joints between the vertebral arches. 1. Articulations of the vertebral bodies. Intercentral ligaments. The articulations between the bodies of the vertebrae are amphiarthroidal joints, and the individual vertebrae move only slightly on each other. When, however, this slight degree of movement between the pairs of bones take place in all the joints of the vertebral column, the total range of movement is very considerable. The ligaments of these articulations are the following: the anterior longitudinal, the posterior longitudinal, the intervertebral fibrocartilages, the anterior longitudinal ligament, ligamentum longitudinale anterius, anterior common ligament. The anterior longitudinal ligament is a broad and strong band of fibres, which extends along the anterior surfaces of the bodies of the vertebrae, from the axis to the sacrum. It is broader below than above, thicker in the thoracic than in the cervical and lumbar regions, and somewhat thicker opposite the bodies of the vertebrae than opposite the intervertebral fibrocartilages. It is attached above to the body of the axis, where it is continuous with the anterior atlantoaxial ligament, and extends down as far as the upper part of the front of the sacrum. It consists of dense longitudinal fibres, which are intimately adherent to the intervertebral fibrocartilages and the prominent margins of the vertebrae, but not to the middle parts of the bodies. In the latter situation the ligament is thick, and serves to fill up the concavities of the anterior surfaces, and to make the front of the vertebral column more even. It is composed of several layers of fibres which vary in length, but are closely interlaced with each other. The most superficial fibres are the longest and extend between 4 or 5 vertebrae. A second subjacent set extends between 2 or 3 vertebrae, while a third set, the shortest and deepest, reaches from one vertebra to the next. At the sides of the bodies the ligament consists of a few short fibres which pass from one vertebra to the next, separated from the concavities of the vertebral bodies by oval apertures for the passage of vessels. The posterior longitudinal ligament. Ligamentum longitudinale posterius. Posterior common ligament. The posterior longitudinal ligament is situated within the vertebral canal, and extends along the posterior surfaces of the bodies of the vertebrae, from the body of the axis, where it is continuous with the membrana tectoria, to the sacrum. It is broader above than below, and thicker in the thoracic than in the cervical and lumbar regions. In the situation of the intervertebral fibrocartilages and contiguous margins of the vertebrae, where the ligament is more intimately adherent, it is broad, and in the thoracic and lumbar regions presents a series of dentations with intervening concave margins. But it is narrow and thick over the centres of the bodies, from which it is separated by the basivertebral veins. The ligament is composed of smooth, shining, longitudinal fibres, denser and more compact than those of the anterior ligament, and consists of superficial layers occupying the interval between 3 or 4 vertebrae, and deeper layers which extend between adjacent vertebrae. The intervertebral fibrocartilages. Fibrocartilagenes intervertebrales. Intervertebral discs. The intervertebral fibrocartilages are interposed between the adjacent surfaces of the bodies of the vertebrae, from the axis to the sacrum, and form the chief bonds of connection between the vertebrae. They vary in shape, size, and thickness in different parts of the vertebral column. In shape and size they correspond with the surfaces of the bodies between which they are placed, except in the cervical region, where they are slightly smaller from side to side than the corresponding bodies. In thickness they vary not only in the different regions of the column, but in different parts of the same fibrocartilage. They are thicker in front than behind in the cervical and lumbar regions, and thus contribute to the anterior convexities of these parts of the column, while they are of nearly uniform thickness in the thoracic region, the anterior concavity of this part of the column being almost entirely owing to the shape of the vertebral bodies. The intervertebral fibrocartilages constitute about 1/4 of the length of the vertebral column, exclusive of the first 2 vertebrae. But this amount is not equally distributed between the various bones, the cervical and lumbar portions having, in proportion to their length, a much greater amount than the thoracic region, with the result that these parts possess greater pliancy and freedom of movement. The intervertebral fibrocartilages are adherent, by their surfaces, to thin layers of hyaline cartilage which cover the upper and under surfaces of the bodies of the vertebrae. In the lower cervical vertebrae, however, small joints lined by synovial membrane are occasionally present between the upper surfaces of the bodies and the margins of the fibrocartilages on either side. By their circumferences the intervertebral fibrocartilages are closely connected in front to the anterior, and behind to the posterior longitudinal ligaments. In the thoracic region they are joined laterally, by means of the interarticular ligaments, to the heads of those ribs which articulate with the 2 vertebrae. Structure of the intervertebral fibrocartilages. Each is composed, at its circumference, of laminae of fibrous tissue and fibrocartilage, forming the annulus fibrosus, and at its centre, of a soft, pulpy, highly elastic substance, of a yellowish colour, which projects considerably above the surrounding level when the disc is divided horizontally. This pulpy substance, nucleus pulposus, especially well developed in the lumbar region, is the remains of the notochord. The laminae are arranged concentrically. The outermost consist of ordinary fibrous tissue, the others of white fibrocartilage. The laminae are not quite vertical in their direction, those near the circumference being curved outward and closely approximated, while those nearest the centre curve in the opposite direction, and are somewhat more widely separated. The fibres of which each lamina is composed are directed, for the most part, obliquely from above downward, the fibres of adjacent laminae passing in opposite directions and varying in every layer, so that the fibres of one layer are directed across those of another, like the limbs of the letter X. This laminar arrangement belongs to about the outer half of each fibrocartilage. The pulpy substance presents no such arrangement, and consists of a fine fibrous matrix containing angular cells united to form a reticular structure. The intervertebral fibrocartilages are important shock absorbers. Under pressure, the highly elastic nucleus pulposus becomes flatter and broader, and pushes the more resistant fibrous laminae outward in all directions. 2. Articulations of vertebral arches. The joints between the articular processes of the vertebrae belong to the arthrodial variety and are enveloped by capsules lined by synovial membranes, while the laminae, spinous and transverse processes are connected by the following ligaments: the ligamenta flava, the ligamentum nuchae, the supraspinal, the interspinal, the intertransverse. The articular capsules, capsulae articulares, capsular ligaments. The articular capsules are thin and loose, and are attached to the margins of the articular process of adjacent vertebrae. They are longer and looser in the cervical than in the thoracic and lumbar regions. The ligamenta flava, ligamenta subflava. The ligamenta flava connect the laminae of adjacent vertebrae from the axis to the first segment of the sacrum. They are best seen from the interior of the vertebral canal. When looked at from the outer surface they appear short, being overlapped by the laminae. Each ligament consists of two lateral portions which commence one on either side of the roots of the articular processes, and extend backwards to the point where the laminae meet to form the spinous process. The posterior margins of the two portions are in contact, and to a certain extent united, slight intervals being left for the passage of small vessels. Each consists of yellow elastic tissue, the fibres of which, almost perpendicular in direction, are attached to the anterior surface of the lamina above, some distance from its inferior margin, and to the posterior surface and upper margin of the lamina below. In the cervical region the ligaments are thin, but broad and long. They are thicker in the thoracic region, and thickest in the lumbar region. Their marked elasticity serves to preserve the upright posture, and to assist the vertebral column in resuming it after flexion. The supraspinal ligament, ligamentum supraspinale, supraspinous ligament. The supraspinal ligament is a strong fibrous cord which connects together the apices of the spinous processes from the seventh cervical vertebra to the sacrum. At the points of attachment to the tips of the spinous processes, fibrocartilage is developed in the ligament. It is thicker and broader in the lumbar than in the thoracic region, and intimately blended, in both situations, with the neighbouring fascia. The most superficial fibres of this ligament extend over 3 or 4 vertebrae. Those more deeply seated pass between 2 or 3 vertebrae, while the deepest connect the spinous processes of the neighbouring vertebrae. Between the spinous processes it is continuous with the interspinal ligaments. It is continued upward to the external occipital protuberance and medial nuchal line, as the ligamentum nuchae. The ligamentum nuchae. The ligamentum nuchae is a fibrous membrane which, in the neck, represents the supraspinal ligaments of the lower vertebrae. It extends from the external occipital protuberance and the median nuchal line to the spinous process of the seventh cervical vertebra. From its anterior border a fibrous lamina is given off, which is attached to the posterior tubercle of the atlas, and to the spinous processes of the cervical vertebrae, and forms a septum between the muscles on either side of the neck. In man it is merely the rudiment of an important elastic ligament, which, in some of the lower animals, serves to sustain the weight of the head. The interspinal ligaments. Ligamenta interspinalia, interspinous ligaments. The interspinal ligaments, thin and membranous, connect adjoining spinous processes and extend from the root to the apex of each process. They meet the ligamenta flava in front and the supraspinal ligament behind. They are narrow and elongated in the thoracic region, broader, thicker, and quadrilateral in form in the lumbar region, and only slightly developed in the neck. The intertransverse ligaments. Ligamenta intertransversaria. The intertransverse ligaments are interposed between the transverse processes. In the cervical region they consist of a few irregular, scattered fibres. In the thoracic region they are rounded cords intimately connected with the deep muscles of the back. In the lumbar region they are thin and membranous. Movements. The movements permitted in the vertebral column are flexion, extension, lateral movement, circumduction, and rotation. In flexion, or movement forward, the anterior longitudinal ligament is relaxed, and the intervertebral fibrocartilages are compressed in front, while the posterior longitudinal ligament, the ligamenta flava, and the inter and supraspinal ligaments are stretched, as well as the posterior fibres of the intervertebral fibrocartilages. The interspaces between the laminae are widened, and the inferior articular processes glide upward upon the superior articular processes of the subjacent vertebrae. Flexion is the most extensive of all the movements of the vertebral column, and is freest in the lumbar region. In extension, or movement backward, an exactly opposite disposition of the parts takes place. The movement is limited by the anterior longitudinal ligament, and by the approximation of the spinous processes. It is freest in the cervical region. In lateral movement, the sides of the intervertebral fibrocartilages are compressed, the extent of motion being limited by the resistance offered by the surrounding ligaments. This movement may take place in any part of the column, but is freest in the cervical and lumbar regions. Circumduction is very limited, and is merely a succession of the preceding movements. Rotation is produced by the twisting of the intervertebral fibrocartilages. This, although only slight between any two vertebrae, allows of a considerable extent of movement when it takes place in the whole length of the column, the front of the upper part of the column being turned to one or other side. This movement occurs to a slight extent in the cervical region, is freer in the upper part of the thoracic region, and absent in the lumbar region. The extent and variety of the movements are influenced by the shape and direction of the articular surfaces. In the cervical region the upward inclination of the superior articular surfaces allows of free flexion and extension. Extension can be carried farther than flexion. At the upper end of the region it is checked by the locking of the posterior edges of the superior atlantal facets in the condyloid fossae of the occipital bone. At the lower end it is limited by a mechanism whereby the inferior articular processes of the seventh cervical vertebra slip into grooves behind and below the superior articular processes of the first thoracic. Flexion is arrested just beyond the point where the cervical convexity is straightened. The movement is checked by the apposition of the projecting lower lips of the bodies of the vertebrae with the shelving surfaces on the bodies of the subjacent vertebrae. Lateral flexion and rotation are free in the cervical region, they are, however, always combined. The upward and medial inclinations of the superior articular surfaces impart a rotary movement during lateral flexion, while pure rotation is prevented by the slight medial slope of these surfaces. In the thoracic region, notably in its upper part, all the movements are limited in order to reduce interference with respiration to a minimum. The almost complete absence of an upward inclination of the superior articular surfaces prohibits any marked flexion, while extension is checked by the contact of the inferior articular margins with the laminae, and the contact of the spinous processes with one another. The mechanism between the seventh cervical and the first thoracic vertebra, which limits extension of the cervical region, will also serve to limit flexion of the thoracic region when the neck is extended. Rotation is free in the thoracic region, The superior articular processes are segments of a cylinder whose axis is in the mid-ventral line of the vertebral bodies. The direction of the articular facets would allow of free lateral flexion, but the movement is considerably limited in the upper part of the region by the resistance of the ribs and sternum. In the lumbar region, flexion and extension are free. Flexion can be carried farther than extension, and is possible to just beyond the straightening of the lumbar curve. It is therefore greatest at the lowest part where the curve is sharpest. The inferior articular facets are not in close apposition with the superior facets of the subjacent vertebrae, and on this account a considerable amount of lateral flexion is permitted. For the same reason, a slight amount of rotation can be carried out, but this is so soon checked by the interlocking of the articular surfaces that it is negligible. The principal muscles which produce flexion are the sternocleidomastoideus, longus capitis, and longus colli, the scaleni, the abdominal muscles, and the psoas major. Extension is produced by the intrinsic muscles of the back, assisted in the neck by the splenius, semispinalis, dorsi and cervicis, and the multifidus. Lateral motion is produced by the intrinsic muscles of the back by the splenius, the scaleni, the quadratus lumborum, and the psoas major, the muscles of one side only acting, and rotation by the action of the following muscles of one side only, viz., the sternocleidomastoideus, Section 4 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 2, by Henry Gray. Articulation of Atlas with Epistropheus, of Vertebral Column with Cranium. 5b. Articulation of the Atlas with the Epistropheus or axis. Articulatio Atlanto-Epistrophica. The articulation of the atlas with the axis is of a complicated nature, comprising no fewer than 4 distinct joints. There is a pivot articulation between the odontoid process of the axis and the ring formed by the anterior arch and the transverse ligament of the atlas. Here there are 2 joints, one between the posterior surface of the anterior arch of the atlas and the front of the odontoid process, the other between the anterior surface of the ligament and the back of the process. Between the articular processes of the 2 bones there is on either side an arthrodial or gliding joint. The ligaments connecting these bones are 2 articular capsules, the anterior atlantoaxial, the posterior atlantoaxial, the transverse. The articular capsules, capsulae articularis, capsular ligaments. The articular capsules are thin and loose, and connect the margins of the lateral masses of the atlas with those of the posterior articular surfaces of the axis. Each is strengthened at its posterior and medial part by an accessory ligament, which is attached below to the body of the axis near the base of the odontoid process, and above to the lateral mass of the atlas near the transverse ligament. The anterior atlantoaxial ligament. This ligament is a strong membrane fixed above to the lower border of the anterior arch of the atlas, below to the front of the body of the axis. It is strengthened in the middle by a rounded cord, which connects the tubercle on the anterior arch of the atlas to the body of the axis, and is a continuation upward of the anterior longitudinal ligament. The ligament is in relation, in front, with the longi capitis. The posterior atlantoaxial ligament. This ligament is a broad, thin membrane attached above to the lower border of the posterior arch of the atlas, below to the upper edges of the laminae of the axis. It supplies the place of the ligamentum flava, and is in relation, behind, with the obliqui capitis inferioris. The transverse ligament of the atlas. Ligamentum transversum atlantis. The transverse ligament of the atlas is a thick, strong band which arches across the ring of the atlas and retains the odontoid process in contact with the anterior arch. It is concave in front, convex behind, broader and thicker in the middle than at the ends, and firmly attached on either side to a small tubercle on the medial surface of the lateral mass of the atlas. As it crosses the odontoid process, a small fasciculus, crus superius, is prolonged upward, and another, crus inferius, downward, from the superficial or posterior fibres of the ligament. The former is attached to the basilar part of the occipital bone, in close relation with the membrana tectoria. The latter is fixed to the posterior surface of the body of the axis. Hence the whole ligament is named the cruciate ligament of the atlas. The transverse ligament divides the ring of the atlas into two unequal parts. Of these, the posterior and larger serves for the transmission of the medulla spinalis and its membranes and the accessory nerves. The anterior and smaller contains the odontoid process. The neck of the odontoid process is constricted where it is embraced posteriorly by the transverse ligament, so that this ligament suffices to retain the odontoid process in position after all the other ligaments have been divided. Synovial membranes. There is a synovial membrane for each of the four joints. The joint cavity between the odontoid process and the transverse ligament is often continuous with those of the atlanto-occipital articulations. Movements. The opposed articular surfaces of the atlas and axis are not reciprocally curved. Both surfaces are convex in their long axes. When, therefore, the upper facet glides forward on the lower, it also descends. The fibres of the articular capsule are relaxed in a vertical direction, and will then permit of movement in an antero-posterior direction. By this means a shorter capsule suffices, and the strength of the joint is materially increased. Note 67. Corner. The Physiology of the Atlanto-Axial Joints. Journal of Anatomy and Physiology, Volume 41. States that the movements which take place at these articulations are of a complex nature. The first part of the movement is an eccentric or asymmetrical one. The atlanto-axial joint of the side to which the head is moved is fixed, or practically fixed, by the muscles of the neck, and forms the centre of the movement, while the opposite atlantal facet is carried downward and forward on the corresponding axial facet. The second part of the movement is centric and symmetrical, the odontoid process forming the axis of the movement. End of note. This joint allows the rotation of the atlas, and, with it the skull, upon the axis, the extent of rotation being limited by the alar ligaments. The principal muscles by which these movements are produced are the sternocleidomastoideus and semispinalis capitis of one side, acting with the longus capitis, splenius, longissimus capitis, rectus capitis posterior major, and obliqui capitis superior and inferior of the other side. 5c. Articulations of the vertebral column with the cranium. The ligaments connecting the vertebral column with the cranium may be divided into two sets: those uniting the atlas with the occipital bone, and those connecting the axis with the occipital bone. Articulation of the atlas with the occipital bone. Articulatio atlanto-occipitalis. The articulation between the atlas and the occipital bone consists of a pair of condyloid joints. The ligaments connecting the bones are: two articular capsules, the anterior atlanto-occipital membrane, the posterior atlanto-occipital membrane, two lateral atlanto-occipital. The articular capsules: capsulae articulares, capsular ligaments. The articular capsules surround the condyles of the occipital bone and connect them with the articular processes of the atlas. they are thin and loose. The anterior atlanto-occipital membrane, membrana atlanto-occipitalis anterior, anterior atlanto-occipital ligament. The anterior atlanto-occipitalis membrane is broad and composed of densely woven fibres, which pass between the anterior margin of the foramen magnum above and the upper border of the anterior arch of the atlas below. Laterally it is continuous with the articular capsules. In front it is strengthened in the middle line by a strong rounded cord, which connects the basilar part of the occipital bone to the tubercle on the anterior arch of the atlas. The membrane is in relation in front with the recti capitis anterioris, behind with the alar ligaments. The posterior atlanto-occipital membrane, membrana atlanto-occipitalis posterior, posterior atlanto-occipital ligament. The posterior atlanto-occipital membrane, broad but thin, is connected above to the posterior margin of the foramen magnum, below to the upper border of the posterior arch of the atlas. On either side this membrane is defective below, over the groove for the vertebral artery, and forms with this groove an opening for the entrance of the artery and the exit of the suboccipital nerve. The free border of the membrane, arching over the artery and nerve, is sometimes ossified. The membrane is in relation behind with the recti capitis posteriores minores and obliqui capitis superiores, in front with the dura mater of the vertebral canal, to which it is intimately adherent. The lateral ligaments. The lateral ligaments are thickened portions of the articular capsules, reinforced by bundles of fibrous tissue, and are directed obliquely upward and medialward. They are attached above to the jugular processes of the occipital bone, and below to the bases of the transverse processes of the atlas. Synovial membranes. There are two synovial membranes, one lining each of the articular capsules. The joints frequently communicate with that between the posterior surface of the odontoid process and the transverse ligament of the atlas. Movements. The movements permitted in this joint are a. Flexion and extension, which give rise to the ordinary forward and backward nodding of the head, and b. Slight lateral motion to one or other side. Flexion is produced mainly by the action of the longi capitis and recti capitis anteriores, extension by the recti capitis posteriores major and minor, the obliquus superior, the semispinalis capitis, splenius capitis, sternocleidomastoideus, and upper fibres of the trapezius. The recti laterales are concerned in the lateral movement, assisted by the trapezius, splenius capitis, semispinalis capitis, and the sternocleidomastoideus of the same side, all acting together. Ligaments connecting the axis with the occipital bone. The membrana tectoria, 2 alar, the apical odontoid. The membrana tectoria, occipito-axial ligament. The membrana tectoria is situated within the vertebral canal. It is a broad, strong band which covers the odontoid process and its ligaments, and appears to be a prolongation upward of the posterior longitudinal ligament of the vertebral column. It is fixed below to the posterior surface of the body of the axis, and, expanding as it ascends, is attached to the basilar groove of the occipital bone in front of the foramen magnum, where it blends with the cranial dura mater. Its anterior surface is in relation with the transverse ligament of the atlas, and its posterior surface with the dura mater. The alar ligaments. Ligamentia alaria, odontoid ligaments. The alar ligaments are strong, rounded cords which arise one on either side of the upper part of the odontoid process, and, passing obliquely upward and lateralward, are inserted into the rough depressions on the medial sides of the condyles of the occipital bone. In the triangular interval between these ligaments is another fibrous cord, the apical odontoid ligament, which extends from the tip of the odontoid process to the anterior margin of the foramen magnum, being intimately blended with the deep portion of the anterior atlanto-occipital membrane and superior crus of the transverse ligament of the atlas. It is regarded as a rudimentary intervertebral fibrocartilage, and in it traces of the notochord may persist. The alar ligaments limit rotation of the cranium and therefore receive the name of check ligaments. In addition to the ligaments which unite the atlas and axis to the skull, the
Section 5 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Leanne Howlett. Anatomy of the Human Body, Part 2, by Henry Gray. Articulation of the Mandible. 5D. Articulation of the Mandible. Articulatio mandibularis, temporomandibular articulation. This is the gingulomo-arthrodial joint. The parts entering into its formation on either side are the anterior part of the mandibular fossa of the temporal bone, and the articular tubercle above, and the condyle of the mandible below. The ligaments of the joint are the following: the articular capsule, the sphenomandibular, the temporomandibular, the articular disc, the stylomandibular. The articular capsule, capsula articularis capsular ligament. The articular capsule is a thin, loose envelope attached above to the circumference of the mandibular fossa and the articular tubercle immediately in front, below to the neck of the condyle of the mandible. The temporomandibular ligament, ligamentum temporomandibulare, external lateral ligament. The temporomandibular ligament consists of two short, narrow fasciculi, one in front of the other, attached above to the lateral surface of the zygomatic arch and to the tubercle on its lower border, below to the lateral surface and posterior border of the neck of the mandible. It is broader above than below, and its fibers are directed obliquely downward and backward. It is covered by the parotid gland and by the integument. The sphenomandibular ligament, ligamentum sphenomandibular, internal lateral ligament. The sphenomandibular ligament is a flat, thin band which is attached above to the spina angularis of the sphenoid bone, and, becoming broader as it descends, is fixed to the lingula of the mandibular foramen. Its lateral surface is in relation above with the pterygoideus externus. Lower down it is separated from the neck of the condyle by the internal maxillary vessels. Still lower, the inferior alveolar vessels and nerve and a lobule of the parotid gland lie between it and the ramus of the mandible. Its medial surface is in relation with the pterygoideus internus. The articular disc, discus articularis, interarticular fibrocartilage, articular meniscus. The articular disc is a thin oval plate placed between the condyle of the mandible and the mandibular fossa. Its upper surface is concavo-convex from before backward to accommodate itself to the form of the mandibular fossa and the articular tubercle. Its under surface, in contact with the condyle, is concave. Its circumference is connected to the articular capsule, and in front to the tendon of the pterygoideus externus. It is thicker at its periphery, especially behind, than at its center. The fibers of which it is composed have a concentric arrangement, more apparent at the circumference than at the center. It divides the joint into two cavities, each of which is furnished with synovial membrane. The synovial membranes. The synovial membranes, 2 in number, are placed one above and the other below the articular disc. The upper one, the larger and looser of the two, is continued from the margin of the cartilage covering the mandibular fossa and articular tubercle onto the upper surface of the disc. The lower one passes from the under surface of the disc to the neck of the condyle, being prolonged a little farther downward behind than in front. The articular disc is sometimes perforated in its center, and the two cavities then communicate with each other. The stylomandibular ligament, ligamentum stylomandibulare, stylomaxillary ligament. The stylomandibular ligament is a specialized band of the cervical fascia which extends from near the apex of the styloid process of the temporal bone to the angle and posterior border of the ramus of the mandible between the masseter and pterygoideus internus. This ligament separates the parotid from the submaxillary gland, and from its deep surface some fibers of the styloglossus take origin. Although classed among the ligaments of the temporomandibular joint, it can only be considered as accessory to it. The nerves of the temporomandibular joint are derived from the auriculotemporal and masseteric branches of the mandibular nerve, the arteries from the superficial temporal branch of the external carotid. Movements. The movements permitted in this articulation are extensive. Thus the mandible may be depressed or elevated, or carried forward or backward. A slight amount of side-to-side movement is also permitted. It must be borne in mind that there are two distinct joints in this articulation, one between the condyle and the articular disc, and another between the disc and the mandibular fossa. When the mouth is but slightly open, as during ordinary conversation, the movement is confined to the lower of the two joints. On the other hand, when the mouth is opened more widely, both joints are concerned in the movement. In the lower joint the movement is of a hinge-like character, the condyle moving around a transverse axis on the disc, while in the upper joint the movement is of a gliding character, the disc, together with the condyle, gliding forward onto the articular tubercle, around an axis which passes through the mandibular foramina. These two movements take place simultaneously. The condyle and disc move forward on the eminence, and at the same time the condyle revolves on the disc. In shutting the mouth the reverse action takes place. The disc glides back, carrying the condyle with it, and this at the same time moves back to its former position. When the mandible is carried horizontally forward, as in protruding the lower incisor teeth in front of the upper, the movement takes place principally in the upper joint, the disc and the condyle gliding forward on the mandibular fossa and articular tubercle. The grinding or chewing movement is produced by one condyle, with its disc gliding alternately forward and backward, while the other condyle moves simultaneously in the opposite direction. At the same time the condyle undergoes a vertical rotation on the disc. One condyle advances and rotates, the other condyle recedes and rotates, in alternate succession. The mandible is depressed by its own weight, assisted by the platysma, the digastricus, the mylohyoideus, and the geniohyoideus. It is elevated by the masseter, pterygoideus internus, and the anterior part of the temporalis. It is drawn forward by the simultaneous action of the pterygoidei internus and externus, the superficial fibers of the masseter and the anterior fibers of the temporalis, and backward by the deep fibers of the masseter and the posterior fibers of the temporalis. The grinding movement is caused by the alternate action of the pterygoidei of Section 6 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Leanne Howlett. Anatomy of the Human Body, Part 2, by Henry Gray. Costovertebral Articulations. 5e. Costovertebral Articulations. Articulations costovertebralis. The articulations of the ribs with the vertebral column may be divided into two sets, one connecting the heads of the ribs with the bodies of the vertebrae, another uniting the necks and tubercles of the ribs with the transverse processes. 1. Articulations of the heads of the ribs. Articulations capitularum, costocentral articulations. These constitute a series of gliding or arthrodial joints and are formed by the articulation of the heads of the typical ribs with the facets on the contiguous margins of the bodies of the thoracic vertebrae and with the intervertebral fibrocartilages between them. The first, 10th, 11th, and 12th ribs each articulate with a single vertebra. The ligaments of the joints are the articular capsule, the radiate, the interarticular. The articular capsule, capsula articularis, capsular ligament. The articular capsule surrounds the joint, being composed of short, strong fibers connecting the head of the rib with the circumference of the articular cavity formed by the intervertebral fibrocartilage and the adjacent vertebrae. It is most distinct at the upper and lower parts of the articulation. Some of its upper fibers pass through the intervertebral foramen to the back of the intervertebral fibrocartilage, while its posterior fibers are continuous with the ligament of the neck of the rib. The radiate ligament. Ligamentum capituli costi radiatum, anterior costovertebral or stellate ligament. The radiate ligament connects the anterior part of the head of each rib with the sides of the bodies of two vertebrae, and the intervertebral fibrocartilage between them. It consists of 3 flat fasciculi, which are attached to the anterior part of the head of the rib just beyond the articular surface. The superior fasciculus ascends and is connected with the body of the vertebra above. The inferior one descends to the body of the vertebra below. The middle one, the smallest and least distinct, is horizontal and is attached to the intervertebral fibrocartilage. The radiate ligament is in relation in front with the thoracic ganglia of the sympathetic trunk, the pleura, and on the right side with the azygos vein, behind with the interarticular ligament and synovial membranes. In the case of the first rib, this ligament is not divided into 3 fasciculi, but its fibers are attached to the body of the last cervical vertebra, as well as to that of the first thoracic. In the articulations of the heads of the 10th, 11th, and 12th ribs, each of which articulates with a single vertebra, the triradiate arrangement does not exist. But the fibers of the ligament in each case are connected to the vertebra above as well as to that with which the rib articulates. The interarticular ligament, ligamentum capituli costi interarticulaire. The interarticular ligament is situated in the interior of the joint. It consists of a short band of fibers, flattened from above downward, attached by one extremity to the crest separating the 2 articular facets on the head of the rib, and by the other to the intervertebral fibrocartilage. It divides the joint into 2 cavities. In the joints of the 1st, 10th, 11th, and 12th ribs, the interarticular ligament does not exist. Consequently, there is but one cavity in each of these articulations. This ligament is the homologue of the ligamentum conjugale, present in some mammals and uniting the heads of opposite ribs across the back of the intervertebral fibrocartilage. Synovial membranes. There are two synovial membranes in each of the articulations where an interarticular ligament exists, one above and one below this structure, but only one in those joints where there are single cavities. 2. Costotransverse articulations, articulations, costotransversarii. The articular portion of the tubercle of the rib forms with the articular surface on the adjacent transverse process an arthrodial joint. In the 11th and 12th ribs this articulation is wanting. The ligaments of the joint are the articular capsule, the anterior costotransverse, the posterior costotransverse, the ligament of the neck of the rib, the ligament of the tubercle of the rib. The articular capsule, capsula articularis, capsular ligament. The articular capsule is a thin membrane attached to the circumferences of the articular surfaces and lined by a synovial membrane. The anterior costotransverse ligament, ligamentum costotransversarium anterius, anterior superior ligament. The anterior costotransverse ligament is attached below to the sharp crest on the upper border of the neck of the rib and passes obliquely upward and lateralward to the lower border of the transverse process immediately above. It is in relation in front with the intercostal vessels and nerves. Its medial border is thickened and free, and bounds an aperture which transmits the posterior branches of the intercostal vessels and nerves. Its lateral border is continuous with the thin aponeurosis which covers the intercostalis externus. The first rib has no anterior costotransverse ligament. A band of fibers, the lumbocostal ligament, in series with the anterior costotransverse ligaments, connects the neck of the 12th rib to the base of the transverse process of the first lumbar vertebra. It is merely a thickened portion of the posterior layer of the lumbodorsal fascia. The posterior costotransverse ligament, ligamentum costotransversarium posterius. The posterior costotransverse ligament is a feeble band which is attached below to the neck of the rib and passes upward and medialward to the base of the transverse process and lateral border of the inferior articular process of the vertebra above. The ligament of the neck of the rib, ligamentum colli costi middle costotransverse or interosseous ligament. The ligament of the neck of the rib consists of short but strong fibers, connecting the rough surface on the back of the neck of the rib with the anterior surface of the adjacent transverse process. A rudimentary ligament may be present in the case of the 11th and 12th ribs. The ligament of the tubercle of the rib, ligamentum tuberculi costi posterior costotransverse ligament. The ligament of the tubercle of the rib is a short but thick and strong fasciculus which passes obliquely from the apex of the transverse process to the rough non-articular portion of the tubercle of the rib. The ligaments attached to the upper ribs ascend from the transverse processes. They are shorter and more oblique than those attached to the inferior ribs, which descend slightly. Movements. The heads of the ribs are so closely connected to the bodies of the vertebrae by the radiate and interarticular ligaments that only slight gliding movements of the articular surfaces on one another can take place. Similarly, the strong ligaments binding the necks and tubercles of the ribs to the transverse processes limit the movements of the costotransverse joints to slight gliding, the nature of which is determined by the shape and direction of the articular surfaces. In the upper 6 ribs the articular surfaces on the tubercles are oval in shape and convex from above downward. They fit into corresponding concavities on the anterior surfaces of the transverse processes, so that upward and downward movements of the tubercles are associated with the rotation of the rib neck on its long axis. In the 7th, 8th, 9th, and 10th ribs, the articular surfaces on the tubercles are flat, and are directed obliquely downward, medialward, and backward. The surfaces with which they articulate are placed on the upper margins of the transverse processes. When, therefore, the tubercles are drawn up they are at the same time carried backward and medialward. The two joints, costocentral and costotransverse, move simultaneously and in the same directions, the total effect being that the neck of the rib moves as if on a single joint, of which the costocentral and costotransverse articulations form the ends. In the upper 6 ribs the neck of the rib moves but slightly upward and downward. Its chief movement is one of rotation around its own long axis, rotation backward being associated with depression, rotation forward with elevation. In the 7th, 8th, 9th, and 10th ribs, the neck of the rib moves upward, backward, and medialward, or downward, forward, and lateralward. Very slight
Section 7 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Alistair Lord. Anatomy of the Human Body, Part 2, by Henry Gray. Sternocostal Articulations and Articulation of Manubrium and Body of Sternum. Sternocostal Articulations. Articulations sternocotales, costosternal articulations. The articulations of the cartilages of the true ribs with the sternum are arthrodial joints, with the exception of the first, in which the cartilage is directly united with the sternum, and which is, therefore, a synarthrodial articulation. The ligaments connecting them are the articular capsules, the interarticular sternocostal, the radiate sternocostal, and the costoxiphoid. The articular capsules, capsulae articulares, capsular ligaments. The articular capsules surround the joints between the cartilages of the true ribs and the sternum. They are very thin, intimately blended with the radiate sternocostal ligaments, and strengthened at the upper and lower parts of the articulations by a few fibres which connect the cartilages to the side of the sternum. The radiate sternocostal ligaments, ligamenta sternocostalia radiata, chondrosternal or sternocostal ligaments. These ligaments consist of broad and thin membranous bands that radiate from the front and back of the sternal ends of the cartilages of the true ribs to the anterior and posterior surfaces of the sternum. They are composed of fasciculi, which pass in different directions. The superior fasciculi ascend obliquely, the inferior fasciculi descend obliquely, and the middle fasciculi run horizontally. The superficial fibres are the longest. They intermingle with the fibres of the ligaments above and below them, with those of the opposite side, and in front with the tendinous fibres of origin of the pectoralis major, forming a thick fibrous membrane, the membrana sterni, which envelops the sternum. This is more distinct at the lower than at the upper part of the bone. The interarticular sternocostal ligament, ligamentum sternocostal interarticular, interarticular chondrosternal ligament. This ligament is found constantly only between the second costal cartilages and the sternum. The cartilage of the second rib is connected with the sternum by means of an interarticular ligament, attached by one end to the cartilage of the rib, and by the other to the fibrocartilage which unites the manubrium and body of the sternum. This articulation is provided with two synovial membranes. Occasionally the cartilage of the third rib is connected with the first and second pieces of the body of the sternum by an interarticular ligament. Still more rarely, similar ligaments are found in the other 4 joints of the series. In the lower 2, the ligament sometimes completely obliterates the cavity so as to convert the articulation into an amphiarthrosis. The costoxiphoid ligaments, Ligamenta costoxiphoidea, chondroxiphoid ligaments. These ligaments connect the anterior and posterior surfaces of the 7th costal cartilage, and sometimes those of the 6th, to the front and back of the xiphoid process. They vary in length and breadth in different subjects. Those on the back of the joint are less distinct than those on the front. Synovial membranes. There is no synovial membrane between the first costal cartilage and the sternum, as this cartilage is directly continuous with the Manubrium. There are 2 in the articulation of the second costal cartilage, and generally 1 in each of the other joints. But those of the 6th and 7th sternocostal joints are sometimes absent. Where an interarticular ligament is present, there are 2 synovial cavities. After middle life, the articular surfaces lose their polish, become roughened, and the synovial membranes apparently disappear. In old age, the cartilages of most of the ribs become continuous with the sternum, and the joint cavities are consequently obliterated. Movements. Slight gliding movements are permitted in the sternocostal articulations. Interchondral articulations. Articulations interchondrales, articulations of the cartilages of the ribs with each other. The contiguous borders of the 6th, 7th and 8th, and sometimes those of the 9th and 10th costal cartilages articulate with each other by small, smooth, oblong facets. Each articulation is enclosed in a thin articular capsule, lined by synovial membrane and strengthened laterally and medially by ligamentous fibers, interchondral ligaments, which pass from one cartilage to the other. Sometimes the 5th costal cartilages, more rarely the 9th and 10th, articulate by their lower borders with the adjoining cartilages by small oval facets. More frequently the connection is by a few ligamentous fibers. Costochondral articulations. The lateral end of each costal cartilage is received into a depression in the sternal end of the rib, and the 2 are held together by the periosteum. Articulation of the Manubrium and body of sternum. The Manubrium is united to the body of the sternum either by an amphiarthrodial joint, a piece of fibrocartilage connecting the segments, or by a diarthrodial joint, in which the articular surface of each bone is clothed with a lamina of cartilage. In the latter case, the cartilage covering the body is continued without interruption onto the cartilages of the facets for the second ribs. Rivington found the diarthrodial form of joint in about 1/3 of the specimens examined by him, Maisonneuve more frequently. It appears to be rare in childhood and is formed, in Rivington's opinion, from the amphiarthrodial form by absorption. The diarthrodial joint seems to have no tendency to ossify, while the amphiarthrodial is more liable to do so, and has been found ossified as early as 34 years of age. The 2 segments are further connected by anterior and posterior intersternal ligaments consisting of longitudinal fibers. Mechanism of the thorax. Each rib possesses its own range and variety of movements, but the movements of all are combined in the respiratory excursions of the thorax. Each rib may be regarded as a lever, the fulcrum of which is situated immediately outside the costotransverse articulation, so that when the body of the rib is elevated, the neck is depressed, and vice versa. From the disproportion in length of the arms of the lever, a slight movement at the vertebral end of the rib is greatly magnified at the anterior extremity. The anterior ends of the ribs lie on a lower plane than the posterior. When, therefore, the body of the rib is elevated, the anterior extremity is thrust also forward. Again, the middle of the body of the rib lies in a plane below that passing through the two extremities, so that when the body is elevated relatively to its ends, it is at the same time carried outward from the median plane of the thorax. Further, each rib forms a segment of a curve which is greater than that of the rib immediately above, and therefore the elevation of a rib increases the transverse diameter of the thorax in the plane to which it is raised. The modifications of the rib movements at their vertebral ends have already been described on page 302. Further modifications result from the attachments of their anterior extremities, and it is convenient therefore to consider separately the movements of the ribs of the three groups: vertebrosternal, vertebrochondral, and vertebral. Vertebrosternal ribs. The first rib differs from the others of this group in that its attachment to the sternum is a rigid one. This is counterbalanced to some extent by the fact that its head possesses no interarticular ligament and is therefore more movable. The first pair of ribs with the Manubrium sterni move as a single piece, the anterior portion being elevated by rotatory movements at the vertebral extremities. In normal quiet respiration, the movement of this arc is practically nil. When it does occur, the anterior part is raised and carried forward, increasing the anterior, posterior, and transverse diameters of this region of the chest. The movement of the second rib is also slight in normal respiration, as its anterior extremity is fixed to the manubrium, and prevented therefore from moving upward. The sternocostal articulation, however, allows the middle of the body of the rib to be drawn up, and in this way the transverse thoracic diameter is increased. Elevation of the third, fourth, fifth, and sixth ribs raises and thrusts forward their anterior extremities, the greater part of the movement being effected by the rotation of the rib neck backward. The thrust of the anterior extremities carries forward and upward the body of the sternum, which moves on the joint between it and the manubrium, and thus the antero-posterior thoracic diameter is increased. This movement is, however, soon arrested, and the elevating force is then expended in raising the middle part of the body of the rib and diverting its lower border. At the same time, the costochondral angle is opened out. By these latter movements, a considerable increase in the transverse diameter of the thorax is effected. Vertebrochondral ribs. The seventh rib is included with this group, as it conforms more closely with their type. While the movements of these ribs assist in enlarging the thorax for respiratory purposes, they are also concerned in increasing the upper abdominal space for viscera displaced by the action of the diaphragm. The costal cartilages articulate with one another, so that each pushes up that above it, the final thrust being directed to pushing forward and upward the lower end of the body of the sternum. The amount of elevation of the anterior extremities is limited on account of the very slight rotation of the rib neck. Elevation of the shaft is accompanied by an outward and backward movement. The outward movement everts the anterior end of the rib and opens up the subcostal angle, while the backward movement pulls back the anterior extremity and counteracts the forward thrust due to its elevation. This latter is more noticeable in the lower ribs, which are the shortest. The total result is a considerable increase in the transverse and a diminution in the median anterio-posterior diameter of the upper part of the abdomen. At the same time, however, the lateral anterio-posterior diameters of the abdomen are increased. Vertebral ribs. Since these ribs have free anterior extremities and only costocentral articulations with no interarticular ligaments, they are capable of slight movements in all directions. When the other ribs are elevated, these are depressed and fixed to form points of action for the diaphragm.
Section 8 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Leanne Howlett. Anatomy of the Human Body, Part 2 by Henry Gray. Articulation of Vertebral Column with Pelvis. 5H. Articulation of the vertebral column with the pelvis, the iliolumbar ligament. The ligaments connecting the fifth lumbar vertebra with the sacrum are similar to those which join the movable segments of the vertebral column with each other, viz. 1. The continuation downward of the anterior and posterior longitudinal ligaments. 2. The intervertebral fibrocartilage connecting the body of the fifth lumbar to that of the first sacral vertebra and forming an amphiarthrodial joint. 3. Ligamenta flava, uniting the laminae of the fifth lumbar vertebra with those of the first sacral. 4. Capsules connecting the articular processes and forming a double arthrodia. 5. Inter- and supraspinal ligaments. On either side an additional ligament, the iliolumbar, connects the pelvis with the vertebral column. The iliolumbar ligament, ligamentum iliolumbale. The iliolumbar ligament is attached above to the lower and front part of the transverse process of the fifth lumbar vertebra. It radiates as it passes lateralward and is attached by two main bands to the pelvis. The lower bands run to the base of the sacrum, blending with the anterior sacroiliac ligament. The upper is attached to the crest of the ilium immediately in front of the sacroiliac articulation, and is continuous above with the lumbodorsal fascia. In front it is in relation with the psoas major, behind with the muscles occupying the vertebral groove, above with the quadratus lumborum. 5I. Articulations of the pelvis. The ligaments connecting the bones of the pelvis with each other may be divided into four groups. 1. Those connecting the sacrum and ilium. 2. Those passing between the sacrum and ischium. 3. Those uniting the sacrum and coccyx. 4. Those between the two pubic bones. 1. Sacroiliac articulation, Articulatio sacroiliaca. The sacroiliac articulation is an amphiarthrodial joint formed between the auricular surfaces of the sacrum and the ilium. The articular surface of each bone is covered with a thin plate of cartilage, thicker on the sacrum than on the ilium. These cartilaginous plates are in close contact with each other, and to a certain extent are united together by irregular patches of softer fibrocartilage, and at their upper and posterior part by fine interosseous fibers. In a considerable part of their extent, especially in advanced life, they are separated by a space containing a synovia-like fluid, and hence the joint presents the characteristics of a diarthrosis. The ligaments of the joint are the anterior sacroiliac, the posterior sacroiliac, the interosseous. The anterior sacroiliac ligament, ligamentum sacroiliacum anterius. The anterior sacroiliac ligament consists of numerous thin bands which connect the anterior surface of the lateral part of the sacrum to the margin of the auricular surface of the ilium and to the pre-auricular sulcus. The posterior sacroiliac ligament, ligamentum sacroiliacum posterius. The posterior sacroiliac ligament is situated in a deep depression between the sacrum and ilium behind. It is strong and forms the chief bond of union between the bones. It consists of numerous fasciculi which pass between the bones in various directions. The upper part, short posterior sacroiliac ligament, is nearly horizontal in direction and pass from the first and second transverse tubercles on the back of the sacrum to the tuberosity of the ilium. The lower part, long posterior sacroiliac ligament, is oblique in direction. It is attached by one extremity to the third transverse tubercle of the back of the sacrum and by the other to the posterior superior spine of the ilium. The interosseous sacroiliac ligament, ligamentum sacroiliacum interosseum. This ligament lies deep to the posterior ligament and consists of a series of short, strong fibers connecting the tuberosities of the sacrum and ilium. 2. Ligaments connecting the sacrum and ischium. The sacrotuberous, the sacrospinous. The sacrotuberous ligament, ligamentum sacrotuberosum, great or posterior sacrosciatic ligament. The sacrotuberous ligament is situated at the lower and back part of the pelvis. It is flat and triangular in form, narrower in the middle than at the ends, attached by its broad base to the posterior inferior spine of the ilium, to the fourth and fifth transverse tubercles of the sacrum, and to the lower part of the lateral margin of that bone and the coccyx. Passing obliquely downward, forward, and lateralward, it becomes narrow and thick, but at its insertion into the inner margin of the tuberosity of the ischium, it increases in breadth and is prolonged forward along the inner margin of the ramus as the falciform process, the free concave edge of which gives attachment to the obturator fascia. One of its surfaces is turned toward the perineum, the other toward the obturator internus. The lower border of the ligament is directly continuous with the tendon of origin of the long head of the biceps femoris, and by many is believed to be the proximal end of this tendon, cut off by the projection of the tuberosity of the ischium. Relations. The posterior surface of this ligament gives origin, by its whole extent, to the gluteus maximus. Its anterior surface is in part united to the sacrospinous ligament. Its upper border forms, above, the posterior boundary of the greater sciatic foramen, and below, the posterior boundary of the lesser sciatic foramen. Its lower border forms part of the boundary of the perineum. It is pierced by the coccygeal nerve and the coccygeal branch of the inferior gluteal artery. The sacrospinous ligament, ligamentum sacrospinosum, small or anterior sacrosciatic ligament. The sacrospinous ligament is thin and triangular in form. It is attached by its apex to the spine of the ischium, and medially by its broad base to the lateral margins of the sacrum and coccyx in front of the sacrotuberous ligament with which its fibers are intermingled. Relations. It is in relation, anteriorly, with the coccygeus muscle to which it is closely connected. Posteriorly, it is covered by the sacrotuberous ligament and crossed by the internal pudendal vessels and nerve. Its upper border forms the lower boundary of the greater sciatic foramen. Its lower border part of the margin of the lesser sciatic foramen. These two ligaments convert the sciatic notches into foramina. The greater sciatic foramen is bounded, in front and above, by the posterior border of the hip bone, behind by the sacrotuberous ligament, and below by the sacrospinous ligament. It is partially filled up in the recent state by the piriformis, which leaves the pelvis through it. Above this muscle, the superior gluteal vessels and nerve emerge from the pelvis, and below it the inferior gluteal vessels and nerve, the internal pudendal vessels and nerve, the sciatic and posterior femoral cutaneous nerves, and the nerves to the obturator internus and quadratus femoris make their exit from the pelvis. The lesser sciatic foramen is bounded in front by the tuberosity of the ischium, above by the spine of the ischium and sacrospinous ligament, behind by the sacrotuberous ligament. It transmits the tendon of the obturator internus, its nerve, and the internal pudendal vessels and nerve. 3. Sacrococcygeal symphysis, symphysis sacrococcygia. Articulation of the sacrum and coccyx. This articulation is an amphiarthrodial joint, formed between the oval surface at the apex of the sacrum and the base of the coccyx. It is homologous with the joints between the bodies of the vertebrae and is connected by similar ligaments. They are the anterior sacrococcygeal, the posterior sacrococcygeal, the lateral sacrococcygeal, the interposed fibrocartilage, the interarticular. The anterior sacrococcygeal ligament, ligamentum sacrococcygeum anterius. This consists of a few irregular fibers, which descend from the anterior surface of the sacrum to the front of the coccyx, blending with the periosteum. The posterior sacrococcygeal ligament, ligamentum sacrococcygeum posterius. This is a flat band which arises from the margin of the lower orifice of the sacral canal, and descends to be inserted into the posterior surface of the coccyx. This ligament completes the lower and back part of the sacral canal and is divisible into a short deep portion and a longer superficial part. It is in relation behind with the gluteus maximus. The lateral sacrococcygeal ligament, ligamentum sacrococcygeum lateral, intertransverse ligament. The lateral sacrococcygeal ligament exists on either side and connects the transverse process of the coccyx to the lower lateral angle of the sacrum. It completes the foramen for the fifth sacral nerve. A disc of fibrocartilage is interposed between the contiguous surfaces of the sacrum and coccyx. It differs from those between the bodies of the vertebrae in that it is thinner, and its central part is firmer in texture. It is somewhat thicker in front and behind than at the sides. Occasionally the coccyx is freely movable on the sacrum, most notably during pregnancy. In such cases, a synovial membrane is present. The interarticular ligaments are thin bands which unite the cornua of the two bones. The different segments of the coccyx are connected by the extension downward of the anterior and posterior sacrococcygeal ligaments, thin annular discs of fibrocartilage being interposed between the segments. In the adult male, all the pieces become ossified together at a comparatively early period, but in the female, this does not commonly occur until a later period of life. At more advanced age, the joint between the sacrum and coccyx is obliterated. Movements. The movements which take place between the sacrum and coccyx and between the different pieces of the latter bone are forward and backward. They are very limited. Their extent increases during pregnancy. 4. The pubic symphysis, symphysis osseum pubis, articulation of the pubic bones. The articulation between the pubic bones is an amphiarthrodial joint formed between the two oval articular surfaces of the bones. The ligaments of this articulation are the anterior pubic, the posterior pubic, the superior pubic, the arcuate pubic, the interpubic fibrocartilaginous lamina. The anterior pubic ligament. The anterior pubic ligament consists of several superimposed layers, which pass across the front of the articulation. The superficial fibers pass obliquely from one bone to the other, decussating and forming an interlacement with the fibers of the aponeuroses of the obliqui externi and the medial tendons of origin of the recti abdominis. The deep fibers pass transversely across the symphysis and are blended with the fibrocartilaginous lamina. The posterior pubic ligament. The posterior pubic ligament consists of a few thin scattered fibers which unite the two pubic bones posteriorly. The superior pubic ligament. Ligamentum pubicum superius. The superior pubic ligament connects together the two pubic bones superiorly, extending laterally as far as the pubic tubercles. The arcuate pubic ligament. Ligamentum arcuatum pubis, inferior pubic or subpubic ligament. The arcuate pubic ligament is a thick triangular arch of ligamentous fibers connecting together the two pubic bones below and forming the upper boundary of the pubic arch. Above, it is blended with the interpubic fibrocartilaginous lamina. Laterally, it is attached to the inferior rami of the pubic bones. Below, it is free and is separated from the fascia of the urogenital diaphragm by an opening through which the deep dorsal vein of the penis passes into the pelvis. The interpubic fibrocartilaginous lamina. Lamina, fibrocartilagina, interpubica, interpubic disc. The interpubic fibrocartilaginous lamina connects the opposed surfaces of the pubic bones. Each of these surfaces is covered by a thin layer of hyaline cartilage firmly joined to the bone by a series of nipple-like processes which accurately fit into corresponding depressions on the osseous surfaces. These opposed cartilaginous surfaces are connected together by an intermediate lamina of fibrocartilage which varies in thickness in different subjects. It often contains a cavity in its interior, probably formed by the softening and absorption of the fibrocartilage, since it rarely appears before the 10th year of life and is not lined by synovial membrane. This cavity is larger in the female than in the male, but it is very doubtful whether it enlarges, as was formerly supposed, during pregnancy. It is most frequently limited to the upper and back part of the joint. It occasionally reaches to the front, and may extend the entire length of the cartilage. It may be easily demonstrated when present by making a coronal section of the symphysis pubis near its posterior surface. Mechanism of the pelvis. The pelvic girdle supports and protects the contained viscera, and affords surfaces for the attachments of the trunk and lower limb muscles. Its most important mechanical function, however, is to transmit the weight of the trunk and upper limbs to the lower extremities. It may be divided into two arches by a vertical plane passing through the acetabular cavities. The posterior of these arches is the one chiefly concerned in the function of transmitting the weight. Its essential parts are the upper three sacral vertebrae and two strong pillars of bone running from the sacroiliac articulations to the acetabular cavities. For the reception and diffusion of the weight, each acetabular cavity is strengthened by two additional bars running toward the pubis and ischium. In order to lessen concussion and rapid changes of distribution of the weight, joints, sacroiliac articulations, are interposed between the sacrum and the iliac bones. An accessory joint, pubis symphysis, exists in the middle of the anterior arch. The sacrum forms the summit of the posterior arch. The weight transmitted falls on it at the lumbosacral articulation, and theoretically has a component in each of two directions. One component of the force is expended in driving the sacrum downward and backward between the iliac bones, while the other thrusts the upper end of the sacrum downward and forward toward the pelvic cavity. The movements of the sacrum are regulated by its form. Viewed as a whole, it presents the shape of a wedge with its base upward and forward. The first component of the force is therefore acting against the resistance of the wedge, and its tendency to separate the iliac bones is resisted by the sacroiliac and iliolumbar ligaments and by the ligaments of the pubic symphysis. If a series of coronal sections of the sacroiliac joints be made, it will be found possible to divide the articular portion of the sacrum into three segments, anterior, middle, and posterior. In the anterior segment, which involves the first sacral vertebra, the articular surfaces show slight sinuosities and are almost parallel to one another. The distance between their dorsal margins is, however, slightly greater than that between their ventral margins. This segment therefore presents a slight wedge shape with the truncated apex downward. The middle segment is a narrow band across the centers of the articulations. Its dorsal width is distinctly greater than its ventral, so that the segment is more definitely wedge-shaped, the truncated apex being again directed downward. Each articular surface presents in the center a marked concavity from above downward, and into this a corresponding convexity of the iliac articular surface fits, forming an interlocking mechanism. In the posterior segment, the ventral width is greater than the dorsal, so that the wedge form is the reverse of those of the other segments, i.e., the truncated apex is directed upward. The articular surfaces are only slightly concave. Dislocation downward and forward of the sacrum by the second component of the force applied to it is prevented therefore by the middle segment, which interposes the resistance of its wedge shape and that of the interlocking mechanism on its surfaces. A rotary movement, however, is produced by which the anterior segment is tilted downward and the posterior upward. The axis of this rotation passes through the dorsal part of the middle segment. The movement of the anterior segment is slightly limited by its wedge form, but chiefly by the posterior and interosseous sacroiliac ligaments. That of the posterior segment is checked to a slight extent by its wedge form, but the chief limiting factors are the sacrotuberous and sacrospinous ligaments. In all these movements the effect of the sacroiliac and iliolumbar ligaments and the ligaments of the symphysis pubis in resisting the separation of the iliac bones must be recognized. During pregnancy the pelvic joints and ligaments are relaxed, and capable therefore of more extensive movements. When the fetus is being expelled, the force is applied to the front of the sacrum. Upward dislocation is again prevented by the interlocking mechanism of the middle segment. As the fetal head passes the anterior segment, the latter is carried upward, enlarging the antero-posterior diameter of the pelvic inlet. When the head reaches the posterior segment, this also is pressed upward against the resistance of its wedge, the movement only being possible by the laxity of the joints and the stretching of the sacrotuberous.
Section 9 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 2, by Henry Gray. Articulations of the upper extremity. Sternoclavicular Articulation. The sternoclavicular articulation is a double arthrodial joint. The parts entering into its formation are the sternal end of the clavicle, the upper and lateral part of the Manubrium sterni, and the cartilage of the first rib. The articular surface of the clavicle is much larger than that of the sternum, and is invested with a layer of cartilage, which is considerably thicker than that on the latter bone. Footnote: according to Brooke, the sternal end of the clavicle is covered by a tissue which is fibrous rather than cartilaginous in structure. End of footnote. The ligaments of this joint are the articular capsule, the anterior sternoclavicular, the posterior sternoclavicular, the interclavicular, the costoclavicular, the articular disc. The articular capsule, capsula articularis, capsular ligament. The articular capsule surrounds the articulation and varies in thickness and strength. In front and behind it is of considerable thickness, and forms the anterior and posterior sternoclavicular ligaments, but above, and especially below, it is thin, and partakes more of the character of areolar than of true fibrous tissue. The anterior sternoclavicular ligament, ligamentum sternoclaviculare anterior. The anterior sternoclavicular ligament is a broad band of fibers, covering the anterior surface of the articulation. It is attached above to the upper and front part of the sternal end of the clavicle, and passing obliquely downward and medialward, is attached below to the front of the upper part of the Manubrium sterni, the sternocleidomastoideus, and the integument behind. It is in relation with the capsule, the articular disc, and the two synovial membranes. The posterior sternoclavicular ligament, ligamentum sternoclaviculare posterius. The posterior sternoclavicular ligament is a similar band of fibers, covering the posterior surface of the articulation. It is attached above to the upper and back part of the sternal end of the clavicle, and passing obliquely downward and medialward, is fixed below to the back of the upper part of the Manubrium sterni. It is in relation, in front, with the articular disc and synovial membranes, behind, with the sternohyoideus and sternothrioideus. The interclavicular ligament, ligamentum interclaviculare. This ligament is a flattened band which varies considerably in form and size in different individuals. It passes in a curved direction from the upper part of the sternal end of one clavicle to that of the other, and is also attached to the upper margin of the sternum. It is in relation, in front, with the integument and sternocleidomastoidea behind, with the sternothrioidea. The costoclavicular ligament, ligamentum costoclaviculare, rhomboid ligament. This ligament is short, flat, strong, and rhomboid in form. Attached below to the upper and medial part of the cartilage of the first rib, it ascends obliquely downward and lateralward, and is fixed above to the costal tuberosity on the under surface of the clavicle. It is in relation, in front, with the tendon of origin of the subclavius, behind with the subclavian vein. The articular disc, discus articularis. The articular disc is flat and nearly circular, interposed between the articulating surfaces of the sternum and clavicle. It is attached above to the upper and posterior border of the articular surface of the clavicle, below to the cartilage of the first rib, near its junction with the sternum, and by its circumference to the interclavicular and anterior and posterior sternoclavicular ligaments. It is thicker at the circumference, especially its upper and back part, than at its center. It divides the joint into two cavities, each of which is furnished with a synovial membrane. Synovial membranes. Of the two synovial membranes found in this articulation, the lateral is reflected from the sternal end of the clavicle over the adjacent surface of the articular disc, and around the margin of the facet on the cartilage of the first rib. The medial is attached to the margin of the articular surface of the sternum, and close the adjacent surface of the articular disc. The latter is the larger of the two. Movements. This articulation admits of a limited amount of motion in nearly every direction, upward, downward, backward, forward, as well as circumduction. When these movements take place in the joint, the clavicle in its motion carries the scapula with it, this bone gliding on the outer surface of the chest. This joint, therefore, forms the center from which all movements of the supporting arch of the shoulder originate, and is the only point of articulation of the shoulder girdle with the trunk. The movements attendant on elevation and depression of the shoulder take place between the clavicle and the articular disc, the bone rotating upon the ligament on an axis drawn from before backward through its own articular facet. When the shoulder is moved forward and backward, The clavicle with the articular disc rolls to and fro on the articular surface of the sternum, revolving with a sliding movement around an axis drawn nearly vertically through the sternum. In the circumduction of the shoulder, which is compounded of these two movements, the clavicle revolves upon the articular disc, and the latter, with the clavicle, rolls upon the sternum. Elevation of the shoulder is limited principally by the costoclavicular ligament, depression by the interclavicular ligament and articular disc. The muscles which raise the shoulder are the upper fibers of the trapezius, the levator scapulae, and the clavicular head of the sternocleidomastoideus, assisted to a certain extent by the rhomboideae, which pull the vertebral border of the scapula backward and upward and so raise the shoulder. The depression of the shoulder is principally effected by gravity, assisted by the subclavius, pectoralis minor, and lower fibers of the trapezius. The shoulder is drawn backward by the rhomboideae and the middle and lower fibers of the
Section 10 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Ann Walden. Anatomy of the Human Body, Part 2, by Henry Gray. Acromioclavicular Articulation. Coracoacromial, superior and inferior transverse. Articulatio acromioclavicularis, scapuloclavicular articulation. The acromioclavicular articulation is an arthrodial joint between the acromial end of the clavicle and the medial margin of the acromion of the scapula. Its ligaments are the articular capsule, the superior acromioclavicular, the inferior acromioclavicular, the articular disc, the coracoclavicular, trapezoid, and conoid. The articular capsule, capsula articularis, capsular ligament. The articular capsule completely surrounds the articular margins, and is strengthened above and below by the superior and inferior acromioclavicular ligaments. The superior acromioclavicular ligament, ligamentum acromioclaviculare. This ligament is a quadrilateral band, covering the superior part of the articulation, and extending between the upper part of the acromial end of the clavicle and the adjoining part of the upper surface of the acromion. It is composed of parallel fibers which interlace with the aponeuroses of the trapezius and deltoideus. Below it is in contact with the articular disc when this is present. The inferior acromioclavicular ligament. This ligament is somewhat thinner than the preceding. It covers the under part of the articulation, and is attached to the adjoining surfaces of the two bones. It is in relation, above, in rare cases, with the articular disc; below, with the tendon of the supraspinatus. The articular disc, discus articularis. The articular disc is frequently absent in this articulation. When present, it generally only partially separates the articular surfaces, and occupies the upper part of the articulation. More rarely, it completely divides the joint into two cavities. The synovial membrane. There is usually only one synovial membrane in this articulation, but when a complete articular disc is present, there are two. The coracoclavicular ligament, ligamentum coracoclaviculare. This ligament serves to connect the clavicle with the coracoid process of the scapula. It does not properly belong to this articulation, but is usually described with it, since it forms a most efficient means of retaining the clavicle in contact with the acromion. It consists of two fasciculi, called the trapezoid and conoid ligaments. The trapezoid ligament, ligamentum trapezoideum, the anterior and lateral fasciculus, is broad, thin, and quadrilateral. It is placed obliquely between the coracoid process and the clavicle. It is attached below to the upper surface of the coracoid process, above to the oblique ridge on the under surface of the clavicle. Its anterior border is free. Its posterior border is joined with the conoid ligament, the two forming, by their junction, an angle projecting backward. The conoid ligament, ligamentum conoideum, the posterior and medial fasciculus, is a dense band of fibers, conical in form, with its base directed upward. It is attached by its apex to a rough impression at the base of the coracoid process, medial to the trapezoid ligament; above, by its expanded base, to the coracoid tuberosity on the under surface of the clavicle, and to a line proceeding medialward from it for 1.25 centimeters. These ligaments are in relation, in front, with the subclavius and deltoideus, behind with the trapezius. Movements. The movements of this articulation are of two kinds. 1. A gliding motion of the articular end of the clavicle on the acromion. 2. Rotation of the scapula forward and backward upon the clavicle. The extent of this rotation is limited by the two portions of the coracoclavicular ligament, the trapezoid limiting rotation forward, and the conoid backward. The acromioclavicular joint has important functions in the movements of the upper extremity. It has been well pointed out by Humphrey that if there had been no joint between the clavicle and scapula, the circular movement of the scapula on the ribs, as in throwing the shoulders backward or forward, would have been attended with a greater alteration in the direction of the shoulder than is consistent with the free use of the arm in such positions, and it would have been impossible to give a blow straight forward with the full force of the arm, that is to say, with the combined force of the scapula, arm, and forearm. This joint, as he happily says, is so adjusted as to enable either bone to turn in a hinge-like manner upon a vertical axis drawn through the other, and it permits the surfaces of the scapula, like the baskets in a roundabout swing, to look the same way in every position, or nearly so. Again, when the whole arch formed by the clavicle and scapula rises and falls, in elevation or depression of the shoulder, the joint between these two bones enables the scapula still to maintain its lower part in contact with the ribs. The ligaments of the scapula. The ligaments of the scapula are: the coracoacromial ligament, ligamentum coracoacromiale. This ligament is a strong triangular band extending between the coracoid process and the acromion. It is attached, by its apex, to the summit of the acromion just in front of the articular surface for the clavicle, and by its broad base to the whole length of the lateral border of the coracoid process. This ligament, together with the coracoid process and the acromion, forms a vault for the protection of the head of the humerus. It is in relation above with the clavicle and under surface of the deltoideus, below with the tendon of the supraspinatus, a bursa being interposed. Its lateral border is continuous with a dense lamina that passes beneath the deltoideus upon the tendons of the supraspinatus and infraspinatus. The ligament is sometimes described as consisting of two marginal bands and a thinner intervening portion, the two bands being attached respectively to the apex and the base of the coracoid process, and joining together at the acromion. When the pectoralis minor is inserted, as occasionally is the case, into the capsule of the shoulder joint, instead of into the coracoid process, it passes between these two bands, and the intervening portion of the ligament is then deficient. The superior transverse ligament, ligamentum transversum scapulae superius, transverse or suprascapular ligament. This ligament converts the scapular notch into a foramen. It is a thin and flat fasciculus, narrower at the middle than at the extremities, attached by one end to the base of the coracoid process, and by the other to the medial end of the scapular notch. The suprascapular nerve runs through the foramen. The transverse scapular vessels cross over the ligament. The ligament is sometimes ossified. The inferior transverse ligament, ligamentum transversum scapulae inferius, spinoglenoid ligament. This ligament is a weak membranous band situated behind the neck of the scapula, and stretching from the lateral border of the spine to the margin of the glenoid cavity. It forms an arch under which the
Section 11 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 2, by Henry Gray. Section 11. Humeral Articulation, or Shoulder Joint. Articulatio Humeri. The shoulder joint is an enarthrodial or ball-and-socket joint. The bones entering into its formation are the hemispherical head of the humerus and the shallow glenoid cavity of the scapula, an arrangement which permits a very considerable movement, while the joint itself is protected against displacement by the tendons which surround it. The ligaments do not maintain the joint surfaces in apposition, because when they alone remain, the humerus can be separated to a considerable extent from the glenoid cavity. Their use, therefore, is to limit the amount of movement. The joint is protected above by an arch, formed by the coracoid process, the acromion, and the coracoacromial ligament. The articular cartilage on the head of the humerus is thicker at the center than at the circumference, the reverse being the case with the articular cartilage of the glenoid cavity. The ligaments of the shoulder are the articular capsule, the coracohumeral, the glenohumeral, the transverse humeral, the glenoidal labrum. Footnote: the long tendon of origin of the biceps brachii also acts as one of the ligaments of this joint. See the observations on page 287 on the function of the muscles passing over more than one joint. End of footnote. The articular capsule, capsula articularis, capsular ligament. The articular capsule completely encircles the joint, being attached above to the circumference of the glenoid cavity beyond the glenoid labrum, below to the anatomical neck of the humerus, approaching nearer to the articular cartilage above than in the rest of its extent. It is thicker above and below than elsewhere, and is so remarkably loose and lax that it has no action in keeping the bones in contact, but allows them to be separated from each other more than 2.5 centimeters, an evident provision for that extreme freedom of movement which is peculiar to this articulation. It is strengthened above by the supraspinatus, below by the long head of the triceps brachii, behind by the tendons of the infraspinatus and teres minor, and in front by the tendon of the subscapularis. There are usually 3 openings in the capsule. One anteriorly, below the coracoid process, establishes a communication between the joint and a bursa beneath the tendon of the subscapularis. The second, which is not constant, is at the posterior part, where an opening sometimes exists between the joint and a bursal sac under the tendon of the infraspinatus. The third is between the tubercles of the humerus, for the passage of the long tendon of the biceps brachii. The coracohumeral ligament, ligamentum coracohumerale. This ligament is a broad band which strengthens the upper part of the capsule. It arises from the lateral border of the coracoid process and passes obliquely downward and lateralward to the front of the greater tubercle of the humerus, blending with the tendon of the supraspinatus. This ligament is intimately united to the capsule by its hinder and lower border, but its anterior and upper border presents a free edge which overlaps the capsule. Glenohumeral ligaments. In addition to the coracohumeral ligament, 3 supplemental bands, which are named the glenohumeral ligaments, strengthen the capsule. These may be best seen by opening the capsule at the back of the joint and removing the head of the humerus. One on the medial side of the joint passes from the medial edge of the glenoid cavity to the lower part of the lesser tubercle of the humerus. A second at the lower part of the joint extends from the under edge of the glenoid cavity to the under part of the anatomical neck of the humerus. A third at the upper part of the joint is fixed above to the apex of the glenoid cavity, close to the root of the coracoid process, and passing downward along the medial edge of the tendon of the biceps brachii, is attached below to a small depression above the lesser tubercle of the humerus. In addition to these, the capsule is strengthened in front by 2 bands derived from the tendons of the pectoralis major and the teres major, respectively. The transverse humeral ligament is a broad band passing from the lesser to the greater tubercle of the humerus, and always limited to that portion of the bone which lies above the epiphyseal line. It converts the intertubercular groove into a canal, and is the homologue of the strong process of bone which connects the summits of the 2 tubercles in the musk ox. The glenoidal labrum, Labrium glenoidale, glenoid ligament, is a fibrocartilaginous rim attached around the margin of the glenoid cavity. It is triangular on section, the base being fixed to the circumference of the cavity, while the free edge is thin and sharp. It is continuous above with the tendon of the long head of the biceps brachii, which gives off 2 fasciculi to blend with the fibrous tissue of the labrum. It deepens the articular cavity and protects the edges of the bone. Synovial membrane. The synovial membrane is reflected from the margin of the glenoid cavity over the labrum. It is then reflected over the inner surface of the capsule and covers the lower part and sides of the anatomical neck of the humerus as far as the articular cartilage on the head of the bone. The tendon of the long head of the biceps brachii passes through the capsule and is enclosed in a tubular sheath of synovial membrane, which is reflected upon it from the summit of the glenoid cavity and is continued around the tendon into the intertubercular groove, as far as the surgical neck of the humerus. The tendon thus traverses the articulation, but is not contained within the synovial cavity. Bursae. The bursae in the neighborhood of the shoulder joint are the following. 1. A constant bursa is situated between the tendon of the subscapularis muscle and the capsule. It communicates with the synovial cavity through an opening in the front of the capsule. 2. A bursa which occasionally communicates with the joint is sometimes found between the tendon of the infraspinatus and the capsule. 3. A large bursa exists between the under surface of the deltoideus and the capsule, but does not communicate with the joint. This bursa is prolonged under the acromion and the coracoacromial ligament, and intervenes between these structures and the capsule. 4. A large bursa is situated on the summit of the acromion. 5. A bursa is frequently found between the coracoid process and the capsule. 6. A bursa exists beneath the coracobrachialis. 7. One lies between the teres major and the long head of the triceps brachii. 8. One is placed in front of, and another behind, the tendon of the latissimus dorsi. The muscles in relation with the joint are above the supraspinatus, below the long head of the triceps brachii, in front the subscapularis, behind the infraspinatus and teres minor, within the tendon of the long head of the biceps brachii. The deltoideus covers the articulation in front, behind, and laterally. The arteries supplying the joint are articular branches of the anterior and posterior humeral circumflex and transverse scapular. The nerves are derived from the axillary and suprascapular. Movements. The shoulder joint is capable of every variety of movement: flexion, extension, abduction, adduction, circumduction, and rotation. The humerus is flexed, drawn forward, by the pectoralis major, anterior fibers of the deltoideus, coracobrachialis, and when the forearm is flexed, by the biceps brachii. Extended, drawn backward, by the latissimus dorsi, teres major, posterior fibers of the deltoideus, and, when the forearm is extended, by the triceps brachii. It is abducted by the deltoideus and supraspinatus. It is adducted by the subscapularis, pectoralis major, latissimus dorsi, and teres major, and by the weight of the limb. It is rotated outward by the infraspinatus and teres minor, and it is rotated inward by the subscapularis, latissimus dorsi, teres major, pectoralis major, and the anterior fibers of the deltoideus. The most striking peculiarities in this joint are: 1. The large size of the head of the humerus in comparison with the depth of the glenoid cavity, even when this latter is supplemented by the glenoid labrum. 2. The looseness of the capsule of the joint. 3. The intimate connection of the capsule with the muscles attached to the head of the humerus. 4. The peculiar relation of the tendon of the long head of the biceps brachii to the joint. It is in consequence of the relative sizes of the two articular surfaces and the looseness of the articular capsule that the joint enjoys such free movement in all directions. When these movements of the arm are arrested in the shoulder joint by the contact of the bony surfaces and by the tension of the fibers of the capsule, together with that of the muscles acting as accessory ligaments, the arm can be carried considerably farther by the movements of the scapula, involving, of course, motion of the acromio and sternoclavicular joints. These joints are therefore to be regarded as accessory structures to the shoulder joint. The extent of the scapular movements is very considerable, especially in extreme elevation of the arm, a movement best accomplished when the arm is thrown somewhat forward and outward, because the margin of the head of the humerus is by no means a true circle. Its greatest diameter is from the intertubercular groove, downward, medialward, and backward, and the greatest elevation of the arm can be obtained by rolling its articular surface in the direction of this measurement. The great width of the central portion of the humeral head also allows a very free horizontal movement when the arm is raised to a right angle, in which movement the arch formed by the acromion, the coracoid process, and the coracoacromial ligament constitutes a sort of supplemental articular cavity for the head of the bone. The looseness of the capsule is so great that the arm will fall about 2.5 centimeters from the scapula when the muscles are dissected from the capsule, and an opening made in it to counteract the atmospheric pressure. The movements of the joint, therefore, are not regulated by the capsule so much as by the surrounding muscles and by the pressure of the atmosphere, an arrangement which renders the movements of the joint much more easy than they would otherwise have been, and permits a swinging, pendulum-like vibration of the limb when the muscles are at rest. Humphrey. The fact also that in all ordinary positions of the joint the capsule is not put on the stretch enables the arm to move freely in all directions. Extreme movements are checked by the tension of appropriate portions of the capsule, as well as by the interlocking of the bones. Thus it is said that abduction is checked by the contact of the great tuberosity with the upper edge of the glenoid cavity, by the tension of the coracohumeral ligament. Bonny et Bouchard. Cleland maintains that the limitations of movement at the shoulder joint are due to the structure of the joint itself, the glenoidal labrum fitting in different positions of the elevated arm into the anatomical neck of the humerus. The scapula is capable of being moved upward and downward, forward and backward, or by a combination of these movements circumducted on the wall of the chest. The muscles which raise the scapula are the upper fibers of the trapezius, the levator scapulae, and the rhomboidii. Those which depress it are the lower fibers of the trapezius, the pectoralis minor, and through the clavicle, the subclavius. The scapula is drawn backward by the rhomboidii and the middle and lower fibers of the trapezius, and forward by the serratus anterior and pectoralis minor, assisted, when the arm is fixed, by the pectoralis major. The mobility of the scapula is very considerable, and greatly assists the movements of the arm at the shoulder joint. Thus, in raising the arm from the side, the deltoideus and supraspinatus can only lift it to a right angle with the trunk, the further elevation of the limb being effected by the trapezius and the serratus anterior moving the scapula on the wall of the chest. This mobility is of special importance in ankylosis of the shoulder joint, the movements of this bone compensating to a very great extent for the immobility of the joint. Cathcart has pointed out that in abducting the arm and raising it above the head, the scapula rotates through the whole movement with the exception of a short space at the beginning and at the end, that the humerus moves on the scapula not only while passing from the hanging to the horizontal position, but also in traveling upward as it approaches the vertical above, that the clavicle moves not only during the second half of the movement, but in the first as well, though to a less extent. That is, the scapula and clavicle are concerned in the first stage as well as in the second, and that the humerus is partly involved in the second as well as chiefly in the first. The intimate union of the tendons of the supraspinatus, infraspinatus, teres minor, and subscapularis with the capsule converts these muscles into elastic and spontaneously acting ligaments of the joint. The peculiar relations of the tendon of the long head of the biceps brachii to the shoulder joint appear to subserve various purposes. In the first place, by its connection with both the shoulder and elbow, the muscle harmonizes the action of the two joints, and acts as an elastic ligament in all positions, in the manner previously discussed. It strengthens the upper part of the articular cavity and prevents the head of the humerus from being pressed up against the acromion. When the deltoideus contracts, it thus fixes the head of the humerus as the center of motion in the glenoid cavity. By its passage along the intertubercular groove, it assists in steadying the head of the humerus in the various movements of the arm. When the arm is raised from the side, it assists the supraspinatus and infraspinatus in rotating the head of the humerus in the glenoid cavity. It also holds the head of the bone firmly in contact with the glenoid cavity, and prevents its slipping over its lower edge, or being displaced by the action of the Section 12 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 2, by Henry Gray. Section 12. Elbow Joint. Articulatio cubiti. The elbow joint is a ginglymus or hinge joint. The trochlea of the humerus is received into the semi-lunar notch of the ulna, and the capitulum of the humerus articulates with the fovea on the head of the radius. The articular surfaces are connected together by a capsule, which is thickened medially and laterally, and, to a less extent, in front and behind. These thickened portions are usually described as distinct ligaments under the following names: the anterior, the posterior, the ulnar collateral, the radiocollateral. The anterior ligament. The anterior ligament is a broad and thin fibrous layer covering the anterior surface of the joint. It is attached to the front of the medial epicondyle and to the front of the humerus immediately above the coronoid and radial fossae below, to the anterior surface of the coronoid process of the ulna, and to the annular ligament, being continuous on either side with the collateral ligaments. Its superficial fibers pass obliquely from the medial epicondyle of the humerus to the annular ligament. The middle fibers, vertical in direction, pass from the upper part of the coronoid depression and become partly blended with the preceding, but are inserted mainly into the anterior surface of the coronoid process. The deep or transverse set intersects these at right angles. This ligament is in relation, in front, with the brachialis, except at its most lateral part. The posterior ligament. This posterior ligament is thin and membranous, and consists of transverse and oblique fibers. Above it is attached to the humerus immediately behind the capitulum, and close to the medial margin of the trochlea, to the margins of the olecranon fossa, and to the back of the lateral epicondyle, some little distance from the trochlea. Below it is fixed to the upper and lateral margins of the olecranon, to the posterior part of the annular ligament, and to the ulna behind the radial notch. The transverse fibers form a strong band which bridges across the olecranon fossa. Under cover of this band, a pouch of synovial membrane and a pad of fat project into the upper part of the fossa when the joint is extended. In the fat are a few scattered fibrous bundles, which pass from the deep surface of the transverse band to the upper part of the fossa. This ligament is in relation, behind, with the tendon of the triceps brachii and the anconeus. The ulnar collateral ligament, ligamentum collaterale ulnare, internal lateral ligament. This ligament is a thick triangular band consisting of two portions, an anterior and posterior, united by a thinner intermediate portion. The anterior portion, directed obliquely forward, is attached above by its apex to the front part of the medial epicondyle of the humerus, and below by its broad base to the medial margin of the coronoid process. The posterior portion, also of triangular form, is attached above by its apex to the lower and back part of the medial epicondyle, below to the medial margin of the olecranon. Between these two bands a few intermediate fibers descend from the medial epicondyle to blend with a transverse band which bridges across the notch between the olecranon and the coronoid process. This ligament is in relation with the triceps brachii and flexor carpi ulnaris and the ulnar nerve, and gives origin to part of the flexor digitorum sublimis. The radial collateral ligament, ligamentum collaterale radiale, external lateral ligament. This ligament is a short and narrow fibrous band, less distinct than the ulnar collateral, attached above to a depression below the lateral epicondyle of the humerus, below to the annular ligament, some of its most posterior fibers passing over that ligament to be inserted into the lateral margin of the ulna. It is intimately blended with the tendon of origin of the supinator. Synovial membrane. The synovial membrane is very extensive. It extends from the margin of the articular surface of the humerus and lines the coronoid, radial, and olecranal fossae on that bone. It is reflected over the deep surface of the capsule and forms a pouch between the radial notch, the deep surface of the annular ligament, and the circumference of the head of the radius. Projecting between the radius and ulna into the cavity is a crescentic fold of synovial membrane, suggesting the division of the joint into two, one of the humero-radial, the other the humeral-ulnar. Between the capsule and the synovial membrane are three masses of fat. The largest, over the olecranon fossa, is pressed into the fossa by the triceps brachii during the flexion, the second, over the coronoid fossa, and the third, over the radial fossa, are pressed by the brachialis into their respective fossae during extension. The muscles in relation with the joint are, in front, the brachialis, behind the triceps brachii and anconeus, laterally the supinator and the common tendon of origin of the extensor muscles, medially the common tendon of origin of the flexor muscles and the flexor carpi ulnaris. The arteries supplying the joint are derived from the anastomosis between the profunda and superior and inferior ulnar collateral branches of the brachial, with the anterior, posterior, and interosseosis recurrent branches of the ulnar and the recurrent branch of the radial. These vessels form a complete anastomotic network around the joint. The nerves of the joint are a twig from the ulnar as it passes between the medial condyle and olecranon, a filament from the musculocutaneous, and two from the median. Movements. The elbow joint comprises three different portions, namely, the joint between the ulna and humerus, that between the head of the radius and the humerus, and the proximal radioulnar articulation described below. All these articular surfaces are enveloped by a common synovial membrane, and the movements of the whole joint should be studied together. The combination of the movements of flexion and extension of the forearm with those of pronation and supination of the hand, which is ensured by the two being performed at the same joint, is essential to the accuracy of the various minute movements of the hand. The portion of the joint between the ulna and the humerus is a simple hinge joint and allows of movements of flexion and extension only. Owing to the obliquity of the trochlea of the humerus, this movement does not take place in the antero-posterior plane of the body of the humerus. When the forearm is extended and supinated, the axes of the arm and forearm are not in the same line. The arm forms an obtuse angle with the forearm, the hand and forearm being directed lateralward. During flexion, however, the forearm and the hand tend to approach the middle line of the body, and thus enable the hand to be easily carried to the face. The accurate adaptation of the trochlea of the humerus, with its prominences and depressions, to the semi-lunar notch of the ulna prevents any lateral movement. Flexion is produced by the action of the biceps brachii and brachialis, assisted by the brachioradialis and the muscles arising from the medial condyle of the humerus. Extension by the triceps brachii and anconeus, assisted by the extensors of the wrist, the extensor digitorum communis, and the extensor digiti quinti proprius. The joint between the head of the radius and the capitulum of the humerus is an arthrodial joint. The bony surfaces would of themselves constitute an inarthrosis and allow of movement in all directions, were it not for the annular ligament, by which the head of the radius is bound to the radial notch of the ulna, and which prevents any separation of the two bones laterally. It is to the same ligament that the head of the radius owes its security from dislocation, which would otherwise tend to occur, from the shallowness of the cup-like surface on the head of the radius. In fact, but for this ligament, the tendon of the biceps brachii would be liable to pull the head of the radius out of the joint. The head of the radius is not in complete contact with the capitulum of the humerus in all positions of the joint. The capitulum occupies only the anterior and inferior surfaces of the lower end of the humerus, so that in complete extension a part of the radial head can be plainly felt projecting at the back of the articulation. In full flexion, the movement of the radial head is hampered by the compression of the surrounding soft parts, so that the freest rotary movement of the radius on the humerus, pronation and supination, takes place in semiflexion, in which position the two articular surfaces are in most intimate contact. Flexion and extension of the elbow joint are limited by the tension of the structures on the front and back of the joint. The limitation of flexion is also aided by the soft structures of the arm and forearm coming into contact. In any position of flexion or extension, the radius, carrying the hand with it, can be rotated in the proximal radioulnar joint. The hand is directly articulated to the lower surface of the radius only, and the ulnar notch on the lower end of the radius travels around the lower end of the ulna. The latter bone is excluded from the wrist joint by the articular disc. Thus, rotation of the head of the radius around an axis passing through the center of the radial head of the
Section 13 of The Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 2, by Henry Gray. Radioulnar Articulation. Articulatio radioulnaris. The articulation of the radius with the ulna is affected by ligaments which connect together the extremities as well as the bodies of these bones. The ligaments may consequently be subdivided into three sets. 1. Those of the proximal radioulnar articulation. 2. The middle radioulnar ligaments. 3. Those of the distal radioulnar articulation. Proximal radioulnar articulation. Articulatio radioulnaris proximalis. Superior radioulnar joint. This articulation is a trochoid or pivot joint between the circumference of the head of the radius and the ring formed by the radial notch of the ulna and the annular ligament. The annular ligament, ligamentum annulare radii. Orbicular ligament. This ligament is a strong band of fibers which encircles the head of the radius and retains it in contact with the radial notch of the ulna. It forms about 4/5 of the osteofibrous ring and is attached to the anterior and posterior margins of the radial notch. A few of its lower fibers are continued around below the cavity and form at this level a complete fibrous ring. Its upper border blends with the anterior and posterior ligaments of the elbow, while from its lower border a thin loose membrane passes to be attached to the neck of the radius, a thickened band which extends from the inferior border of the annular ligament below the radial notch to the neck of the radius is known as the quadrate ligament. The superficial surface of the annular ligament is strengthened by the radial collateral ligament of the elbow and affords origin to part of the supinator. Its deep surface is smooth and lined by a synovial membrane which is continuous with that of the elbow joint. Movements. The movements allowed in this articulation are limited to rotatory movements of the head of the radius within the ring formed by the annular ligament and the radial notch of the ulna. Rotation forward being called pronation, rotation backward supination. Supination is performed by the biceps brachii and supinator, assisted to a slight extent by the extensor muscles of the thumb. Pronation is performed by the pronator teres and pronator quadratus. Middle radioulnar union. The shafts of the radius and ulna are connected by the oblique cord and the interosseous membrane. The oblique cord, chorda obliqua, oblique ligament. The oblique cord is a small flattened band extending downward and lateralward from the lateral surface of the tubercle of the ulna at the base of the coronoid process to the radius a little below the radial tuberosity. Its fibers run in the opposite direction to those of the interosseous membrane. It is sometimes wanting. The interosseous membrane, membrana interossea antebrachii. The interosseous membrane is a broad and thin plane of fibrous tissue descending obliquely downward and medialward from the interosseous crest of the radius to that of the ulna. The lower part of the membrane is attached to the posterior of the two lines into which the interosseous crest of the radius divides. It is deficient above, commencing about 2.5 centimeters beneath the tuberosity of the radius, is broader in the middle than at either end, and presents an oval aperture a little above its lower margin for the passage of the volar interosseous vessels to the back of the forearm. This membrane serves to connect the bones and to increase the extent of surface for the attachment of the deep muscles. Between its upper border and the oblique cord is a gap through which the dorsal interosseous vessels pass. 2 or 3 fibrous bands are occasionally found on the dorsal surface of this membrane. They descend obliquely from the ulna towards the radius and have consequently a direction contrary to that of the other fibers. The membrane is in relation in front by its upper 3/4 with the flexor pollicis longus on the radial side and with the flexor digitorum profundus on the ulnar, lying in the interval between which are the volar interosseous vessels and nerve, by its lower fourth with the pronator quadratus behind, with the supinator, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, extensor indicis proprius, and near the wrist with the volar interosseous artery and dorsal interosseous nerve. Distal radioulnar articulation. Articulatio radioulnaris distalis. Inferior radioulnar joint. This is a pivot joint formed between the head of the ulna and the ulnar notch on the lower end of the radius. The articular surfaces are connected together by the following ligaments: the volar radioulnar, the dorsal radioulnar, the articular disc. The volar radioulnar ligament, anterior radioulnar ligament. This ligament is a narrow band of fibers extending from the anterior margin of the ulnar notch of the radius to the front of the head of the ulna. The dorsal radioulnar ligament, posterior radioulnar ligament. This ligament extends between corresponding surfaces on the dorsal aspect of the articulation. The articular disc, discus articularis, triangular fibrocartilage. The articular disc is triangular in shape and is placed transversely beneath the head of the ulna, binding the lower ends of the ulna and radius firmly together. Its periphery is thicker than its center, which is occasionally perforated. It is attached by its apex to a depression between the styloid process and the head of the ulna, and by its base, which is thin, to the prominent edge of the radius, which separates the ulnar notch from the carpal articular surface. Its margins are united to the ligaments of the wrist joint. Its upper surface, smooth and concave, articulates with the head of the ulna, forming an arthroidal joint. Its undersurface, also concave and smooth, forms part of the wrist joint and articulates with the triangular bone and medial part of the lunate. Both surfaces are clothed by synovial membrane, the upper by that of the distal radioulnar articulation, the under by that of the wrist. Synovial membrane. The synovial membrane of this articulation is extremely loose and extends upward as a recess, recessus sacciformis, between the radius and the ulna. Movements. The movements in the distal radioulnar articulation consist of rotation of the lower end of the radius around an axis which passes through the center of the head of the ulna. When the radius rotates forward, pronation of the forearm and hand is the result, and when backward, supination. It will thus be seen that in pronation and supination the radius describes the segment of a cone, the axis of which extends from the center of the head of the radius to the middle of the head of the ulna. In this movement, the head of the ulna is not stationary but describes a curve in a direction opposite to that taken by the head of the radius. This, however, is not to be regarded as a rotation of the ulna. The curve which the head of this bone describes is due to a combined antero-posterior and rotatory movement, the former taking place almost entirely at the elbow joint, the latter at the shoulder joint. Radiocarpal articulation or wrist joint. Articulatio radiocarpi. The wrist joint is a condyloid articulation. The parts forming it are the lower end of the radius and undersurface of the articular disc above, and the navicular, lunate, and triangular bones below. The articular surface of the radius and the undersurface of the articular disc form together a transversely elliptical concave surface, the receiving cavity. The superior articular surfaces of the navicular, lunate, and triangular form a smooth convex surface, the condyle, which is received into the concavity. The joint is surrounded by a capsule strengthened by the following ligaments: the volar radiocarpal, the dorsal radiocarpal, the ulnar collateral, the radial collateral. The volar radiocarpal ligament. Ligamentum radiocarpium volare. Anterior ligament. This ligament is a broad membranous band attached above to the anterior margin of the lower end of the radius, to its styloid process, and to the front of the lower end of the ulna. Its fibers pass downward and medialward to be inserted into the volar surfaces of the navicular, lunate, and triangular bones, some being continued to the capitate. In addition to this broad membrane, there is a rounded fasciculus, superficial to the rest, which reaches from the base of the styloid process of the ulna to the lunate and triangular bones. The ligament is perforated by apertures for the passage of vessels and is in relation in front with the tendons of the flexor digitorum profundus and flexor pollicis longus. Behind, it is closely adherent to the anterior border of the articular disc of the distal radioulnar articulation. The dorsal radiocarpal ligament. Ligamentum radiocarpium dorsale. Posterior ligament. The dorsal radiocarpal ligament, less thick and strong than the volar, is attached above to the posterior border of the lower end of the radius. Its fibers are directed obliquely downward and medialward and are fixed below to the dorsal surfaces of the navicular, lunate, and triangular, being continuous with those of the dorsal intercarpal ligaments. It is in relation behind with the extensor tendons of the fingers. In front, it is blended with the articular disc. The ulnar collateral ligament, Ligamentum collaterale carpi ulnar. Internal lateral ligament. The ulnar collateral ligament is a rounded cord attached above to the end of the styloid process of the ulna and dividing below into two fasciculi, one of which is attached to the medial side of the triangular bone, the other to the pisiform and transverse carpal ligament. The radial collateral ligament, Ligamentum collaterale carpi radiale. External lateral ligament. The radial collateral ligament extends from the tip of the styloid process of the radius to the radial side of the navicular, some of its fibers being prolonged to the greater multangular bone and the transverse carpal ligament. It is in relation with the radial artery, which separates the ligament from the tendons of the abductor pollicis longus and extensor pollicis brevis. Synovial membrane. The synovial membrane lines the deep surfaces of the ligaments above described, extending from the margin of the lower end of the radius and articular disc above to the margins of the articular surfaces of the carpal bones below. It is loose and lax and presents numerous folds, especially behind. The wrist joint is covered in front by the flexor and behind by the extensor tendons. The arteries supplying the joint are the volar and dorsal carpal branches of the radial and ulnar, the volar and dorsal metacarpals, and some ascending branches from the deep volar arch. The nerves are derived from the ulnar and dorsal interosseous. Movements. The movements permitted in this joint are flexion, extension, abduction, adduction, and circumduction. They will be studied with those of the carpus with which they are combined.
Section 14 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 2, by Henry Gray. Intercarpal Articulations. Articulations intercarpi. Articulations of the carpus. These articulations may be subdivided into three sets. Number 1. The articulations of the proximal row of carpal bones. Number 2. The articulations of the distal row of carpal bones. Number 3. The articulations of the two rows with each other. Articulations of the proximal row of carpal bones. These are arthroidal joints. The navicular, lunate, and triangular are connected by dorsal, volar, and interosseous ligaments. The dorsal ligaments, ligamenta intercarpae dorsalia. The dorsal ligaments, 2 in number, are placed transversely behind the bones of the first row. They connect the navicular and lunate and the lunate and triangular. The volar ligaments, ligamenta intercarpae volaria. Palmar ligaments. The volar ligaments also too connect the navicular and lunate and the lunate and triangular. They are less strong than the dorsal and placed very deeply behind the flexor tendons and the volar radiocarpal ligament. The interosseous ligaments, ligamenta intercarpae interossea. The interosseous ligaments are 2 narrow bundles, one connecting the lunate with the navicular, the other joining it to the triangular. They are on a level with the superior surfaces of these bones, and their upper surfaces are smooth and form part of the convex articular surface of the wrist joint. The ligaments connecting the pisiform bone are the articular capsule and the 2 volar ligaments. The articular capsule is a thin membrane which connects the pisiform to the triangular. It is lined by synovial membrane. The 2 volar ligaments are strong fibrous bands. One, the pisohamate ligament, connects the pisiform to the hamate. The other, the pisometacarpal ligament, joins the pisiform to the base of the 5th metacarpal bone. These ligaments are, in reality, prolongations of the tendon of the flexor carpi ulnaris. Articulations of the distal row of carpal bones. These also are arthroidal joints. The bones are connected by dorsal, volar, and interosseous ligaments. The dorsal ligaments, ligamenta intercarpae dorsalia. The dorsal ligaments, 3 in number, extend transversely from one bone to other on the dorsal surface, connecting the greater with the lesser multangular with the capitate, and the capitate with the hamate. The volar ligaments, ligamenta intercarpae volaria. Palmar ligaments. The volar ligaments, also 3, have a similar arrangement on the volar surface. The interosseous ligaments, ligamenta intercarpae interossea. The 3 interosseous ligaments are much thicker than those of the first row. One is placed between the capitate and the hamate, a second between the capitate and the lesser multangular, and a third between the greater and lesser multangulars. The first is much the strongest, and the third is sometimes wanting. Articulations of the 2 rows of carpal bones with each other. The joint between the navicular, lunate, and triangular on the one hand and the second row of carpal bones on the other is named the mid-carpal joint and is made up of 3 distinct portions. In the center, the head of the capitate and the superior surface of the hamate articulate with the deep cup-shaped cavity formed by the navicular and lunate, and constitute a sort of ball and socket joint. On the radial side, the greater and lesser multangulars articulate with the navicular, and on the ulnar side, the hamate articulates with the triangular, forming gliding joints. The ligaments are volar, dorsal, ulnar, and radial collateral. The volar ligaments. Ligamenta intercarpi volaria. Anterior or palmar ligaments. The volar ligaments consist of short fibers which pass, for the most part, from the volar surfaces of the bones of the first row to the front of the capitate. The dorsal ligaments. Ligamenta intercarpi dorsalia. Posterior ligaments. The dorsal ligaments consist of short, irregular bundles passing between the dorsal surfaces of the bones of the first and second rows. The collateral ligaments. Lateral ligaments. The collateral ligaments are very short. One is placed on the radial, the other on the ulnar side of the carpus. The former, the stronger and more distinct, connects the navicular and greater multangular. The later, the triangular and hamate, they are continuous with the collateral ligaments of the wrist joint. In addition to these ligaments, a slender interosseous band sometimes connects the capitate and the navicular. Synovial membrane. The synovial membrane of the carpus is very extensive and bounds a synovial cavity of very irregular shape. The upper portion of the cavity intervenes between the undersurfaces of the navicular, lunate, and triangular bones and the upper surfaces of the bones of the second row. It sends two prolongations upward between the navicular and lunate and the lunate and triangular, and three prolongations downward between the four bones of the second row. The prolongation between the greater and lesser multangulars, or that between the lesser multangular and capitate, is, owing to the absence of the interosseous ligament, often continuous with the cavity of the carpometacarpal joints, sometimes of the second, third, fourth, and fifth metacarpal bones, sometimes of the second and third only. In the later condition, the joint between the hamate and the fourth and fifth metacarpal bones has a separate synovial membrane. The synovial cavities of these joints are prolonged for a short distance between the bases of the metacarpal bones. There is a separate synovial membrane between the pisiform and triangular. Movements. The articulation of the hand and wrist considered as a whole involves four articular surfaces. A. The inferior surfaces of the radius and the articular disc. B. The superior surfaces of the navicular, lunate, and triangular, the pisiform having no essential part in the movement of the hand. C. The S-shaped surface formed by the interior surfaces of the navicular, lunate, and triangular. D. The reciprocal surface formed by the upper surfaces of the bones of the second row. These four surfaces form two joints. 1. A proximal, the wrist joint proper, and 2. A distal, the mid-carpal joint. 1. The wrist joint proper is a true condyloid articulation, and therefore all movements but rotation are permitted. Flexion and extension are the most free. and of these a greater amount of extension than of flexion is permitted, since the articulating surfaces extend farther on the dorsal than on the volar surfaces of the carpal bones. In this movement, the carpal bones rotate on a transverse axis drawn between the tips of the styloid processes of the radius and ulna. A certain amount of adduction or ulnar flexion and abduction or radial flexion is also permitted. The former is considerably greater in extent than the latter on account of the shortness of the styloid process of the ulna, abduction being soon limited by the contact of the styloid process of the radius with the greater multangular. In this movement, the carpus revolves upon an antero-posterior axis drawn through the center of the wrist. Footnote: H. M. Johnston, Journal of Anatomy and Physiology, Volume 41, maintains that ulnar and radial flexion, only slight lateral movement occurs at the radiocarpal joint, and that in complete flexion and extension of the hand there is a small degree of ulnar flexion at the radiocarpal joint. End footnote. Finally, circumduction is permitted by the combined and consecutive movements of adduction, extension, abduction, and flexion. No rotation is possible, but the effect of rotation is obtained by the pronation and supination of the radius on the ulna. The movement of flexion is performed by the flexor carpi radialis, the flexor carpi ulnaris, and the palmaris longus. Extension by the extensors carpi radialis longus and brevis and the extensor carpi ulnaris. Adduction, ulnar flexion by the flexor carpi ulnaris and the extensor carpi ulnaris. Abduction, radial flexion by the abductor pollicis longus, the extensors of the thumb, and the extensors carpi radialis longus and brevis, and the flexor carpi radialis. When the fingers are extended, flexion of the wrist is performed by the flexor carpi radialis and ulnaris, and extension is aided by the extensor digitorum communis. When the fingers are flexed, flexion of the wrist is aided by the flexors digitorum sublimis and profundus, and extension is performed by the extensors carpi radialis and ulnaris. Number 2. The chief movements permitted in the mid-carpal joint are flexion and extension and a slight amount of rotation. In the flexion and extension, which are the movements most freely enjoyed, the greater and lesser multangulars on the radial side and the hamate on the ulnar side glide forward and backward on the navicular and triangular respectively, while the head of the capitate and the superior surface of the hamate rotate in the cup-shaped cavity of the navicular and lunate. Flexion at this joint is freer than extension. A very trifling amount of rotation is also permitted, the head of the capitate rotating around a vertical axis drawn through its own center while at the same time a slight gliding movement takes place in the lateral and medial. Section 15 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Bunley. Anatomy of the Human Body, Part 2, by Henry Gray. Carpometacarpal Articulations. Articulations Carpometacarpi. Carpometacarpal articulation of the thumb. Articulatio Carpometacarpi pollicis. This is a joint of reciprocal reception between the first metacarpal and the greater multiangular. It enjoys great freedom of movement on account of the configuration of its articular surfaces, which are saddle-shaped. The joint is surrounded by a capsule which is thick but loose and passes from the circumference of the base of the metacarpal bone to the rough edge bounding the articular surface of the greater multiangular. It is thickest laterally and dorsally and is lined by synovial membrane. Movements. In this articulation, the movements permitted are flexion and extension in the plane of the palm of the hand, adduction and abduction in a plane at right angles to the palm, circumduction and opposition. It is by the movement of opposition that the tip of the thumb is brought into contact with the volar surfaces of the slightly flexed fingers. This movement is effected through the medium of a small sloping facet on the anterior lip of the saddle-shaped articular surface of the greater multiangular. The flexure muscles pull the corresponding part of the articular surface of the metacarpal bone onto this facet, and the movement of opposition is then carried out by the adductors. Flexion of this joint is produced by the flexors pollicis longus and brevis, assisted by opponens pollicis and adductor pollicis. Extension is effected mainly by the abductor pollicis longus, assisted by extensors pollicis longus and brevis. Adduction is carried out by the adductor, abduction mainly by the abductors pollicis longus and brevis, assisted by the extensors. Articulations of the other four metacarpal bones with the carpus. Articulations Carpometacarpi. The joints between the carpus and the second, third, fourth, and fifth metacarpal bones are arthroidal. The bones are united by dorsal, volar, and interosseous ligaments. The dorsal ligaments, ligamenta Carpometacarpi dorsalia. The dorsal ligaments, the strongest and most distinct, connect the carpal and metacarpal bones on their dorsal surfaces. The second metacarpal bone receives two fasciculi, one from the greater, the other from the lesser multiangular. The third metacarpal receives two, one each from the lesser multangular and capitate, the fourth, two, one each from the capitate and the hamate, the fifth receives a single fasciculus from the hamate, and this is continuous with a similar ligament on the volar surface, forming an incomplete capsule. The volar ligaments. Ligamenta Carpometacarpae volaria. Palmar ligaments. The volar ligaments have a somewhat similar arrangement, with the exception of those of the third metacarpal, which are 3 in number, a lateral one from the greater multangular, situated superficial to the sheath of the tendon of the flexure carpi radialis, an intermediate one from the capitate, and a medial one from the hamate. Interosseous ligaments. The interosseous ligaments consist of short, thick fibers and are limited to one part of the carpometacarpal articulation. They connect the contiguous inferior angles of the capitate and hamate with the adjacent surfaces of the third and fourth metacarpal bones. Synovial membrane. The synovial membrane is a continuation of that of the intercarpal joints. Occasionally, the joint between the hamate and the fourth and fifth metacarpal bones has a separate synovial membrane. The synovial membranes of the wrist and carpus are thus seen to be 5 in number. The first passes from the lower end of the ulnar to ulnar notch of the radius and lines the upper surface of the articular disc. The second passes from the articular disc and the lower end of the radius above to the bones of the first row below. The third, the most extensive, passes between the contiguous margins of the 2 rows of carpal bones, and sometimes, in the event of one of the interosseous ligaments being absent, between the bones of the second row to the carpal extremities of the second, third, fourth, and fifth metacarpal bones. The fourth extends from the margin of the greater multangular to the metacarpal bone of the thumb. The fifth runs between the adjacent margins of the triangular and pisiform bones. Occasionally, the fourth and fifth metacarpal joints have a separate synovial membrane. Movements. The movements permitted in the carpometacarpal articulations of the fingers are limited to slight gliding of the articular surfaces upon each other, the extent of which varies in different joints. The metacarpal bone of the little finger is most movable than that of the ring finger. The metacarpal bones of the index and middle fingers are almost immovable. Intermetacarpal articulations. Articulations intercarpae, articulations of the metacarpal bones with each other. The bases of the second, third, fourth, and fifth metacarpal bones articulate with one another by small surfaces covered with cartilage and are connected together by dorsal, volar, and interosseous ligaments. The dorsal, ligamenta basium osseous metacarp dorsalia, and volar ligaments, ligamenta basium osseous metacarp volaria, palmar ligaments, pass transversely from one bone to another on the dorsal and volar surfaces. The interosseous ligaments, ligamenta basium, osteometacarp, interossea, connect their contiguous surfaces just distal to their collateral articular facets. The synovial membrane for these joints is continuous with that of the Carpometacarpal Articulations. The transverse metacarpal ligament, ligamentum capitularium, osteometacarpalium, transversum. This ligament is a narrow fibrous band which runs across the volar surfaces of the heads of the second, third, fourth, and fifth metacarpal bones, connecting them together. It is blended with the volar glenoid ligaments of the Metacarpophalangeal articulations. Its volar surface is concave where the flexor tendons pass over it. Behind it, the tendons of the interossi pass to their insertions. Metacarpophalangeal articulations. Articulations metacarpophalangeal. Metacarpophalangeal joints. These articulations are of condyloid kind, formed by the reception of the rounded heads of the metacarpal bones into shallow cavities on the proximal ends of the first phalanges, with the exception of that of thumb, which presents more of the characters of a gynglenoid joint. Each joint has a volar and two collateral ligaments. The volar ligaments. Glenoid ligaments of Humeral, palmar, or vaginal ligaments. The volar ligaments are thick, dense, fibrocartilaginous structures placed upon the volar surfaces of the joints in the intervals between the collateral ligaments to which they are connected. They are loosely united to the metacarpal bones, but are very firmly attached to the bases of the first phalanges. Their volar surfaces are intimately blended with the transverse metacarpal ligament and present grooves for the passage of the flexor tendons, the sheaths surrounding which are connected to the sides of the grooves. Their deep surfaces form parts of the articular facets for the heads of the metacarpal bones and are lined by synovial membranes. The collateral ligaments, ligamenta collateralia, lateral ligaments. The collateral ligaments are strong grounded cords placed on the sides of the joints. Each is attached by one extremity to the posterior tubercle and adjacent depression on the side of the head of the metacarpal bone, and by the other to the contiguous extremity of the phalanx. The dorsal surface of these joints are covered by the expansions of the extensor tendons together with some loose areolar tissue which connects the deep surfaces of the tendons to the bones. Movements. The movements which occur in these joints are flexion, extension, adduction, abduction, and circumduction. The movements of abduction and adduction are very limited and cannot be performed when the fingers are flexed.
Articulations of the digits. Articulations digitorum manus. Interphalangeal joints. The interphalangeal articulations are hinge joints. Each has a volar and two collateral ligaments. The arrangement of these ligaments is similar to those in the Metacarpophalangeal articulations. The extensor tendons supply the place of posterior ligaments. Movements. The only movements permitted in the interphalangeal joints are flexion and extension. These movements are more extensive between the first and second phalanges than between the second and third. The amount of flexion is very considerable, but extension is limited by the volar and collateral ligaments. Muscles acting on the joints of the digits. Flexion of the metacarpophalangeal joints of the fingers is effected by the flexors digitorum, sublimis and profundus, lubricales and interossi, assisted in the case of the little finger by the flexor digiti quinti brevis. Extension is produced by the extensor digitorum communis, extensor indicis proprius, and extensor digiti quinti proprius. Flexion of the interphalangeal joints of the fingers is accomplished by the flexor digitorum profundus acting on the proximal and distal joints, and by the flexor digitorum sublimis acting on the proximal joints. Extension is mainly effected by the lubricales and interossi, the long extensors having little or no action upon these joints. Flexion of the metacarpophalangeal joint of the thumb is effected by the flexors pollicis longus and brevis. Extension by the extensors pollicis longus and brevis. Flexion of the interphalangeal joint is accomplished by the flexor pollicis longus, and extension by
Section 16 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Ruth Golding. Anatomy of the Human Body, Part 2, by Henry Gray. 7. Articulations of the lower extremity. A. Coxal articulation or hip joint. The articulations of the lower extremity comprise the following: 1. Hip. 2. Knee. 3. Tibiofibula. 4. Ankle. 5. Intertarsal. 6. Tarsometatarsal. 7. Intermetatarsal. 8. Metatarsophalangeal. 9. Articulations of the digits. Coxal articulation or hip joint. Articulatio coxae. This articulation is an enarthrodial or ball and socket joint, formed by the reception of the head of the femur into the cup-shaped cavity of the acetabulum. The articular cartilage on the head of the femur, thicker at the centre than at the circumference, covers the entire surface with the exception of the fovea capitis femoris, to which the ligamentum teres is attached. That on the acetabulum forms an incomplete marginal ring, the lunate surface. Within the lunate surface there is a circular depression devoid of cartilage, occupied in the fresh state by a mass of fat, covered by synovial membrane. The ligaments of the joint are the articular capsule, the iliofemoral, the ischiocapsular, the pubocapsular, the ligamentum teres femoris, the glenoidal labrum, the transverse acetabula. The articular capsule, capsula articularis, capsular ligament. The articular capsule is strong and dense. Above, it is attached to the margin of the acetabulum, 5 to 6 millimetres beyond the glenoidal labrum behind, but in front it is attached to the outer margin of the labrum, and opposite to the notch where the margin of the cavity is deficient, it is connected to the transverse ligament, and by a few fibres to the edge of the obturator foramen. It surrounds the neck of the femur, and is attached in front to the intertrochanteric line, above to the base of the neck, behind to the neck about 1.25 centimetres above the intertrochanteric crest, below to the lower part of the neck, close to the lesser trochanter. From its femoral attachment, some of the fibres are reflected upward along the neck as longitudinal bands, termed retinacular. The capsule is much thicker at the upper and fore part of the joint, where the greatest amount of resistance is required. Behind and below it is thin and loose. It consists of two sets of fibres, circular and longitudinal. The circular fibres, zona orbicularis, are most abundant at the lower and back part of the capsule, and form a sling or collar around the neck of the femur. Anteriorly, they blend with the deep surface of the iliofemoral ligament, and gain an attachment to the anterior inferior iliac spine. The longitudinal fibres are greatest in amount at the upper and front part of the capsule, where they are reinforced by distinct bands or accessory ligaments, of which the most important is the iliofemoral ligament. The other accessory bands are known as the pubocapsular and the ischiocapsular ligaments. The external surface of the capsule is rough, covered by numerous muscles, and separated in front from the psoas major and iliacus by a bursa, which not infrequently communicates by a circular aperture with the cavity of the joint. The iliofemoral ligament, ligamentum iliofemorale, Y ligament, ligament of Bigelow. The iliofemoral ligament is a band of great strength which lies in front of the joint. It is intimately connected with the capsule and serves to strengthen it in this situation. It is attached above to the lower part of the anterior inferior iliac spine. Below it divides into two bands, one of which passes downward and is fixed to the lower part of the intertrochanteric line. The other is directed downward and lateralward and is attached to the upper part of the same line. Between the two bands is a thinner part of the capsule. In some cases there is no division, and the ligament spreads out into a flat triangular band which is attached to the whole length of the intertrochanteric line. This ligament is frequently called the Y-shaped ligament of Bigelow, and its upper band is sometimes named the iliotrochanteric ligament. The pubocapsular ligament, ligamentum pubocapsulare, pubofemoral ligament. This ligament is attached above to the obturator crest and the superior ramus of the pubis. Below, it blends with the capsule and with the deep surface of the vertical band of the iliofemoral ligament. The ischiocapsular ligament, ligamentum ischiocapsulare, ischiocapsular band, ligament of Bertin. The ischiocapsular ligament consists of a triangular band of strong fibres, which spring from the ischium below and behind the acetabulum, and blend with the circular fibres of the capsule. The ligamentum teres femoris. The ligamentum teres femoris is a triangular, somewhat flattened band, implanted by its apex into the antero-superior part of the fovea capitis femoris. Its base is attached by two bands, one into either side of the acetabular notch, and between these bony attachments it blends with the transverse ligament. It is ensheathed by the synovial membrane, and varies greatly in strength in different subjects. Occasionally only the synovial fold exists, and in rare cases even this is absent. The ligament is made tense when the thigh is semi-flexed, and the limb then adducted or rotated outward. It is, on the other hand, relaxed when the limb is abducted. It has, however, but little influence as a ligament. The glenoidal labrum, labrum glenoidale, cotyloid ligament. The glenoidal labrum is a fibrocartilaginous rim attached to the margin of the acetabulum, the cavity of which it deepens. At the same time it protects the edge of the bone and fills up the inequalities of its surface. It bridges over the notch as the transverse ligament, and thus forms a complete circle, which closely surrounds the head of the femur and assists in holding it in its place. It is triangular on section, its base being attached to the margin of the acetabulum, while its opposite edge is free and sharp. Its two surfaces are invested by synovial membrane, the external one being in contact with the capsule, the internal one being inclined inward so as to narrow the acetabulum and embrace the cartilaginous surface of the head of the femur. It is much thicker above and behind than below and in front, and consists of compact fibres. The transverse acetabular ligament, ligamentum transversum acetabulae, transverse ligament. This ligament is in reality a portion of the glenoidal labrum, though differing from it in having no cartilage cells among its fibres. It consists of strong flattened fibres, which cross the acetabular notch and convert it into a foramen through which the nutrient vessels enter the joint. Synovial membrane. The synovial membrane is very extensive. Commencing at the margin of the cartilaginous surface of the head of the femur, it covers the portion of the neck which is contained within the joint. From the neck it is reflected on the internal surface of the capsule, covers both surfaces of the glenoidal labrum and the mass of fat contained in the depression at the bottom of the acetabulum, and ensheathes the ligamentum teres as far as the head of the femur. The joint cavity sometimes communicates through a hole in the capsule between the vertical band of the iliofemoral ligament and the pubocapsular ligament with a bursa situated on the deep surfaces of the psoas major and iliacus. The muscles in relation with the joint are, in front, the psoas major and iliacus, separated from the capsule by a bursa; above, the reflected head of the rectus femoris and gluteus minimus, the latter being closely adherent to the capsule; medially, the obturator externus and pectineus; behind, the piriformis, gemellus superior, obturator internus, gemellus inferior, obturator externus, and quadratus femoris. The arteries supplying the joint are derived from the obturator, medial femoral circumflex, and superior and inferior gluteals. The nerves are articular branches from the sacral plexus, sciatic, obturator, accessory obturator, and a filament from the branch of the femoral supplying the rectus femoris. Movements. The movements of the hip are very extensive, and consist of flexion, extension, adduction, abduction, circumduction, and rotation. The length of the neck of the femur and its inclinations to the body of the bone have the effect of converting the angular movements of flexion, extension, adduction, and abduction partially into rotatory movements in the joint. Thus, when the thigh is flexed or extended, the head of the femur, on account of the medial inclination of the neck, rotates within the acetabulum with only a slight amount of gliding to and fro. The forward slope of the neck similarly affects the movements of adduction and abduction. Conversely, rotation of the thigh, which is permitted by the upward inclination of the neck, is not a simple rotation of the head of the femur in the acetabulum, but is accompanied by a certain amount of gliding. The hip joint presents a very striking contrast to the shoulder joint, in the much more complete mechanical arrangements for its security, and for the limitation of its movements. In the shoulder, as has been seen, the head of the humerus is not adapted at all in size to the glenoid cavity, and is hardly restrained in any of its ordinary movements by the capsule. In the hip joint, on the contrary, the head of the femur is closely fitted to the acetabulum for an area extending over nearly half a sphere, and at the margin of the bony cup it is still more closely embraced by the glenoidal labrum, so that the head of the femur is held in its place by that ligament, even when the fibres of the capsule have been quite divided. The iliofemoral ligament is the strongest of all the ligaments in the body, and is put on the stretch by any attempt to extend the femur beyond a straight line with the trunk. That is to say, this ligament is the chief agent in maintaining the erect position without muscular fatigue. For a vertical line passing through the centre of gravity of the trunk falls behind the centres of rotation in the hip joints, and therefore the pelvis tends to fall backward, but is prevented by the tension of the iliofemoral ligaments. The security of the joint may be provided for also by the two bones being directly united through the ligamentum teres, but it is doubtful whether this ligament has much influence upon the mechanism of the joint. When the knee is flexed, flexion of the hip joint is arrested by the soft parts of the thigh and abdomen being brought into contact, and when the knee is extended, by the action of the hamstring muscles. Extension is checked by the tension of the iliofemoral ligament, adduction by the thighs coming into contact. Adduction with flexion by the lateral band of the iliofemoral ligament and the lateral part of the capsule. Abduction by the medial band of the iliofemoral ligament and the pubocapsular ligament. Rotation outward by the lateral band of the iliofemoral ligament, and rotation inward by the ischiocapsular ligament and the hinder part of the capsule. The muscles which flex the femur on the pelvis are the psoas major, iliacus, rectus femoris, sartorius, pectineus, adductores longus and brevis, and the anterior fibres of the glutei medius and minimus. Extension is mainly performed by the gluteus maximus, assisted by the hamstring muscles and the ischial head of the adductor magnus. The thigh is adducted by the adductores magnus, longus, and brevis, the pectineus, the gracilis, and lower part of the gluteus maximus, and abducted by the glutei medius and minimus and the upper part of the gluteus maximus. The muscles which rotate the thigh inward are the gluteus minimus and the anterior fibres of the gluteus medius, the tensor fasciae latae, and the iliacus and psoas major, while those which rotate it outward are the posterior fibres of the gluteus medius, the piriformis, obturatores externus and internus, gemelli superior and inferior, quadratus femoris, gluteus maximus, the adductores longus, brevis, and magnus,
Section 17 of Gray's Anatomy Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by the Bodster. Anatomy of the Human Body, Part 2, by Henry Gray. Section 7b, the knee joint. Articulatio genu. The knee joint was formerly described as the ginglymus or hinge joint, but is really of a much more complicated character. It must be regarded as consisting of three articulations in one: two condyloid joints, one between each condyle of the femur and the corresponding meniscus and the condyle of the tibia, and a third between the patella and the femur, part arthrodile, but not completely so, since the articular surfaces are not mutually adapted to each other, so that the movement is not a simple gliding one. This view of the construction of the knee joint receives confirmation from the study of the articulation in some of the lower mammals, where, corresponding to these three subdivisions, three synovial cavities are sometimes found, either entirely distinct or only connected together by small communications. This view is further rendered probable by the existence in the middle of the joint of the two cruciate ligaments, which must be regarded as the collateral ligaments of the medial and lateral joints. The existence of the patellar fold of synovial membrane would further indicate a tendency to separation of the synovial cavity into two minor sacs, one corresponding to the lateral and the other to the medial joint. The bones are connected together by the following ligaments: the articular capsule, the ligamentum patellae, the oblique popliteal, the tibial collateral, the fibula collateral, the anterior cruciate, the posterior cruciate, the medial and lateral menisci, the transverse, and the coronary. The articular capsule, capsula articularis, capsular ligament. The articular capsule consists of a thin but strong fibrous membrane, which is strengthened in almost its entire extent by bands inseparably connected with it. Above and in front, beneath the tendon of the quadriceps femoris, it is represented only by the synovial membrane. Its chief strengthening bands are derived from the fascia lata and from the tendons surrounding the joint. In front, expansions from the vasti and from the fascia lata and its iliotibial band fill in the intervals between the anterior and collateral ligaments, constituting the medial and lateral patella retinacula. Behind the capsule consists of vertical fibres which arise from the condyles and from the sides of the intercondyloid fossa of the femur. The posterior part of the capsule is therefore situated on the sides of and in front of the cruciate ligaments, which are thus excluded from the joint cavity. Behind the cruciate ligaments is the oblique popliteal ligament, which is augmented by fibres derived from the tendon of the semimembranosus. Laterally, a prolongation from the iliotibial band fills in the interval between the oblique popliteal and the fibular collateral ligaments and partly covers the latter. Medially, expansions from the sartorius and the semimembranosus pass upward to the tibial collateral ligament and strengthen the capsule. The ligamentum patellae, anterior ligament. The ligamentum patellae is the central portion of the common tendon of the quadriceps femoris, which is continued from the patella to the tuberosity of the tibia. It is a strong, flat, ligamentous band, about 8 centimetres in length, attached above to the apex and adjoining margins of the patella and the rough depression on its posterior surface. Below, to the tuberosity of the tibia, its superficial fibres are continuous over the front of the patella with those of the tendon of the quadriceps femoris. The medial and lateral portions of the tendon of the quadriceps pass down on either side of the patella to be inserted into the upper extremity of the tibia on either side of the tuberosity. These portions merge into the capsule, as stated above, forming the medial and lateral patella retinacula. The posterior surface of the ligamentum patellae is separated from the synovial membrane of the joint by a large infrapatellar pad of fat, and from the tibia by a bursa. The oblique popliteal ligament, ligamentum popliteum obliquum, posterior ligament. This ligament is a broad, flat, fibrous band formed of fasciculi separated from one another by apertures from the passage of vessels and nerves. It is attached above to the upper margin of the intercondyloid fossa and posterior surface of the femur, close to the articular margins of the condyles, and below to the posterior margin of the head of the tibia. Superficial to the main part of the ligament is a strong fasciculus, derived from the tendon of the semimembranosus and passing from the back part of the medial condyle of the tibia obliquely upward and lateralward to the back part of the lateral condyle of the femur. The oblique popliteal ligament forms part of the floor of the popliteal fossa, and the popliteal artery rests upon it. The tibial collateral ligament, ligamentum collateral tibial, internal lateral ligament. The tibial collateral is a broad, flat, membranous band, situated nearer to the back than to the front of the joint. It is attached above to the medial condyle of the femur immediately below the adductor tubercle, below to the medial condyle and medial surface of the body of the tibia. The fibres of the posterior part of the ligament are short and incline backward as they descend. They are inserted into the tibia above the groove for the semimembranosus. The anterior part of the ligament is a flattened band, about 10 centimetres long, which inclines forward as it descends. It is inserted into the medial surface of the body of the tibia about 2.5 centimetres below the level of the condyle. It is crossed at its lower part by the tendons of the sartorius, gracilis, and semitendinosus, a bursa being interposed. Its deep surface covers the inferior medial genicular vessels and nerve, and the anterior portion of the tendon of the semimembranosus, with which it is connected by a few fibres. It is intimately adherent to the medial meniscus. The fibular collateral ligament, ligamentum collaterale fibular, external lateral or long external lateral ligament. The fibular collateral is a strong, rounded, fibrous cord attached above to the back part of the lateral condyle of the femur, immediately above the groove for the tendon of the popliteus, below to the lateral side of the head of the fibula in front of the styloid process. The greater part of its lateral surface is covered by the tendon of the biceps femoris. The tendon, however, divides at its insertion into two parts, which are separated by the ligament. Deep to the ligament are the tendon of the popliteus and the inferior lateral genicular vessels and nerve. The ligament has no attachment to the lateral meniscus. An inconstant bundle of fibres, the short fibular collateral ligament, is placed behind and parallel with the preceding, attached above to the lower and back part of the lateral condyle of the femur, below to the summit of the styloid process of the fibula. Passing deep to it are the tendon of the popliteus and the inferior lateral genicular vessels and nerve. The cruciate ligaments, ligamenta cruciata genu, crucial ligaments. The cruciate ligaments are of considerable strength, situated in the middle of the joint, nearer to its posterior than to its anterior surface. They are called cruciate because they cross each other somewhat like the lines of the letter X, and have received the names anterior and posterior from the position of their attachments to the tibia. The anterior cruciate ligament, ligamentum cruciatum anterius, external crucial ligament, is attached to the depression in front of the intercondyloid eminence of the tibia, being blended with the anterior extremity of the lateral meniscus. It passes upward, backward, and lateralward, and is fixed into the medial and back part of the lateral condyle of the femur. The posterior cruciate ligament, ligamentum cruciatum posterius, internal crucial ligament, is stronger but shorter and less oblique in its direction than the anterior. It is attached to the posterior intercondyloid fossa of the tibia and to the posterior extremity of the lateral meniscus, and passes upward, forward, and medialward to be fixed into the lateral and front part of the medial condyle of the femur. The menisci, semilunar fibrocartilages. The menisci are two crescentic lamellae, which serve to deepen the surfaces of the head of the tibia for articulation with the condyles of the femur. The peripheral border of each meniscus is thick, convex, and attached to the inside of the capsule of the joint. The opposite border is thin, concave, and free. The upper surfaces of the menisci are concave and in contact with the condyles of the femur. Their lower surfaces are flat and rest upon the head of the tibia. Both surfaces are smooth and invested by synovial membrane. Each meniscus covers approximately the peripheral 2/3 of the corresponding articular surface of the tibia. The medial meniscus, meniscus medialis, internal semilunar fibrocartilage, is nearly semicircular in form, a little elongated from before backward, and broader behind than in front. Its anterior end, thin and pointed, is attached to the anterior intercondyloid fossa of the tibia, in front of the anterior cruciate ligament. Its posterior end is fixed to the posterior intercondyloid fossa of the tibia, between the attachments of the lateral meniscus and the posterior cruciate ligament. The The lateral meniscus, meniscus lateralis, external semilunar fibrocartilage, is nearly circular and covers a larger portion of the articular surface than the medial one. It is grooved laterally for the tendon of the popliteus, which separates it from the fibular collateral ligament. Its anterior end is attached in front of the intercondyloid eminence of the tibia, lateral to and behind the anterior cruciate ligament with which it blends. The posterior end is attached behind the intercondyloid eminence of the tibia and in front of the posterior end of the medial meniscus. The anterior attachment of the lateral meniscus is twisted on itself so that its free margin looks backward and upward, its anterior end resting on a sloping shelf of bone on the front of the lateral process of the intercondyloid eminence. Close to its posterior attachment, it sends off a strong fasciculus, the ligament of Risberg, which passes upward and medialward to be inserted into the medial condyle of the femur, immediately behind the attachment of the posterior cruciate ligament. Occasionally a small fasciculus passes forward to be inserted into the lateral part of the anterior cruciate ligament. The lateral meniscus gives off from its anterior convex margin a fasciculus which forms the transverse ligament. The transverse ligament, ligamentum transversum genu. The transverse ligament connects the anterior convex margin of the lateral meniscus to the anterior end of the medial meniscus. Its thickness varies considerably in different subjects, and it is sometimes absent. The coronary ligaments are merely portions of the capsule, which connect the periphery of each meniscus with the margin of the head of the tibia. Section 18 of Gray's Anatomy Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by The Bodster. Anatomy of the Human Body, Part 2 by Henry Gray. Section 7b, the knee joint. Articulatio genu. Synovial membrane. The synovial membrane of the knee joint is the largest and most extensive in the body. Commencing at the upper border of the patella, it forms a large cul-de-sac beneath the quadriceps femoris, on the lower part of the front of the femur, and frequently communicates with a bursa interposed between the tendon and the front of the femur. The pouch of synovial membrane between the quadriceps and front of the femur is supported, during the movement of the knee, by a small muscle, the articularis genu, which is inserted into it. On either side of the patella, the synovial membrane extends beneath the aponeuroses of the vasti, and more especially beneath that of the vastus medialis. Below the patella, it is separated from the ligamentum patellae by a considerable quantity of fat, known as the infrapatellar pad. From the medial and lateral borders of the articular surface of the patella, reduplications of the synovial membrane project into the interior of the joint. These form two fringe-like folds termed the alar folds. Below, these folds converge and are continued as a single band, the patellar fold, ligamentum mucosum, to the front of the intercondyloid fossa of the femur. On either side of the joint, the synovial membrane passes downward from the femur, lining the capsule to its point of attachment to the menisci. It may then be traced over the upper surfaces of these to their free borders, and thence along their under surfaces to the tibia. At the back part of the lateral meniscus, it forms a cul-de-sac between the groove on its surface and the tendon of the popliteus. It is reflected across the front of the cruciate ligaments, which are therefore situated outside the synovial cavity. Bursae. The bursae near the knee joint are the following. In front, there are 4 bursae. A large one is interposed between the patella and the skin, a small one between the upper part of the tibia and the ligamentum patellae, a third between the lower part of the tuberosity of the tibia and the skin, and a fourth between the anterior surface of the lower part of the femur and the deep surface of the quadriceps femoris, usually communicating with the knee joint. Laterally, there are 4 bursae, one, which sometimes communicates with the joint, between the lateral head of the gastrocnemius and the capsule, one between the fibular collateral ligament and the tendon of the biceps, one between the fibular collateral ligament and the tendon of the popliteus. This is sometimes only an expansion from the next bursa, and one between the tendon of the popliteus and the lateral condyle of the femur, usually an extension from the synovial membrane of the joint. Medially, there are 5 bursae, one between the medial head of the gastrocnemius and the capsule. This sends a prolongation between the tendon of the medial head of the gastrocnemius and the tendon of the semimembranosus, and often communicates with the joint. One superficial to the tibial collateral ligament between it and the tendons of the sartorius, gracilis, and semitendinosus. One deep to the tibial collateral ligament between it and the tendon of the semimembranosus. This is sometimes only an expansion from the next bursa. One between the tendon of the semimembranosus and the head of the tibia, and occasionally there is a bursa between the tendons of the semimembranosus and the semitendinosus. Structures around the joint. In front and at the sides is the quadriceps femoris. Laterally, the tendons of the biceps femoris and popliteus and the common peroneal nerve. Medially, the sartorius, gracilis, semitendinosus, and semimembranosus. Behind, the popliteal vessels and the tibial nerve, popliteus, plantaris, and medial and lateral heads of the gastrocnemius, some lymph glands, and fat. The arteries supplying the joints are the highest genicular, anastomotica magna, a branch of the femoral, the genicular branches of the popliteal, the recurrent branches of the anterior tibial, and the descending branch from the lateral femoral circumflex of the profunda femoris. The nerves are derived from the obturata, femoral, tibial, and common peroneal. Movements. The movements which take place at the knee joint are flexion and extension, and, in certain positions of the joint, internal and external rotation. The movements of flexion and extension at this joint differ from those in a typical hinge joint, such as the elbow, in that a. the axis around which motion takes place is not a fixed one, but shifts forward during extension and backward during flexion, and b. the commencement of flexion and the end of extension are accompanied by rotatory movements associated with the fixation of the limb in a position of great stability. The movement from full flexion to full extension may therefore be described in 3 phases. 1. In the fully flexed condition, the posterior parts of the femoral condyles rest on the corresponding portions of the meniscotibial surfaces, and in this position a slight amount of simple rolling movement is allowed. 2. During the passage of the limb from the flexed to the extended position, a gliding movement is superposed on the rolling, so that the axis, which at the commencement is represented by a line through the inner and outer condyles of the femur, gradually shifts forward. In this part of the movement, the posterior 2/3 of the tibial articular surfaces of the two femoral condyles are involved, and as these have similar curvatures and are parallel to one another, they move forward equally. And 3, the lateral condyle of the femur is brought almost to rest by the tightening of the anterior cruciate ligament. It moves, however, slightly forward and medialward, pushing before it the anterior part of the lateral meniscus. The tibial surface on the medial condyle is prolonged farther forward than that on the lateral, and this prolongation is directed lateralward. When, therefore, the movement forward of the condyles is checked by the anterior cruciate ligament, continued muscular action causes the medial condyle, dragging with it the meniscus, to travel backward and medialward, thus producing an internal rotation of the thigh on the leg. When the position of full extension is reached, the lateral part of the groove on the lateral condyle is pressed against the anterior part of the corresponding meniscus, while the medial part of the groove rests on the articular margin in front of the lateral process of the tibial intercondyloid eminence. Into the groove on the medial condyle is fitted the anterior part of the medial meniscus, while the anterior cruciate ligament and the articular margin in front of the medial process of the tibial intercondyloid eminence are received into the forepart of the intercondyloid fossa of the femur. This third phase, by which all these parts are brought into accurate apposition, is known as the screwing home, or locking movement of the joint. The complete movement of flexion is the converse of that described above, and is therefore preceded by an external rotation of the femur, which unlocks the extended joint. The axes around which the movements of flexion and extension take place are not precisely at right angles to either bone. In flexion, the femur and tibia are in the same plane, but in extension, the one bone forms an angle, opening lateralward to the other. In addition to the rotary movements associated with the completion of extension and initiation of flexion, rotation inward or outward can be effected when the joint is partially flexed. These movements take place mainly between the tibia and the menisci, and are freest when the leg is bent at right angles with the thigh. Movements of patella. The articular surface of the patella is indistinctly divided into 7 facets: upper, middle, and lower horizontal pairs, and a medial perpendicular facet. When the knee is forcibly flexed, the medial perpendicular facet is in contact with the semilunar surface of the lateral part of the medial condyle. This semilunar surface is a prolongation backward of the medial part of the patellar surface. As the leg is carried from the flexed to the extended position, first the highest pair, then the middle pair, and lastly the lowest pair of horizontal facets, is successively brought into contact with the patellar surface of the femur. In the extended position, when the quadriceps femoris is relaxed, the patella lies loosely on the front of the lower end of the femur. During flexion, the ligamentum patellae is put upon the stretch, and in extreme flexion the posterior cruciate ligament, the oblique popliteal and collateral ligaments, and to a slight extent the anterior cruciate ligament, are relaxed. Flexion is checked during life by the contact of the leg with the thigh. When the knee joint is fully extended, the oblique popliteal and collateral ligaments, the anterior cruciate ligament, and the posterior cruciate ligament are rendered tense. In the act of extending the knee, the ligamentum patellae is tightened by the quadriceps femoris, but in full extension, with the heel supported, it is relaxed. Rotation inward is checked by the anterior cruciate ligament. Rotation outward tends to uncross and relax the cruciate ligaments, but is checked by the tibial collateral ligament. The main function of the cruciate ligament is to act as a direct bond between the tibia and femur, and to prevent the former bone from being carried too far backward or forward. They also assist the collateral ligaments in resisting any bending of the joint to either side. The menisci are intended, as it seems, to adapt the surfaces of the tibia to the shape of the femoral condyles to a certain extent, so as to fill up the intervals which would otherwise be left in the varying positions of the joint, and to obviate the jars which would be so frequently transmitted up the limb in jumping or by falls on the feet. Also, to permit of the two varieties of motion, flexion and extension, and rotation, as explained above. The patella is a great defence to the front of the knee joint, and distributes upon a large and tolerably even surface, during kneeling, the pressure which would otherwise fall upon the prominent ridges of the condyles. It also affords leverage to the quadriceps femoris. When standing erect in the attitude of attention, the weight of the body falls in front of a line carried across the centres of the knee joints, and therefore tends to produce overextension of the articulations. This, however, is prevented by the tension of the anterior cruciate, oblique popliteal, and collateral ligaments. Extension of the leg on the thigh is performed by the quadriceps femoris, flexion by the biceps femoris, semitendinosus, and semimembranosus, assisted by the gracilis, sartorius, gastrocnemius, popliteus, and plantaris. Rotation outward is effected by the biceps femoris, and rotation inward by the popliteus, semitendinosus, and to a slight extent the semimembranosus, the sartorius, and the gracilis. The popliteus comes into action especially at the commencement of the movement of flexion of the knee. By its contraction, the leg is rotated inward, or, if the tibia be fixed, the thigh is rotated outward, and the knee joint is unlocked. End of section.
Section 19 of Gray's Anatomy Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Ruth Golding. Anatomy of the Human Body Part 2 by Henry Gray. 7c. Articulations between the tibia and fibula. The articulations between the tibia and fibula are effected by ligaments which connect the extremities and bodies of the bones. The ligaments may consequently be subdivided into three sets: 1. Those of the tibio-fibular articulation; 2. The interosseous membrane; 3. Those of the tibio-fibular syndesmosis. Tibio-fibular articulation. Articulatio tibiofibularis, superior tibio-fibular articulation. This articulation is an arthrodial joint between the lateral condyle of the tibia and the head of the fibula. The contiguous surfaces of the bones present flat oval facets covered with cartilage, and connected together by an articular capsule and by anterior and posterior ligaments. The articular capsule. Capsula articularis, capsular ligament. The articular capsule surrounds the articulation, being attached around the margins of the articular facets on the tibia and fibula. It is much thicker in front than behind. The anterior ligament, anterior superior ligament. The anterior ligament of the head of the fibula consists of 2 or 3 broad and flat bands, which pass obliquely upward from the front of the head of the fibula to the front of the lateral condyle of the tibia. The posterior ligament, posterior superior ligament. The posterior ligament of the head of the fibula is a single thick and broad band, which passes obliquely upward from the back of the head of the fibula to the back of the lateral condyle of the tibia. It is covered by the tendon of the popliteus. Synovial membrane. A synovial membrane lines the capsule. It is continuous with that of the knee joint in occasional cases when the 2 joints communicate. Interosseous membrane. Membrana interossea cruris. Middle tibiofibular ligament. An interosseous membrane extends between the interosseous crests of the tibia and fibula, and separates the muscles on the front from those on the back of the leg. It consists of a thin aponeurotic lamina composed of oblique fibres, which for the most part run downward and lateralward. Some few fibres, however, pass in the opposite direction. It is broader above than below. Its upper margin does not quite reach the tibiofibular joint, but presents a free concave border, above which is a large oval aperture for the passage of the anterior tibial vessels to the front of the leg. In its lower part is an opening for the passage of the anterior peroneal vessels. It is continuous below with the interosseous ligament of the tibiofibular syndesmosis, and presents numerous perforations for the passage of small vessels. It is in relation in front with the tibialis anterior, extensor digitorum longus, extensor hallucis proprius, peroneus tertius, and the anterior tibial vessels and deep peroneal nerve, behind with the tibialis posterior and flexor hallucis longus. Tibiofibular syndesmosis. Syndesmosis tibiofibularis, inferior tibiofibular articulation. This syndesmosis is formed by the rough convex surface of the medial side of the lower end of the fibula and a rough concave surface on the lateral side of the tibia. Below, to the extent of about 4 millimetres, these surfaces are smooth and covered with cartilage, which is continuous with that of the ankle joint. The ligaments are anterior, posterior, inferior transverse, and interosseous. The anterior ligament, ligamentum malleoli lateralis anterius, anterior inferior ligament. The anterior ligament of the lateral malleolus is a flat triangular band of fibres, broader below than above, which extends obliquely downward and lateralward between the adjacent margins of the tibia and fibula, on the front aspect of the syndesmosis. It is in relation in front with the peroneus tertius, the aponeurosis of the leg and the integument, behind with the interosseous ligament, and lies in contact with the cartilage covering the talus. The posterior ligament, ligamentum malleoli lateralis posterius, posterior inferior ligament. The posterior ligament of the lateral malleolus, smaller than the preceding, is disposed in a similar manner on the posterior surface of the syndesmosis. The inferior transverse ligament. The inferior transverse ligament lies in front of the posterior ligament, and is a strong thick band of yellowish fibres, which passes transversely across the back of the joint, from the lateral malleolus to the posterior border of the articular surface of the tibia, almost as far as its malleolar process. This ligament projects below the margin of the bones and forms part of the articulating surface for the talus. The interosseous ligament. The interosseous ligament consists of numerous short, strong, fibrous bands, which pass between the contiguous rough surfaces of the tibia and fibula, and constitute the chief bond of union between the bones. It is continuous above with the interosseous membrane. Synovial membrane. The synovial membrane, associated with the small arthrodial part of this joint,
Section 20 of Gray's Anatomy Part 2. This is LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Logan McCammon. Anatomy of the Human Body, Part 2, by Henry Gray. Talocrural articulation, or ankle joint. The ankle joint is a gigglymus, or hinge joint. The structures entering into its formation are the lower end of the tibia and its malleolus, the malleolus of the fibula, and the transverse ligament, which together form a mortise for the reception of the upper convex surface of the talus and its medial and lateral facets. The bones are connected by the following ligaments: the articular capsule, the anterior talofibular, the deltoid, the posterior talofibular, and the calcaneofibular. The articular capsule, capsula articularis, capsular ligament. The articular capsule surrounds the joints and is attached above to the borders of the articular surfaces of the tibia and malleoli, and below to the talus around its upper articular surface. The anterior part of the capsule, anterior ligament, is a broad, thin, membranous layer attached above to the anterior margin of the lower end of the tibia, below to the talus, in front of its superior articular surface. It is in relation in front with the extensor tendons of the toes, the tendons of the tibialis anterior and peroneus tertius, and the anterior tibial vessels and deep peroneal nerve. The posterior part of the capsule, posterior ligament, is very thin and consists principally of transverse fibers. It is attached above to the margin of articular surface of the tibia, blending with the transverse ligament below to the talus behind its superior articular facet. Laterally it is somewhat thickened and is attached to the hollow on the medial surface of the lateral malleolus. The deltoid ligament, ligamentum deltoideum, internal lateral ligament. The deltoid ligament is a strong, flat, triangular band attached above to the apex and anterior and posterior borders of the medial malleolus. It consists of two sets of fibers, superficial and deep. Of the superficial fibers, the most anterior, tibio-navicular, pass forward to be inserted into the tuberosity of the navicular bone, and immediately behind this they blend with the medial margin of the plantar calcaneonavicular ligament. The middle, calcaneotibial, descend almost perpendicular to be inserted into the hole of the sustentaculum tali of the calcaneus. The posterior fibers, posterior talotibial, pass backward and lateralward to be attached to the inner side of the talus and to the prominent tubercle in its posterior surface, medial to the groove for the tendon of the flexor hallucis longus. The deep fibers, anterior talotibial, are attached above to the tip of the medial malleolus, and below to the medial surface of the talus. The deltoid ligament is covered by the tendons of the tibialis posterior and flexor digitorum longus. The anterior and posterior taliofibular and calcaneofibular ligaments were formerly described as the three fasciculi of the external lateral ligament of the ankle joint. The anterior talofibular ligament, ligamentum talofibular anterius. The anterior talofibular ligament, the shortest of the three, passes from the anterior margin of the fibular malleolus forward and medially to the talus, in front of its lateral articular facet. The posterior talofibular ligament, ligamentum talofibular posterius. The posterior talofibular ligament, the strongest and most deeply seated, runs almost horizontally from the depression at the medial and back part of the fibular malleolus to a prominent tubercle on the posterior surface of the talus, immediately lateral to the groove from the tendon of the flexor hallucis longus. The calcaneofibular ligament, ligamentum calcaneofibular. The calcaneofibular ligament, the longest of the three, is a narrow rounded cord running from the apex of the fibular malleolus downward and slightly backward to a tubercle on the lateral surface of the calcaneus. It is covered by the tendons of the peroneal longus and brevis. Synovial membrane. The synovial membrane invests the deep surfaces of the ligaments and sends a small process upward between the lower ends of the tibia and fibula. Relations. The tendons, vessels, and nerves in connection with the joint are, in front from the medial side, the tibialis anterior, extensor hallucis proprius, anterior tibial vessels, deep peroneal nerve, extensor digitorum longus, and peroneus tertius. Behind, from the medial side, the tibialis posterior, flexor digitorum longus, posterior tibial vessels, tibial nerve, flexor hallucis longus, and, in the groove behind the fibular malleolus, the tendons of the peroneal longus and brevis. The arteries supplying the joint are derived from the malleolar branches of the anterior tibial and the peroneal. The nerves are derived from the deep peroneal and tibial. Movements. When the body is in the erect position, the foot is at a right angle to the leg. The movements of the joint are those of dorsiflexion and extension. Dorsiflexion consists in the approximation of the dorsum of the foot to the front of the leg, while in extension the heel is drawn up and the toes pointed downward. The range of movement varies in different individuals from about 50 degrees to 90 degrees. The transverse axis about which movement takes place is slightly oblique. The malleoli tightly embrace the talus in all positions of the joint, so that any slight degree of side-to-side movement which may exist is simply due to stretching of the ligaments of the talofibular syndesmosis and slight bending of the body of the fibula. The superior articular surface of the talus is broader in front than behind. In dorsiflexion, therefore, greater space is required between the two malleoli. This is obtained by a slight outward rotatory movement of the lower end of the fibula and a stretching of the ligaments of the syndesmosis. This lateral movement is facilitated by a slight gliding of the tibiofibular articulation and possibly also by the bending of the body of the fibula. Of the ligaments the deltoid is of very great power, so much so that it usually resists a force which fractures the process of the bone to which it is attached. Its middle portion, together with the calcaneofibular ligament, binds the bone of the leg firmly to the foot, and resists displacement in every direction. Its anterior and posterior fibers limit extension and flexion in the foot respectively, and the anterior fibers also limit abduction. The posterior talofibular ligament assists the calcaneofibular in resisting the displacement of the foot backward, and deepens the cavity for the reception of the talus. The anterior talofibular is a security against the displacement of the foot forward, and limits extension of the joint. The movements of inversion and eversion of the foot, together with the minute changes in form by which it is applied to the ground or takes hold of an object in climbing, etc., are mainly effected in the tarsal joints. the joint which enjoys the greatest amount of motion being that between the talus and calcaneus behind and the navicular and cuboid in front. That is often called the transverse tarsal joint, and it can, with the subordinate joints of the tarsus, replace the ankle joint in a great measure when the latter has become ankylosed. Extension of the foot upon the tibia and fibula is produced by the gastrocnemius, soleus, plantaris, tibialis posterior, peroneus longus and brevis, flexor digitorum longus, and flexor hallucis longus, dorsiflexion, or the tibialis anterior, peroneus tertius, extensor digitorum longus, and extensor hallucis proprius. Note 74. The student must bear in mind that the extensor digitorum longus and extensor hallucis proprius are extensors of the toes, but flexors of the ankle, and that flexor digitorum longus and flexor hallucis longus are flexors of the toes, but extensors of the ankle.
Section 21 of Gray's Anatomy Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by The Bodster. Anatomy of the Human Body, Part 2 by Henry Gray. Section 7e. Intertarsal Articulations. Articulations intertarsiae. Articulations of the tarsus. Talocalcaneal articulation. Articulatio talocalcanea. Articulation of the calcaneus and astragalus. Calcaneo-astragaloid articulation. The articulations between the calcaneus and the talus are two in number, anterior and posterior. Of these, the anterior forms part of the talocalcaneo-navicular joint and will be described with that articulation. The posterior, or talocalcaneal articulation, is formed between the posterior calcaneal facet on the inferior surface of the talus and the posterior facet on the superior surface of the calcaneus. It is an arthrodile joint, and the two bones are connected by an articular capsule and by anterior, posterior, lateral, medial, and interosseous talocalcaneal ligaments. The articular capsule, capsula articularis. The articular capsule envelops the joint and consists for the most part of the short fibres which are split up into distinct slips. Between these there is only a weak fibrous investment. The anterior talocalcaneal ligament. Ligamentum talocalcaneum anterius. Anterior calcaneo-astragaloid ligament. The anterior talocalcaneal ligament extends from the front and lateral surface of the neck of the talus to the superior surface of the calcaneus. It forms the posterior boundary of the talocalcaneo-navicular joint and is sometimes described as the anterior interosseous ligament. The posterior talocalcaneal ligament. Ligamentum talocalcaneum posterius. Posterior calcaneo-astragaloid ligament. The posterior talocalcaneal ligament connects the lateral tubercle of the talus with the upper and medial part of the calcaneus. It is a short band, and its fibres radiate from their narrow attachment to the talus. The lateral talocalcaneal ligament. Ligamentum talocalcaneum laterale. External calcaneo-astragaloid ligament. The lateral talocalcaneal ligament is a short, strong fasciculus passing from the lateral surface of the talus, immediately beneath its fibular facet, to the lateral surface of the calcaneus. It is placed in front of, but on a deeper plane than, the calcaneo-fibular ligament, with the fibres of which it is parallel. The medial talocalcaneal ligament. Ligamentum talocalcaneum medial, internal calcaneo-astragaloid ligament. The medial talocalcaneal ligament connects the medial tubercle of the back of the talus with the back of the sustentaculum tali. Its fibres blend with those of the plantar calcaneo-navicular ligament. The interosseous talocalcaneal ligament, ligamentum talocalcaneum interosseum. The interosseous talocalcaneal ligament forms the chief bond of union between the bones. It is, in fact, a portion of the united capsules of the talocalcaneo-navicular and the talocalcaneal joints, and consists of two partially united layers of fibres, one belonging to the former and the other to the latter joint. It is attached above to the groove between the articular facets of the undersurface of the talus, below to a corresponding depression on the upper surface of the calcaneus. It is very thick and strong, being at least 2.5 centimetres in breadth from side to side, and serves to bind the calcaneus and the talus firmly together. Synovial membrane. The synovial membrane lines the capsule of the joint, and is distinct from the other synovial membranes of the tarsus. Movements. The movements permitted between the talus and calcaneus are limited to gliding of the one bone on the other, backward and forward, and from side to side. Talocalcaneo-navicular articulation. Articulatio talocalcaneo-navicularis. This articulation is an arthrodial joint, the rounded head of the talus being received into the concavity formed by the posterior surface of the navicula, the anterior articular surface of the calcaneus, and the upper surface of the plantar calcaneo-navicular ligament. There are two ligaments in this joint, the articular capsule and the dorsal talonavicular. The articular capsule, capsula articularis. The articular capsule is imperfectly developed except posteriorly, where it is considerably thickened and forms with a part of the capsule of the talocalcaneal joint, the strong interosseous ligament which fills in the canal formed by the opposing grooves on the calcaneus and talus, as above mentioned. The dorsal talonavicular ligament, ligamentum talonavicular dorsal. Superior astragalonavicular ligament. This ligament is a broad, thin band which connects the neck of the talus to the dorsal surface of the navicular bone. It is covered by the extensor tendons. The plantar calcaneo-navicular supplies the place of a plantar ligament for this joint. Synovial membrane. The synovial membrane lines all parts of the capsule of the joint. Movements. This articulation permits of a considerable range of gliding movements and some rotation. Its feeble construction allows occasionally of dislocation of the other bones of the tarsus from the talus. Calcaneo-cuboid articulation. Articulatio calcaneo-cuboidea. Articulation of the calcaneus with the cuboid. The ligaments connecting the calcaneus with the cuboid are 5 in number, viz. the articular capsule, the dorsal calcaneo-cuboid, part of the bifurcated, the long plantar, and the plantar calcaneo-cuboid. The articular capsule, capsula articularis. The articular capsule is an imperfectly developed investment containing certain strengthened bands, which form the other ligaments of the joint. The dorsal calcaneo-cuboid ligament. Ligamentum calcaneo-cuboideum dorsal. Superior calcaneo-cuboid ligament. The dorsal calcaneo-cuboid ligament is a thin but broad fasciculus, which passes between the contiguous surfaces of the calcaneus and cuboid on the dorsal surface of the joint. The bifurcated ligament. Ligamentum bifurcatum. Internal calcaneo-cuboid. Interosseous ligament. The bifurcated ligament is a strong band attached behind to the deep hollow of the upper surface of the calcaneus and dividing in front in a Y-shaped manner into the calcaneocuboid and a calcaneonavicular part. The calcaneocuboid part is fixed to the medial side of the cuboid and forms one of the principal bonds between the first and second rows of the tarsal bones. The calcaneonavicular part is attached to the lateral side of the navicula. The long plantar ligament, ligamentum plantari longum, long calcaneocuboid ligament, superficial long plantar ligament. The long plantar ligament is the longest of all the ligaments of the tarsus. It is attached behind to the plantar surface of the calcaneus in front of the tuberosity, and in front to the tuberosity on the plantar surface of the cuboid bone, the more superficial fibres being continued forward to the bases of the second, third, and fourth metatarsal bones. This ligament converts the groove on the plantar surface of the cuboid into a canal for the tendon of the peroneus longus. The plantar calcaneocuboid ligament, ligamentum calcaneocuboidium plantari, short calcaneocuboid ligament, short plantar ligament. The plantar calcaneocuboid ligament lies nearer to the bones than the preceding, from which it is separated by a little areolar tissue. It is a short but wide band of great strength, and extends from the tubercle and the depression in front of it, on the forepart of the plantar surface of the calcaneus, to the plantar surface of the cuboid behind the perineal groove. Synovial membrane. The synovial membrane lines the inner surface of the capsule and is distinct from that of the other tarsal articulations. Movements. The movements permitted between the calcaneus and cuboid are limited to slight gliding movements of the bones upon each other. The transverse tarsal joint is formed by the articulation of the calcaneus with the cuboid, and the articulation of the talus with the navicula. The movement which takes place in this joint is more extensive than that in the other tarsal joints, and consists of a sort of rotation by means of which the foot may be slightly flexed or extended, the sole being at the same time carried medially, inverted, or laterally, everted. The ligaments connecting the calcaneus and navicula. Though the calcaneus and navicula do not directly articulate, they are connected by two ligaments, the calcaneonavicular part of the bifurcated and the plantar calcaneonavicular. The calcaneonavicular part of the bifurcated ligament is described on page 354. The plantar calcaneonavicular ligament, ligamentum calcaneonaviculare plantare, inferior or internal calcaneonavicular ligament, calcaneonavicular ligament. The plantar calcaneonavicular ligament is a broad and thick band of fibres, which connects the anterior margin of the sustenaculum tali of the calcaneus to the plantar surface of the navicula. This ligament not only serves to connect the calcaneus and navicula, but supports the head of the talus, forming part of the articular cavity in which it is received. The dorsal surface of the ligament presents a fibrocartilaginous facet, lined by the synovial membrane, and upon this a portion of the head of the talus rests. Its plantar surface is supported by the tendon of the tibialis posterior. Its medial border is blended with the forepart of the deltoid ligament of the ankle joint. The plantar calcaneonavicular ligament, by supporting the head of the talus, is principally concerned in maintaining the arch of the foot. When it yields, the head of the talus is pressed downward, medialward, and forward by the weight of the body, and the foot becomes flattened, expanded, and turned lateralward, and exhibits the condition known as flat foot. This ligament contains a considerable amount of elastic fibres, so as to give elasticity to the arch and spring to the foot. Hence it is sometimes called the spring ligament. It is supported on its plantar surface by the tendon of the tibialis posterior, which spreads out at its insertion into a number of fasciculi, to be attached to most of the tarsal and metatarsal bones. This prevents undue stretching of the ligament and is a protection against the occurrence of flat foot. Hence, muscular weakness is, in most cases, the primary cause of the deformity. Cuneo-navicular articulation, articulatio cuneo-navicularis, articulation of the navicular with the cuneiform bones. The navicular is connected to the three cuneiform bones by dorsal and plantar ligaments. The dorsal ligaments, ligamenta naviculari cuneiformia dorsalia. The dorsal ligaments are three small bundles, one attached to each of the cuneiform bones. The bundle connecting the navicular with the first cuneiform is continuous around the medial side of the articulation with the plantar ligament which unites these two bones. The plantar ligaments, ligamenta naviculari cuneiformia plantaria. The plantar ligaments have a similar arrangement to the dorsal and are strengthened by slips from the tendon of the tibialis posterior. Synovial membrane. The synovial membrane of these joints is part of the great tarsal synovial membrane. Movements. Mere gliding movements are permitted between the navicular and the cuneiform bones. Cuboideo-navicular articulation. The navicular bone is connected with the cuboid by dorsal, plantar and interosseous ligaments. The dorsal ligament, ligamentum cuboideo-naviculari dorsali. The dorsal ligament extends obliquely forward and lateralward from the navicular to the cuboid bone. The plantar ligament, ligamentum cuboideo-naviculari plantari. The plantar ligament passes nearly transversely between these two bones. The interosseous ligament. The interosseous ligament consists of strong transverse fibres and connects the rough non-articular portions of the adjacent surfaces of the two bones. Synovial membrane. The synovial membrane of this joint is part of the great tarsal synovial membrane. Movements. The movements permitted between the navicular and cuboid bones are limited to a slight gliding upon each other. Intercuneiform and cuneo-cuboid articulations. The three cuneiform bones and the cuboid are connected together by dorsal, plantar and interosseous ligaments. The dorsal ligaments, ligamenta intercuneiformia dorsalia. The dorsal ligaments consist of three transverse bands. One connects the first with the second cuneiform, another the second with the third cuneiform, and another the third cuneiform with the cuboid. The plantar ligaments, ligamenta intercuneiformia plantaria. The plantar ligaments have a similar arrangement to the dorsal and are strengthened by slips from the tendon of the tibialis posterior. The interosseous ligaments, ligamenta intercuneiformia interossea. The interosseous ligaments consist of strong transverse fibres which pass between the rough non-articular portions of the adjacent surfaces of the bones. Synovial membrane. The synovial membrane of these joints is part of the great tarsal synovial membrane. Movements. The movements permitted between these bones
Section 22 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Leanne Howlett. Anatomy of the Human Body, Part 2 by Henry Gray. Tarsometatarsal Articulations. 1F. Tarsometatarsal Articulations. Articulations, Tarsometatarsal. These are arthrodial joints. The bones entering into their formation are the first, second, and third cuneiforms, and the cuboid, which articulate with the bases of the metatarsal bones. The first metatarsal bone articulates with the first cuneiform. The second is deeply wedged in between the first and third cuneiforms, articulating by its base with the second cuneiform. The third articulates with the third cuneiform, the fourth with the cuboid and third cuneiform, and the fifth with the cuboid. The bones are connected by dorsal, plantar, and interosseous ligaments. The dorsal ligaments, ligamenta, tarsometatarsi, dorsalia. The dorsal ligaments are strong, flat bands. The first metatarsal is joined to the first cuneiform by a broad, thin band. The second has 3, one from each cuneiform bone. The third has 1 from the third cuneiform. The fourth has 1 from the third cuneiform and 1 from the cuboid, and the fifth 1 from the cuboid. The plantar ligaments, ligamenta tarsometatarsi plantaria. The plantar ligaments consist of longitudinal and oblique bands, disposed with less regularity than the dorsal ligaments. Those for the first and second metatarsals are the strongest. The second and third metatarsals are joined by oblique bands to the first cuneiform. The fourth and fifth metatarsals are connected by a few fibers to the cuboid. The interosseous ligaments, ligamenta cuneometatarsi interossea. The interosseous ligaments are 3 in number. The first is the strongest and passes from the lateral surface of the first cuneiform to the adjacent angle of the second metatarsal. The second connects the third cuneiform with the adjacent angle of the second metatarsal. The third connects the lateral angle of the third cuneiform with the adjacent side of the base of the third metatarsal. Synovial membrane. The synovial membrane between the first cuneiform and the first metatarsal forms a distinct sac. The synovial membrane between the second and third cuneiforms behind and the second and third metatarsal bones in front is part of the great tarsal synovial membrane. 2 prolongations are sent forward from it, one between the adjacent sides of the second and third, and another between those of the third and fourth metatarsal bones. The synovial membrane between the cuboid and the fourth and fifth metatarsal bones forms the distinct sac. From it a prolongation is sent forward between the fourth and fifth metatarsal bones. Movements. The movements permitted between the tarsal and metatarsal bones are limited to slight gliding of the bones upon each other. Nerve supply. The intertarsal and tarsometatarsal joints are supplied by the deep peroneal nerve. 7G. Intermetatarsal Articulations. Articulations, Intermetatarsi. The base of the first metatarsal is not connected with that of the second by any ligaments. In this respect the great toe resembles the thumb. The bases of the other 4 metatarsals are connected by the dorsal, plantar, and interosseous ligaments. The dorsal ligaments, ligamenta basium, os metatars dorsalia, pass transversely between the dorsal surfaces of the bases of the adjacent metatarsal bones. The plantar ligaments, ligamenta basium, os metatars plantaria. The plantar ligaments have a similar arrangement to the dorsal. The interosseous ligaments, ligamenta basium, os metatars interossea. The interosseous ligaments consist of strong transverse fibers which connect the rough non-articular portions of the adjacent surfaces. Synovial membranes. The synovial membranes between the second and third and the third and fourth metatarsal bones are part of the great tarsal synovial membrane, that between the fourth and fifth is a prolongation of the synovial membrane of the cuboideo-metatarsal joint. Movements. The movement permitted between the tarsal ends of the metatarsal bones is limited to a slight gliding of the articular surfaces upon one another. The heads of all the metatarsal bones are connected together by the transverse metatarsal ligament. The transverse metatarsal ligament. The transverse metatarsal ligament is a narrow band which runs across and connects together the heads of all the metatarsal bones. It is blended anteriorly with the plantar glenoid ligaments of the Metatarsophalangeal articulations. Its plantar surface is concave where the flexor tendons run below it. Above it the tendons of the interossei pass to their insertions. It differs from the transverse metacarpal ligament in that it connects the metatarsal to the others. The synovial membranes in the tarsal and tarsometatarsal joints. The synovial membranes found in the articulations of the tarsus and metatarsus are 6 in number: one for the talocalcaneal articulation, a second for the talocalcaneoavicular articulation, a third for the calcaneocuboid articulation, and a fourth for the cuneoavicular intercuneiform and cuneocuboid articulations, the articulations of the second and third cuneiforms with the bases of the second and third metatarsal bones, and the adjacent surfaces of the bases of the second, third, and fourth metatarsal bones. A fifth for the first cuneiform with the metatarsal bone of the great toe, and a sixth for the articulation of the cuboid with the fourth and fifth metatarsal bones. A small synovial cavity is sometimes found between the contiguous surfaces of the navicular Section 23 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Leanne Howlett. Anatomy of the Human Body, Part 2, by Henry Gray. Metatarsophalangeal Articulations. 7H. Metatarsophalangeal Articulations. Articulations, Metatarsophalangeal. The metatarsophalangeal articulations are of the condyloid kind, formed by the reception of the rounded heads of the metatarsal bones in shallow cavities on the ends of the first phalanges. The ligaments are the plantar and 2 collateral. The plantar ligaments. Ligamenta accessoria plantaria, glenoid ligaments of Cuvier. The plantar ligaments are thick, dense, fibrous structures. They are placed on the plantar surfaces of the joints in the intervals between the collateral ligaments to which they are connected. They are loosely united to the metatarsal bones, but very firmly to the bases of the first phalanges. Their plantar surfaces are intimately blended with the transverse metatarsal ligament, and grooved for the passage of the flexor tendons, the sheaths surrounding which are connected to the sides of the grooves. Their deep surfaces form part of the articular facets for the heads of the metatarsal bones, and are lined by synovial membrane. The collateral ligaments. Ligamenta collateralia, lateral ligaments. The collateral ligaments are strong, rounded cords, placed one on either side of each joint, and attached by one end to the posterior tubercle on the side of the head of the metatarsal bone, and by the other to the contiguous extremity of the phalanx. The place of dorsal ligaments is supplied by the extensor tendons on the dorsal surfaces of the joints. Movements. The movements permitted in the metatarsophalangeal articulations are flexion, extension, abduction, and adduction. 7I. Articulations of the digits. Articulations digitorum pedis, articulations of the phalanges. The interphalangeal articulations are ginglymoid joints, and each has a plantar and 2 collateral ligaments. The arrangement of these ligaments is similar to that in the Metatarsophalangeal articulations. The extensor tendons supply the places of dorsal ligaments. Movements. The only movements permitted in the joints of the digits are flexion and extension. These movements are more extensive between the first and second phalanges than between the second and third. The amount of flexion is very considerable, but extension is limited by the plantar and collateral ligaments. 7J. Arches of the foot. In order to allow it to support the weight of the body in the erect posture with the least expenditure of material, the foot is constructed of a series of arches formed by the tarsal and metatarsal bones and strengthened by the ligaments and tendons of the foot. The main arches are the antero-posterior arches, which may for descriptive purposes be regarded as divisible into 2 types, a medial and a lateral. The medial arch is made up by the calcaneus, the talus, the navicular, the 3 cuneiforms, and the first, second, and third metatarsals. Its summit is at the superior articular surface of the talus, and its 2 extremities or piers, on which it rests in standing, are the tuberosity on the plantar surface of the calcaneus posteriorly, and the heads of the first, second, and third metatarsal bones anteriorly. The chief characteristic of this arch is its elasticity, due to its height and to the number of small joints between its component parts. Its weakest part, that is, the part most liable to yield from overpressure, is the joint between the talus and navicular, but this portion is braced by the plantar calcaneo-navicular ligament, which is elastic and is thus able to quickly restore the arch to its pristine condition when the disturbing force is removed. The ligament is strengthened medially by blending with the deltoid ligament of the ankle joint, and is supported inferiorly by the tendon of the tibialis posterior, which is spread out in a fan-shaped insertion and prevents undue tension of the ligament or such an amount of stretching as would permanently elongate it. The arch is further supported by the plantar aponeuroses, by the small muscles in the sole of the foot, by the tendons of the tibialis anterior and posterior, and peroneus longus, and by the ligaments of all the articulations involved. The lateral arch is composed of the calcaneus, the cuboid, and the 4th and 5th metatarsals. Its summit is at the talocalcaneal articulation, and its chief joint is the calcaneo-cuboid, which possesses a special mechanism for locking and allows only a limited movement. The most marked features of this arch are its solidity and its slight elevation. 2 strong ligaments, the long plantar and the plantar calcaneo-cuboid, together with the extensor tendons and the short muscles of the little toe, preserve its integrity. While these medial and lateral arches may be readily demonstrated as the component antero-posterior arches of the foot, yet the fundamental longitudinal arch is contributed to by both, and consists of the calcaneus, cuboid, 3rd cuneiform, and 3rd metatarsal. All the other bones of the foot may be removed without destroying this arch. In addition to the longitudinal arches, the foot presents a series of transverse arches. At the posterior part of the metatarsus and the anterior part of the tarsus, the arches are complete, but in the middle of the tarsus they present more the characters of half domes, the concavities of which are directed downward and medialward, so that when the medial borders of the feet are placed in apposition a complete tarsal dome is formed. The transverse arches are strengthened by the interosseous, plantar, and dorsal ligaments, by the short muscles of the 1st and 5th toes, especially the transverse head of the adductor hallucis, and by the peroneus longus, whose tendon stretches across.
Section 24 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Ann Walden. Anatomy of the Human Body, Part 2, by Henry Gray. Section 24. Myology. The muscles are connected with the bones, cartilages, ligaments, and skin, either directly or through the intervention of fibrous structures called tendons or aponeuroses. Footnote: the muscles and fascia are described conjointly in order that the student may consider the arrangement of the latter in his dissection of the former. It is rare for the student of anatomy in this country to have the opportunity of dissecting the fascia separately, and it is for this reason, as well as from the close connection that exists between the muscles and their investing sheaths, that they are considered together. Some general observations are first made on the anatomy of the muscles and fascia, the special descriptions being given in connection with the different regions. End footnote. Where a muscle is attached to bone or cartilage, the fibers end in blunt extremities upon the periosteum or perichondrium, and do not come into direct relation with the osseous or cartilaginous tissue. Where muscles are connected with its skin, they lie as a flattened layer beneath it, and are connected with its areolar tissue by larger or smaller bundles of fibers, as in the muscles of the face. The muscles vary extremely in their form. In the limbs they are of considerable length, especially the more superficial ones. They surround the bones and constitute an important protection to the various joints. In the trunk they are broad, flattened, and expanded, and assist in forming the walls of the trunk cavities. Hence the reason of the terms long, broad, short, etc., used in the description of a muscle. There is considerable variation in the arrangement of the fibers of certain muscles with reference to the tendons to which they are attached. In some muscles the fibers are parallel, and run directly from their origin to their insertion. These are quadrilateral muscles, such as the thyrohyoideus. A modification of these is found in the fusiform muscles, in which the fibers are not quite parallel, but slightly curved, so that the muscle tapers at either end. In their actions, however, they resemble the quadrilateral muscles. Secondly, in other muscles the fibers are convergent. Arising by a broad origin, they converge to a narrow or pointed insertion. This arrangement of fibers is found in the triangular muscles, for example, the temporalis. In some muscles, which otherwise would belong to the quadrilateral or triangular type, the origin and insertion are not in the same plane, but the plane of the line of origin intersects that of the line of insertion. Such is the case in the pectineus. Thirdly, in some muscles, for example, the peronei, the fibers are oblique and converge, like the plumes of a quill pen, to one side of a tendon which runs the entire length of the muscle. Such muscles are termed unipinnate. A modification of this condition is found where oblique fibers converge to both sides of a central tendon. These are called bipinnate, and an example is afforded in the rectus femoris. Finally, there are muscles in which the fibers are arranged in curved bundles in one or more planes, as in the sphincters. The arrangement of the fibers is of considerable importance in respect to the relative strength and range of movement of the muscle. Those muscles where the fibers are long and few in number have great range, but diminished strength. Where, on the other hand, the fibers are short and more numerous, there is great power, but lessened range. The names applied to the various muscles have been derived: 1. From their situation, as the tibialis, radialis, ulnaris, peroneus. 2. From their direction, as the rectus abdominis, obliqui capitis, transversus abdominis. 3. From their uses, as flexors, extensors, abductors, etc. 4. From their shape, as the deltoideus, rhomboideus. 5. From the number of their divisions, as the biceps and triceps. 6. From their points of attachment, as the sternocleidomastoideus, sternohyoideus, sternothyroideus. In the description of a muscle, the term origin is meant to imply its more fixed or central attachment, and the term insertion the movable point on which the force of the muscle is applied. But the origin is absolutely fixed in only a small number of muscles, such as those of the face which are attached by one extremity to immovable bones, and by the other to the movable integument. In the greater number the muscle can be made to act from either extremity. In the dissection of the muscles, attention should be directed to the exact origin, insertion, and actions of each, and to its more important relations with surrounding parts. While accurate knowledge of the points of attachment of the muscles is of great importance in the determination of their actions, it is not to be regarded as conclusive. The action of the muscle deduced from its attachments, or even by pulling on it in the dead subject, is not necessarily its action in the living. By pulling, for example, on the brachioradialis in the cadaver, the hand may be slightly supinated when in the prone position, and slightly pronated when in the supine position. But there is no evidence that these actions are performed by the muscle during life. It is impossible for an individual to throw into action any one muscle. In other words, movements, not muscles, are represented in the central nervous system. To carry out a movement, a definite combination of muscles is called into play, and the individual has no power either to leave out a muscle from this combination, or to add one to it. One or more muscle of the combination is the chief moving force. When this muscle passes over more than one joint, other muscles, synergic muscles, come into play to inhibit the movements not required. A third set of muscles, fixation muscles, fix the limb, for example, in the case of the limb movements, and also prevent disturbances of the equilibrium of the body generally. As an example, the movement of the closing of the fist may be considered. 1. The prime movers are the flexores digitorum, flexor pollicis longus, and the small muscles of the thumb. 2. The synergic muscles are the extensores carpi, which prevent flexion of the wrist, while 3. The fixation muscles are the biceps and triceps brachii, which steady the elbow and shoulder. A further point which must be borne in mind in considering the actions of muscles is that in certain positions a movement can be effected by gravity, and in such a case the muscles acting are the antagonists of those which might be supposed to be in action. Thus, in flexing the trunk when no resistance is interposed, the sacrospinales contract to regulate the action of gravity, and the recti abdominis are relaxed. Footnote: consult in this connection the Cronian Lectures, 1903, on Muscular Movements and Their Representation in the Central Nervous System, by Charles E. Beaver, M.D. End footnote. By a consideration of the action of the muscles, the surgeon is able to explain the causes of displacement in various forms of fracture, and the causes which produce distortion in various deformities, and, consequently, to adopt appropriate treatment in each case. The relations, also, of some of the muscles, especially those in immediate apposition with the larger blood vessels, and the surface markings they produce. Section 25 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Ann Walden. Anatomy of the Human Body by Henry Gray, Part 2. Mechanics of Muscle. In studying the mechanical action of muscles, the individual muscle cannot always be treated as a single unit, since different parts of the same muscle may have entirely different actions, as with the pectoralis major, the deltoid, and the trapezius, where the nerve impulses control and stimulate different portions of the muscle in succession or at different times. Most muscles are, however, in a mechanical sense, units. But in either case, the muscle fibers constitute the elementary motor elements. The direction of the muscle pull. In those muscles where the fibers always run in a straight line from origin to insertion in all positions of the joint, a straight line joining the middle of the surface of origin with the middle of the insertion surface will give the direction of the pull. If, however, the muscle or its tendon is bent out of a straight line by a bony process or ligament so that it runs over a pulley-like arrangement, the direction of the muscle pull is naturally bent out of line. The direction of the pull in such cases is from the middle point of insertion to the middle point of the pulley where the muscle or tendon is bent. Muscles, or tendons of muscles, which pass over more than one joint, and pass through more than one pulley, may be resolved, so far as the direction of the pull is concerned, into two or more units or single joint muscles. The tendons of the flexor profundus digitorum, for example, pass through several pulleys formed by fibrous sheaths. The direction of the pull is different for each joint, and varies for each joint according to the position of the bones. The direction is determined in each case, however, by a straight line between the centers of the pulleys on either side of the joint. The direction of the pull in any of the segments would not be altered by any change in the position or origin of the muscle belly above the proximal pulley. The action of the muscle pull on the tendon. Where the muscle fibers are parallel, or nearly parallel, to the direction of the tendon, the entire strength of the muscle contraction acts in the direction of the tendon. In pinnate muscles, however, only a portion of the strength of contraction is efficient in the direction of the tendon, since a portion of the pull would tend to draw the tendon to one side. This is mostly annulled by pressure of surrounding parts. In bipinnate muscles, this lateral pull is counterbalanced. If, for example, the muscle fibers are inserted into the tendon at an angle of 60 degrees, it is easy to determine by the parallelogram of forces that the strength of the pull along the direction of the tendon is equal to 1/2 the muscle pull. Capital T equals tendon, M equals strength and direction of muscle pull, small t equals component acting in the direction of the tendon, phi equals angle of insertion of muscle fibers into tendon, cosine phi equals small t divided by m, cosine angle 60 degrees equals 0.5. 0.5 equals small t over m, t equals 1/2 m. If phi equals 72 degrees 30 minutes, cosine equals 1/3. If phi equals 41 degrees 20 minutes, cosine equals 3/4. If phi equals 90 degrees, cosine equals 0. If phi equals 0 degrees, cosine equals 1. The more acute the angle phi, that is, the smaller the angle, the greater the component acting in the direction of the tendon pull. At 41 degrees 20 minutes, 3/4 of the pull would be exerted in the direction of the tendon, and at 0 degrees the entire strength. On the other hand, the greater the angle, the smaller the tendon component. At 72 degrees 30 minutes, 1/3 the muscle strength would act in the direction of the tendon, and at 90 degrees the tendon component would be nil. The strength of muscles. The strength of a muscle depends upon the number of fibers in what is known as the physiological cross-section, that is, a section which passes through practically all of the fibers. In a muscle with parallel or nearly parallel fibers which have the same direction as the tendon, this corresponds to the anatomical cross-section. but in unipinnate and bipinnate muscles, the physiological cross-section may be nearly at right angles to the anatomical cross-section. Since Huber has shown that muscle fibers in a single fasciculus of a given muscle vary greatly in length, in some fasciculi from 9 mm to 30.4 mm, it is unlikely that the physiological cross-section will pass through all the fibers. Estimates have been made of the strength of muscles, and it is probable that coarse-fibred muscles are somewhat stronger per square centimeter of physiological cross-section than are the fine-fibred muscles. Fick estimates the average strength as about 10 kilograms per square centimeter. This is known as the absolute muscle strength. The total strength of a muscle would be equal to the number of square centimeters in its physiological cross-section times 10 kilograms. The work accomplished by muscles. For practical uses, this should be expressed in kilogram meters. In order to reckon the amount of work which a muscle can perform under the most favorable conditions, it is necessary to know 1. Its physiological cross-section, 2. The maximum shortening, and 3. The position of the joint when the latter is obtained. Work equals lifted weight times height through which the weight is lifted, or work equals tension times distance. Tension equals physiological cross-section times absolute muscle strength. If a muscle has a physiological cross-section of 5 square centimeters, its tension strength equals 5 times 10, or 50 kilograms. If it shortens 5 centimeters, the work equals 50 times 0.05 equals 2.5 kilogram meters. If one determines then the physiological cross-section and multiplies the absolute muscle strength, 10 kilograms, by this, the amount of tension is easily obtained. Then one must determine only the amount of shortening of the muscle for any particular position of the joint, in order to determine the amount of work the muscle can do, since work equals tension times distance. The tension of a muscle is, however, not constant during the course of contraction, but is continually decreasing during contraction. It is at a maximum at the beginning, and gradually decreases. This can be illustrated by the work diagram. AMD ordinate equals tension. AVX abscissa equals shortening. AD equals tension of muscle in extended or antagonistic position. AV equals amount of actual shortening. AM equals tension in mid-position equals absolute muscle strength. DV shows how the tension sinks from maximum in the extended position of the muscle, where it is about double that in the mid-position, M, to nothing on complete contraction. Delta ADV equals work diagram. In reality, the hypotenuse is not straight, but has a concave curve. The delta has the same area as the rectangle AMM'(V). AM equals the average tension. Work equals AM times AV kilogram meters, if the size of the ordinate is expressed in kilograms and the abscissa in meters. Although the muscle works with a changing tension, yet the accomplishment is the same as if it were contracting with the tension of the mid-position. In reality, the amount of work is somewhat greater, since even in extreme contraction the muscle still retains a certain amount of tension, so that the maximum amount of work is more nearly like ADX. We know that a muscle may have an extreme actual shortening of about 80% of its length when the tendon of insertion is cut. The trapezoid ADSV represents more nearly the amount of work, but since there are only approximate values, and ADSV is not much larger than AM'V, we may use the latter. Only the tension and amount of shortening are needed to determine the amount of work of the muscle. Neither the lever arm nor the fiber angle in pinnate muscles need be considered. The diagram shows that the lever arm is of no importance for determining the amount of work the muscle performs. JB and JB1 equals 2 bones jointed at J. CD and EF equal the direction of the pull of 2 muscles of equal cross-section, each having a muscle tension of 1,000 grams. The centers of the attachments are such that perpendiculars J small c and J small e to CD and EF are equal to 40 and 23 millimeters respectively. J small c equals 40 millimeters, and J small e equals 23 millimeters. The static moments are equal to 1,000 times 40 and 1,000 times 23. Therefore the first muscle can hold a much larger load, L, on the bone JB1 at H1, 100 millimeters from J, than the second muscle whose load can be designated as L1. Equilibrium exists for the first muscle if L times 100 equals 1,000 times 40, or L equals 1,000 times 40 over 100 equals 400 grams. For the second muscle, L1 times 100 equals 1,000 times 23. L1 equals 1,000 times 23 over 100 equals 230 grams. If we suppose JB to be fixed, and JB1 to move in the plane of the paper about J, and the muscle CD to shorten 5 millimeters, C small d equals CD minus 5 millimeters, and with the tension of 1,000 grams, JB1 will take the position JB2, and the load, L, will be lifted from H1 to H2. If the second muscle likewise shortens 5 millimeters, then E small f equals EF minus 5 millimeters, and with the tension of 1,000 grams, the bone JB1 will take the position JB3, and the weight or load, L1, will be lifted from H1 to H3. The question now is to prove that the work done is the same in both cases, namely, 5 times 1,000 gram-millimeters. If so, 400 times H1 H2 equals 230 times H1 H3 equals 5,000 gram-millimeters. Since the two radii C small d and C small d prime are very long as compared with the arc small d d prime, we may consider this short arc as a line to CD at small d prime. Likewise the arc small f prime may be considered as a straight line to EF. In the same manner we can consider the short arcs F small f, D small d, H1 H2 and H1 H3 to the line JB1. The sides D small d prime and F small f prime of the delta D small d prime and F small f prime are each 5 millimeters. The lever arm DJ equals 60 millimeters and JF equals 30 millimeters. The delta D small d prime is similar to the delta D small c j. Hence D small d to 5 is to 60 to 40. D small d equals 300 divided by 40. Also H1 H2 to D small d as to 100 to 60. H1 H2 to 300 over 40 as to 100 to 60. H1 H2 equals 300 divided by 24. Hence F small f to 5 is to 30 to 23. F small f equals 150 divided by 23. Also H1 H3 is to F small f as to 100 to 30. H1 H3 is to 150 over 23 as 100 to 30. H1 H3 equals 1500 over 69. 400 times 300 divided by 24 equals 230 times 1500 divided by 69 equals 5000. Thus we see that the work of the two muscles depends on the size of the contraction and on the tension, and not on the lever arm in very small contractions, or in the summation of such contractions, and therefore for large contractions. In the first muscle a large load is moved through a short distance, and in the second muscle a lighter load is moved through a greater distance. The amount of work accomplished by pinnate muscles is not dependent upon the angle of insertion of the muscle fibers into the tendon, as will be seen by the following diagram. T' equals direction of the tendon pull. WA equals direction of muscle fiber before contraction. M' equals direction of muscle fiber after contraction. V equals amount of contraction. M equals tension of the muscle. Phi equals angle of insertion of muscle fiber. T equals tendon component equals M times cosine phi equals the weight carried by the tendon to balance the muscle tension. D equals distance tendon is drawn up. 1. M times V equals work done by the muscle fiber. 2. T times D equals work done by the movement of the tendon. If we consider the distance V as being very short, then the line BC can be dealt with as though it were perpendicular to AC. Then V equals D times cosine phi, or D equals V over cosine phi. Since T equals M times cosine phi, or M equals T over cosine phi. M times V equals T over cosine phi times D times cosine phi equals T times D. If this is true for very minute contractions, it is likewise true for a series of such contraction, and hence for larger contractions. If we assume that phi equals 60 degrees, M equals 10 kilograms, and V equals 5 millimeters, the work done by the contracting muscle fiber equals mv, or 10 times 5 kilogram millimeters. Cosine angle 60 degrees equals 1/2, hence T equals 1/2 M, and D equals V over 1/2 equals 2V. 1/2 M equals 5 kilograms, and 2V equals 10 millimeters. Hence TD equals 50 kilogram millimeters, or the work done by the movement of the tendon in lifting the load of 5 kilograms a distance of 10 millimeters, and is exactly the same as that done by the muscle fiber. The load on the tendon is but 1/2 the tension of the muscle, but the distance through which the load is lifted is twice that of the amount of shortening of the muscle. If phi equals 41 degrees 20 minutes, then cosine phi equals 3 over 4. Hence T equals 3/4 M, and D equals 4/3 V, and TD equals MV. In pinnate muscles, then, we have the rather unexpected condition in which the same amount of movement of the tendon can be accomplished with less contraction of the muscle than in muscles where the fibers have the same direction as the tendon. The action of muscles on joints. If we consider now the action of a single muscle extending over a single joint, in which one bone is fixed and the other movable, we will find that muscle pull can be resolved into two components, a turning component and a friction or pressure component, as shown in Figure 369. DF equals the fixed bone from which the muscle takes its origin. DK equals the movable bone. OI equals a line from the middle of origin to the middle of insertion. IM equals size and direction of the muscle pull. If the parallelogram is constructed with IT and MB perpendicular to DK, then IT equals the turning component, and IB equals the component which acts against the joint. The size of the two components depends upon the insertion angle, phi. The smaller this angle, the smaller the turning component, and the nearer this angle phi is to 90 degrees, the larger the turning component. IT equals IM times sine phi. IB equals IM times cosine phi. If phi equals 90 degrees, cosine phi equals 0, sine phi equals 1, hence IB equals 0, and IT equals IM. If phi equals 0 degrees, cosine phi equals 1, sine phi equals 0, hence IB equals 1, and IT equals 0. With movements of the bone dk, the angle of insertion is continually changing, and hence the two components are changing in value. If, for example, the distance from origin O to the joint D is greater than from D to I, as in the brachialis or biceps muscles, the turning component increases until the insertion angle phi equals 90 degrees, which is the optimum angle for muscle action, while the pressure component gradually decreases. If the movement continues beyond this point, the turning component gradually decreases, and the pressure component changes into a component which tends to draw the two bones apart, and which gradually increases. When the bone dk is in such a position that the insertion angle phi equals 41 degrees 20 minutes, the pressure component equals 3/4 Im, and the turning component 1/4 Im. At 60 degrees the two components are equal. At 90 degrees the pressure component equals 0, and the turning component equals Im. And at 131 degrees 21 minutes, the pressure component has been converted into a pulling component, equals 1/4 Im, and the turning component equals 3/4 Im. If, for example, the distance from the origin O to the joint D is less than the distance from the insertion I to the joint D, as in the brachioradialis muscle, the insertion angle increases with the flexion but never reaches 90 degrees. The turning component gradually increases to a certain point, and then slowly decreases, as shown in Figure 371, while the pressure component gradually decreases and then slowly increases. It always remains large, and its action is always in the direction of the joint. Levers. The majority of the muscles of the body act on bones as the power on levers. Levers of the 3 class are the most common, as the action of the biceps and the brachialis muscles on the forearm bones. Levers of the 1 class are found in movements of the head, where the occipito-atlantal joint acts as the fulcrum, and the muscles on the back of the neck as the power. Another common example is the foot, when one raises the body by contracting the gastrocnemius and soleus. Here the ankle joint acts as the fulcrum, and the pressure of the toes on the ground as the weight. This is frequently, though wrongly, considered a lever of the 2 class. If one were to stand on one's head with the legs up, and with a weight on the plantar surface of the toes, it is easy to see that we would have a lever of the 1 class if the weight were raised by contraction of the gastrocnemius muscle. The confusion has arisen by not considering the fact that the fulcrum and the power in all 3 classes of levers must have a common basis of action, as shown in Figure 372. If the fulcrum rests on the earth, the power must either directly or indirectly push from the earth, or be attached to the earth, either by gravity or otherwise, if it pulls toward the earth. If the power were attached to the weight, no lever action.
Section 26 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 2, by Henry Gray. Development of the muscles. Both the cross-striated and smooth muscles, with the exception of a few that are of ectodermal origin, arise from the mesoderm. The intrinsic muscles of the trunk are derived from the myotomes, while the muscles of the head and limbs differentiate directly from the mesoderm. The myotomic muscles. The intrinsic muscles of the trunk, which are derived directly from the myotomes, are conveniently treated in 2 groups. the deep muscles of the back, and the thoracoabdominal muscles. The deep muscles of the back extend from the sacral to the occipital region and vary much in length and size. They act chiefly on the vertebral column. The shorter muscles, such as the interspinalis, intertransversarii, the deeper layers of the multifidus, the rotatores, levatores costarum, obliquus capitis inferior, obliquus capitis superior, and rectus capitis posterior minor, which extend between the adjoining vertebrae, retain the primitive segmentation of the myotomes. Other muscles, such as the splenius capitis, splenius cervicis, sacrospinalis semispinalis, multifidus, iliocostalis, longissimus, spinalis semispinalis, and rectus capitis posterior major, which extend over several vertebrae, are formed by the fusion of successive myotomes and the splitting into longitudinal columns. The fascia lumbodorsalis develops between the true myotomic muscles and the more superficial ones which migrate over the back, such as the trapezius, rhomboideus, and latissimus. The anterior vertebral muscles, the longus colli, longus capitis, rectus capitis anterior, and rectus capitis lateralis, are derived from the ventral part of the cervical myotomes, as are probably also the scaleni. The thoracoabdominal muscles arise through the ventral extension of the thoracic myotomes into the body wall. This process takes place coincident with the ventral extension of the ribs. In the thoracic region, the primitive myotomic segments still persist as the intercostal muscles, but over the abdomen, these ventral myotomic processes fuse into a sheet which splits in various ways to form the rectus, the obliquus externus and internus, and the transversalis. Such muscles as the pectoralis major and minor and the serratus anterior do not belong to the above group. The ventrolateral muscles of the neck. The intrinsic muscles of the tongue, the infrahyoid muscles, and the diaphragm are derived from a more or less continuous premuscle mass which extends on each side from the tongue into the lateral region of the upper half of the neck, and into it early extend the hypoglossal and branches of the upper cervical nerves. The two halves which form the infrahyoid muscles and the diaphragm are at first widely separated from each other by the heart. As the latter descends into the thorax, the diaphragmatic portion of each lateral mass is carried with its nerve down into the thorax, and laterally placed infrahyoid muscles move towards the midventral line of the neck. Muscles of the shoulder girdle and arm. The trapezius and sternocleidomastoid arise from a common premuscle mass in the occipital region, just caudal to the last branchial arch. As the mass increases in size, it spreads downward to the shoulder girdle, to which it later becomes attached. It also spreads backward and downward to the spinous processes, gaining attachment at the still later period. The levator scapulae, serratus anterior, and the rhomboids arise from premuscle tissue in the lower cervical region and undergo extensive migration. The latissimus dorsi and teres major are associated in their origin from the premuscle sheath of the arm, as are also the two pectoral muscles when the arm bud lies in the lower cervical region. The intrinsic muscles of the arm develop in situ from the mesoderm of the arm bud, and probably do not receive cells or buds from the myotomes. The nerves enter the arm bud when it still lies in the cervical region, and as the arm shifts caudally over the thorax, the lower cervical nerves which unite to form the brachial plexus acquire a caudal direction. The muscles of the leg. The muscles of the leg, like those of the arm, develop in situ from the mesoderma of the leg bud, the myotomes apparently taking no part in their formation. The muscles of the head. The muscles of the orbit arise from the mesoderm over the dorsal and caudal sides of the optic stalk. The muscles of mastication arise from the mesoderm of the mandibular arch. The mandibular division of the trigeminal nerve enters this premuscle mass before it splits into the temporal, masseter, and pterygoideus. The facial muscles, muscles of expression, arise from the mesoderm of the hyoid arch. The facial nerve enters this mass before it begins to split, and as the muscle mass spreads out over the face and head and neck, it splits more or less incompletely into the various muscles. The early differentiation of the muscular system apparently goes on independently of the nervous system, and only later does it appear that muscles are dependent on the functional stimuli of the nerves for their continued existence and growth. Although the nervous system does not influence muscle differentiation, the nerves, owing to their early attachments to the muscle rudiments, are in a general way indicators of the position of origin of many of the muscles, and likewise, in many instances, the nerves indicate the paths along which the developing muscles have migrated during development. The muscle of the diaphragm, for example, has its origin in the region of the fourth and fifth cervical segments. The phrenic nerve enters the muscle mass while the latter is in this region, and is drawn out as the diaphragm migrates through the thorax. The trapezius and sternocleidomastoids mastoids arise in the lateral occipital region as a common muscle mass, into which, at a very early period, the nervus accessoris extends, and as the muscle mass migrates and extends caudally, the nerve is carried with it. The pectoralis major and minor arise in the cervical region, receive their nerves while in this position, and, as the muscle mass migrates and extends caudally over the thorax, the nerves are carried along. The latissimus dorsi and serratus anterior are excellent examples of migrating muscles, whose nerve supply indicates their origin in the cervical region. The rectus abdominis and the other abdominal muscles migrate or shift from a lateral to a ventrolateral or abdominal position, carrying with them the nerves. The facial nerve, which early enters the common facial muscle mass of the second branchial or hyoid arch, is dragged about with the muscle as it spreads over the head and face and neck, and as the muscle splits into the various muscles of expression, the nerve is correspondingly split. The mandibular division of the trigeminal nerve enters at an early time the muscle mass in the mandibular arch, and as this mass splits and migrates apart to form the muscles of mastication, the nerve splits into its various branches. The nerve supply then serves as a key to the common origin of certain groups of muscles. The muscles supplied by the oculomotor nerve arise from a single mass in the eye region. The lingual muscles arise from a common mass supplied by the hypoglossal nerve. Striped or voluntary muscle. Striped or voluntary muscle is composed of bundles of fibers, each enclosed in a delicate web called the perimysium, in contradistinction to the sheath of areolar tissue which invests the entire muscle, the epimysium. The bundles are termed fasciculi. They are prismatic in shape, of different sizes in different muscles, and are for the most part placed parallel to one another, though they have a tendency to converge towards their tendinous attachments. Each fasciculus is made up of a strand of fibers, which also run parallel with each other, and are separated from one another by a delicate connective tissue derived from the perimysium and termed endomysium. This does not form the sheath of fibers, but serves to support the blood vessels and nerves ramifying between them. A muscle fiber may be said to consist of a soft contractile substance enclosed in the tubular sheath, named by Momin the sarcolemma. The fibers are cylindrical or prismatic in shape, and are of no great length, not exceeding, as a rule, 40 millimeters. Huber has recently found that the muscle fibers in the adductor muscle of the thigh of the rabbit vary greatly in length, even in the same fasciculus. In a fasciculus 40 millimeters in length, the fibers varied from 30.4 millimeters to 9 millimeters in length. Their breadth varies in man from 0.01 to 0.1 millimeters. As a rule, the fibers do not divide or anastomose, but occasionally, especially in the tongue and facial muscles, they may be seen to divide into several branches. In the substance of the muscle, the fibers end by tapering extremities which are joined to the ends of other fibers by the sarcolemma. At the tendinous end of the muscle, the sarcolemma appears to blend with a small bundle of fibers into which the tendon becomes subdivided, while the muscular substance ends abruptly and can be readily made to retract from the point of junction. The areolar tissue between the fibers appears to be prolonged more or less into the tendon, so as to form the kind of sheath around the tendon bundles for a longer or shorter distance. When muscle fibers are attached to skin or mucous membranes, their fibers become continuous with those of the areolar tissue. The sarcolemma, or tubular sheath of the fiber, is a transparent, elastic, and apparently homogeneous membrane of considerable toughness, so that it sometimes remains entire when the included substance is ruptured. On the internal surface of the sarcolemma in Mammalia, and also in the substance of the fiber in frogs, elongated nuclei are seen, and in connection with these is a little granular protoplasm. Upon examination of a voluntary muscle fiber by transmitted light, it is found to be marked by alternate light and dark bands or striae, which pass transversely across the fiber. When examined by polarized light, the dark bands are found to be doubly refracting, anisotropic, while the clear stripes are single refracting, isotropic. The dark and light bands are of nearly equal breadth and alternate with great regularity. They vary in breadth from about 1 to 2 microns. If the surface be carefully focused, rows of granules will be detected at the points of junction of the dark and light bands, and very fine longitudinal lines may be seen running through the dark bands and joining these granules together. By treating the specimen with certain reagents, for example chloride of gold, fine lines may be seen running transversely between the granules and uniting them together. This appearance is believed to be due to a reticulum or network of interstitial substance lying between the contractile portions of the muscle. The longitudinal striation gives the fiber the appearance of being made up of a bundle of fibers which have been termed sarcostyles or muscle columns, and if the fiber be hardened in alcohol, it can be broken up longitudinally and the sarcostyles separated from each other. The reticulum, with its longitudinal and transverse meshes, is called sarcoplasm. In a transverse section, the muscle fiber is seen to be divided into a number of areas called the areas of Cohnheim, more or less polyhedral in shape and consisting of the transversely divided sarcostyles surrounded by transparent sarcoplasm. Upon closer examination, and by somewhat altering the focus, the appearances become more complicated and are susceptible of various interpretations. The transverse striation, which appears as a mere alternating of dark and light bands, is resolved into the appearance which shows a series of broad dark bands separated by light bands, each of which is divided into 2 by a dark dotted line. This line is termed Dobbe's line or Krauss's membrane, because it was believed by Krauss to be an actual membrane, continuous with the sarcolemma, and dividing the light band into 2 compartments. In addition to the membrane of Krauss, fine clear lines may be made out, with a sufficiently high power, crossing the center of the dark band. These are known as the lines of Henson. Schaefer has worked out the minute anatomy of muscle fiber, particularly in the wing muscle of insects, which are peculiarly adapted for this purpose on account of the large amount of interstitial sarcoplasm which separates the sarcostyles. In the following description, that given by Schaefer will be closely followed. A sarcostyle may be said to be made up of succession portions, each of which is termed a sarcomere. The sarcomere is situated between 2 membranes of Krauss and consists of 1. A central dark part, which forms a portion of the dark band of the whole fiber and is named a sarcous element. This sarcous element really consists of 2 parts, superimposed one on top of the other, and when the fiber is stretched, these 2 parts become separated from each other at the line of Henson. 2. On either side of this central dark portion is a clear layer, most visible when the fiber is extended. This is situated between the dark center and the membrane of Krauss, and when the sarcomeres are joined together to form the sarcostyle, constitutes the light band of the striated muscle fiber. When the sarcostyle is extended, the clear intervals are well marked and plainly to be seen. When, on the other hand, the sarcostyle is contracted, that is to say, when the muscle is in the state of contraction, these clear portions are very small, or they may have disappeared altogether. When the sarcostyle is stretched to its full extent, Not only is the clear portion well marked, but the dark portion, the sarcus element, is separated into its two constituents along the line of Henson. The sarcus element does not lie free in the sarcomere, for when the sarcostyle is stretched so as to render the clear portion visible, very fine lines, which are probably septa, may be seen running through it from the sarcus element to the membrane of Krauss. Schaefer explains these phenomena in the following way. He considers that each sarcus element is made up of a number of longitudinal channels, which open into the clear part towards the membrane of Krauss, but are closed at the line of Henson. When the muscular fiber is contracted, the clear part of the muscular substance is driven into these channels or tubes, and is therefore hidden from sight. But at the same time, it swells up the sarcus element and widens and shortens the sarcomere. When, on the other hand, the fiber is extended, this clear substance is driven out of the tubes and collects between the sarcus elements and the membrane of Krauss, and gives the appearance of the light part between these two structures. By this means, it elongates and narrows the sarcomere. If this view be true, it is a matter of great interest, and, as Schaefer has shown, harmonizes the contraction of muscle with the amoeboid action of protoplasm. In an amoeboid cell, there is a framework of spongioplasm which stains with hematoxylin and similar reagents, enclosing in its meshes a clear substance, hyaloplasm, which will not stain with these reagents. Under stimulation, the hyaloplasm passes into the pores of the spongioplasm. Without stimulation, it tends to pass out, as in the formation of pseudopodia. In muscle, there is the same thing, that is, a framework of spongioplasm staining with hematoxylin, the substance of the sarcus element, and this encloses a clear hyaloplasm, the clear substance of the sarcomere, which resists staining with this reagent. During contraction of the muscle, that is stimulation, this clear substance passes into the pores of the spongioplasm, while during extension of the muscle, that is when there's no stimulation, it tends to pass out of the spongioplasm. In this way, the contraction is brought about. Under stimulation, the protoplasmic material, the clear substance of the sarcomere, recedes into the sarcus elements, causing the sarcomere to widen out and shorten. The contraction of the muscle is merely the sum total of this widening out and shortening of these bodies. Vessels and nerves of striped muscle. The capillaries of striped muscles are very abundant and form a sort of rectangular network, the branches of which run longitudinally in the endomysium between the muscle fibers, and are joined at short intervals by transverse anastomosing branches. In the red muscles of the rabbit, dilatations occur on the transverse branches of the capillary network. The larger vascular channels, arteries and veins, are found only in the perimysium, between the muscular fasciculi. Nerves are profusely distributed to striped muscle. Their mode of termination is described on page 730. The existence of lymphatic vessels in striped muscle has not been ascertained, though they have been found in tendons and in the sheaths of muscles. Ossification of muscular tissue as a result of repeated strain or injury is not infrequent. It is oftenest found about the tendon of the adductor longus and vastus medialis in horsemen, or in the pectoralis major and deltoideus of soldiers. It may take the form of exostoses firmly fixed to the bone, for example, quote, rider's bone, end quote, on the femur, or of layers or spicules of bone lying in the muscles or their fascia and tendons. Bucy states that these bony deposits are preceded by a hemorrhagic myositis due to injury, the effused blood organizing and being finally converted into bone. In the rarer disease, progressive myositis ossificans, there is an unexplained tendency for practically any of the voluntary muscles to become converted into solid and brittle bony masses, which are completely rigid. End of section 26. Recording by M.
Section 27 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 2 by Henry Gray. Tendons, Aponeuroses, and Fasciae. Tendons are white, glistening, fibrous cords, varying in length and thickness, sometimes round, sometimes flattened, and devoid of elasticity. They consist almost entirely of white fibrous tissue, the fibrils of which have an undulating course parallel with each other, and are firmly united together. When boiled in water, tendon is almost completely converted into gelatin, the white fibres being composed of the albuminoid collagen, which is often regarded as the anhydride of gelatin. They are very sparingly supplied with blood vessels, the smaller tendons presenting in their interior no trace of them. Nerves supplying tendons have special modifications of their terminal fibres, named organs of Golgi. Aponeuroses are flattened or ribbon-shaped tendons of a pearly white colour, iridescent, glistening, and similar in structure to the tendons. They are only sparingly supplied with blood vessels. The tendons and aponeuroses are connected, on the one hand with the muscles, and on the other hand with the movable structures, such as the bones, cartilages, ligaments, and fibrous membranes, for instance, the sclera. Where the muscular fibres are in a direct line with those of the tendon or aponeurosis, the two are directly continuous. But where the muscular fibres join the tendon or aponeurosis at an oblique angle, they end, according to Kolliker, in rounded extremities which are received into the corresponding depressions on the surface of the latter, the connective tissue between the muscular fibres being continuous with that of the tendon. The latter mode of attachment occurs in all the peniform and bipeniform muscles, and in those muscles the tendons of which commence in a membranous form, as the gastrocnemius and soleus. The fasciae are fibro-areolar or aponeurotic laminae, of variable thickness and strength, found in all regions of the body, investing the softer and more delicate organs. During the process of development, many of the cells of the mesoderm are differentiated into bones, muscles, vessels, etc. The cells of the mesoderm which are not so utilized form an investment for these structures and are differentiated into the true skin and the fasciae of the body. They have been subdivided from the situations in which they occur into superficial and deep. The superficial fascia is found immediately beneath the integument over almost the entire surface of the body. It connects the skin with the deep fascia and consists of fibro-areolar tissue, containing in its meshes pellicles of fat in varying quantity. Fibro-areolar tissue is composed of white fibres and yellow elastic fibres intercrossing in all directions, and united together by a homogeneous cement or ground substance, the matrix. The cells of areolar tissue are of four principal kinds. 1. Flattened lamellar cells, which may be either branched or unbranched. The branched lamellar cells are composed of clear cytoplasm and contain oval nuclei. The processes of these cells may unite so as to form an open network, as in the cornea. The unbranched cells are joined edge to edge like the cells of an epithelium. The tendon cells, presently to be described, are examples of this variety. 2. Plasmatocytes, large irregular cells characterized by the presence of granules or vacuoles in their protoplasm and containing oval nuclei. 3. Granule cells, Mastzellen, which are ovoid or spheroidal in shape. They are formed of a soft protoplasm containing granules which are basophil in character. 4. Plasma cells of Waldeyer, usually spheroidal and distinguished by containing a vacuolated protoplasm. The vacuoles are filled with fluid, and the protoplasm between the spaces is clear, with occasionally a few scattered basophil granules. In addition to these four typical forms of connective tissue corpuscles, areolar tissue may be seen to possess wandering cells, i.e. leukocytes, which have emigrated from the neighbouring vessels. In some instances, as in the choroid coat of the eye, cells filled with granules of pigment cells, are found. The cells lie in spaces in the ground substance between the bundles of fibres, and these spaces may be brought into view by treating the tissue with nitrate of silver and exposing it to the light. This will colour the ground substance and leave cell spaces unstained. Fat is entirely absent in the subcutaneous tissue of the eyelids, of the penis and scrotum, and of the labia minora. It varies in thickness in different parts of the body. In the groin it is so thick that it may be subdivided into several laminae. Beneath the fatty layer there is generally another layer of superficial fascia, comparatively devoid of adipose tissue, in which the trunks of the subcutaneous vessels and nerves are found, as the superficial epigastric vessels in the abdominal region, the superficial veins in the forearm, the saphenous veins in the leg and thigh, and the superficial lymph glands. Certain cutaneous muscles are also situated in the superficial fascia, as the platysma in the neck, and the orbicularis oculi around the eyelids. This fascia is most distinct at the lower part of the abdomen, perineum, and extremities. It is very thin in those regions where muscular fibres are inserted into the integument, as on the side of the neck, the face, and around the margin of the anus. It is very dense in the scalp, in the palms of the hands and soles of the feet, forming a fibro-fatty layer which binds the integument firmly to the underlying structures. The superficial fascia connects the skin to the subjacent parts, facilitates the movement of the skin, serves as a soft nidus for the passage of vessels and nerves to the integument, and retains the warmth of the body, since the fat contained in its areolae is a bad conductor of heat. The deep fascia is a dense, inelastic, fibrous membrane, forming sheaths for the muscles, and in some cases affording them broad surfaces for attachment. It consists of shining tendinous fibres, placed parallel with one another, and connected together by other fibres disposed in a rectilinear manner. It forms a strong investment which not only binds down collectively the muscles in each region, but gives a separate sheath to each, as well as to the vessels and nerves. The fasciae are thick in unprotected situations, as on the lateral side of a limb, and thinner on the medial side. The deep fasciae assist the muscles in their actions by the degree of tension and pressure they make upon their surfaces. The degree of tension and pressure is regulated by the associated muscles, as, for instance, by the tensor fasciae latae and gluteus maximus in the thigh, by the biceps in the upper and lower extremities, and palmaris longus in the hand. In the limbs the fasciae not only invest the entire limb, but give off septa which separate the various muscles, and are attached to the periosteum. These prolongations of fasciae are usually spoken of as intermuscular septa. The fasciae and muscles may be arranged, according to the general division of the body, Section 28 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 2 by Henry Gray. Muscles of the scalp, eyelid, and nose. 4. The fasciae and muscles of the head. A. The muscles of the scalp. Epicranius. The skin of the scalp. This is thicker than in any other part of the body. It is intimately adherent to the superficial fascia, which attaches it firmly to the underlying aponeuroses and muscle. Movements of the muscle move the skin. The hair follicles are very closely set together and extend throughout the whole thickness of the skin. It also contains a number of sebaceous glands. The superficial fascia in the cranial region is a firm, dense, fibro-fatty layer, intimately adherent to the integument, and to the epicranius and its tendinous aponeurosis. It is continuous behind with a superficial fascia at the back of the neck and, laterally, is continued over the temporal fascia. It contains between its layers the superficial vessels and nerves and much granular fat. The epicranius, occipitofrontalis, is a broad, muscular fibrous layer which covers the whole of one side of the vertex of the skull from the occipital bone to the eyebrow. It consists of two parts, the occipitalis and the frontalis, connected by an intervening tendinous aponeurosis, the gallia aponeurotica. The occipitalis, thin and quadrilateral in form, arises by tendinous fibres from the lateral 2/3 of the superior nuchal line of the occipital bone and from the mastoid part of the temporal. It ends in the gallia aponeurotica. The frontalis is thin, of a quadrilateral form and intimately adherent to the superficial fascia. It is broader than the occipitalis and its fibres are longer and paler in colour. It has no bony attachments. Its medial fibres are continuous with those of the procerus. Its immediate fibres blend with the corrugator and orbicularis oculi, and its lateral fibres are also blended with the latter muscle over the zygomatic process of the frontal bone. From these attachments the fibres are directed upward, and join the gallia aponeurotica below the coronal suture. The medial margins of the frontalis are joined together for some distance above the root of the nose, but between the occipitalis there is a considerable, though variable, interval, occupied by the gallia aponeurotica. The gallia aponeurotica, epicranial aponeurosis, covers the upper part of the cranium. Behind it is attached, in the interval between its union with the occipitalis, to the external occipital protuberance and highest nuchal lines of the occipital bone. In front, it forms a short and narrow prolongation between its union with the frontalis. On either side it gives origin to the auricularis anterior and superior. In this situation it loses its aponeurotic character, and is continued over the temporal fascia to the zygomatic arch as a layer of laminated areolar tissue. It is closely connected to the integument by the firm, dense, fibro-fatty layer which forms the superficial fascia of the scalp. It is attached to the pericranium by loose cellular tissue, which allows the aponeurosis, carrying with it the integument, to move through a considerable distance. Variations. Both frontalis and occipitalis vary considerably in size and in extent of attachment. Either may be absent. Fusion of the frontalis to skin has been noted. Nerves. The frontalis is supplied by the temporal branches of the facial nerve, and the occipitalis by the posterior auricular branch of the same nerve. Actions. The frontalis raise the eyebrows and the skin over the root of the nose, and at the same time draw the scalp forward, throwing the integument of the forehead into transverse wrinkles. The occipitalis draw the scalp backward. By bringing alternately into action the frontalis and occipitalis, the entire scalp may be moved forward and backward. In the ordinary action of the muscles, the eyebrows are elevated, and at the same time the aponeurosis is fixed by the occipitalis, thus giving the face the expression of surprise. If the action be exaggerated, the eyebrows are still further raised, and the skin of the forehead thrown into transverse wrinkles, as in the expression of fright or horror. A thin, muscular slip, the transversus nuchae, is present in a considerable proportion, 25%, of cases. It arises from the external occipital protuberance or from the superior nuchal line, either superficial or deep to the trapezius. It is frequently inserted with the auricularis posterior, but may join the posterior edge of the sternocleidomastoideus. 4b. The muscles of the eyelid. The muscles of the eyelids are levator palpebrae superioris, orbicularis oculi, corrugator. The levator palpebrae superioris is described with the anatomy of the eye. The orbicularis oculi, orbicularis palpebrarum, arises from the nasal part of the frontal bone, from the frontal process of the maxilla in front of the lacrimal groove, and from the anterior surface and borders of a short fibrous band, the medial palpebral ligament. From this origin the fibres are directed lateralward, forming a broad and thin layer, which occupies the eyelids of palpebrae, surrounds the circumference of the orbit, and spreads over the temple and downward on the cheek. The palpebral portion of the muscle is thin and pale. It arises from the bifurcation of the medial palpebral ligament, forms a series of concentric curves, and is inserted into the lateral palpebral raphe. The orbital portion is thicker and of a reddish colour. Its fibres form a complete ellipse without interruption at the lateral palpebral commissure. The upper fibres of this portion blend with frontalis and corrugator. The lacrimal part, tensor tarsi, is a small thin muscle, about 6 mm in breadth and 12 mm in length, situated behind the medial palpebral ligament and lacrimal sac. It arises from the posterior crest and adjacent part of the orbital surface of the lacrimal bone, and, passing behind the lacrimal sac, divides into two slips, upper and lower, which are inserted into the superior and inferior tarsi, medial to the puncta lacrimalia. Occasionally it is very indistinct. The medial palpebral ligament, tendo oculi, about 4 mm in length and 2 mm in breadth, is attached to the frontal process of the maxilla in front of the lacrimal groove. Crossing the lacrimal sac, it divides into two parts, upper and lower, each attached to the medial end of the corresponding tarsus. As the ligament crosses the lacrimal sac, a strong aponeurotic lamina is given off from its posterior surface. This expands over the sac and is attached to the posterior lacrimal crest. The lateral palpebral raphe is a much weaker structure than the medial palpebral ligament. It is attached to the margin of the frontosphenoidal process of the zygomatic bone, and passes medialward to the lateral commissure of the eyelids, where it divides into two slips, which are attached to the margins of the respective tarsi. The corrugator. Note 79. The corrugator is not recognized as a separate muscle in the basal nomenclature. End of note 79. Corrugator supercilii is a small, narrow, pyramidal muscle placed at the medial end of the eyebrow, beneath the frontalis and orbicularis oculi. It arises from the medial end of the superciliary arch, and its fibres pass upward and lateralward, between the palpebral and orbital portions of the orbicularis oculi, and are inserted into the deep surface of the skin above the middle of the orbital arch. Nerves. The orbicularis oculi and corrugator are supplied by the facial nerve. Actions. The orbicularis oculi is the sphincter muscle of the eyelids. The palpebral portion acts involuntarily, closing the lids gently, as in sleep or in blinking. The orbital portion is subject to the will. When the entire muscle is brought into action, the skin of the forehead, temple, and cheek is drawn toward the medial angle of the orbit, and the eyelids are firmly closed, as in photophobia. The skin thus drawn upon is thrown into folds, especially radiating from the lateral angle of the eyelids. These folds become permanent in old age, and form the so-called crow's feet. The levator palpebrae superioris is the direct antagonist of this muscle. It raises the upper eyelid and exposes the front of the bulb of the eye. Each time the eyelids are closed through the action of the orbicularis, the medial palpebral ligament is tightened. The wall of the lacrimal sac is thus drawn lateralward and forward, so that a vacuum is made in it and the tears are sucked along the lacrimal canals into it. The lacrimal part of the orbicularis oculi draws the eyelids and the ends of the lacrimal canals medialward and compresses them against the surface of the globe of the eye, thus placing them in the most favourable situation for receiving the tears. It also compresses the lacrimal sac. The corrugator draws the eyebrow downward and medialward, producing the vertical wrinkles of the forehead. It is the frowning muscle, and may be regarded as the principal muscle in the expression of suffering. 4c. The muscles of the nose. The muscles of the nose comprise procerus, nasalis, depressor septi, dilator naris posterior, dilator naris anterior. The procerus, pyramidalis nasi, is a small pyramidal slip arising by tendinous fibres from the fascia covering the lower part of the nasal bone and upper part of the lateral nasal cartilage. It is inserted into the skin over the lower part of the forehead between the two eyebrows, its fibres decussating with those of the frontalis. The nasalis compressor naris consists of two parts, transverse and alar. The transverse part arises from the maxilla, above and lateral to the incisive fossa. Its fibres proceed upward and medialward, expanding into a thin aponeurosis which is continuous on the bridge of the nose with that of the muscle of the opposite side, and with the aponeurosis of the procerus. The alar part is attached by one end to the greater alar cartilage, and by the other to the integument at the point of the nose. The depressor septi, depressor alae nasi, arises from the incisive fossa of the maxilla. Its fibres ascend to be inserted into the septum and back part of the alar of the nose. It lies between the mucous membrane and muscular structure of the lip. The dilator naris posterior is placed partly beneath the quadratus labii superioris. It arises from the margin of the nasal notch of the maxilla, and from the lesser alar cartilages, and is inserted into the skin near the margin of the nostril. The dilator naris anterior is a delicate fasciculus, passing from the greater alar cartilage to the integument near the margin of the nostril. It is situated in front of the preceding. Variations. These muscles vary in size and strength, or may be absent. Nerves. All the muscles of this group are supplied by the facial nerve. Actions. The procerus draws down the medial angle of the eyebrows and produces transverse wrinkles over the bridge of the nose. The two dilatores enlarge the aperture of the nares. Their action in ordinary breathing is to resist the tendency of the nostrils to close from atmospheric pressure, but in difficult breathing, as well as in some emotions, such as anger, they contract strongly. The depressor septi is a direct antagonist of the other muscles of the nose, drawing the alar of the nose downward, and thereby constricting the aperture of the nares. The nasalis Section 29 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 2 by Henry Gray. Muscles of the Mouth. 4D. The muscles of the mouth. The muscles of the mouth are quadratus labii superioris, quadratus labii inferioris, caninus, triangularis, zygomaticus, buccinator, mentalis, orbicularis oris, risorius. The quadratus labii superioris is a broad sheet, the origin of which extends from the side of the nose to the zygomatic bone. Its medial fibres form the angular head, which arises by a pointed extremity from the upper part of the frontal process of the maxilla, and passing obliquely downward and lateralward divides into two slips. One of these is inserted into the greater alar cartilage and skin of the nose. The other is prolonged into the lateral part of the upper lip, blending with the infraorbital head and with the orbicularis oris. The intermediate portion or infraorbital head arises from the lower margin of the orbit immediately above the infraorbital foramen, some of its fibres being attached to the maxilla, others to the zygomatic bone. Its fibres converge, to be inserted into the muscular substance of the upper lip between the angular head and the caninus. The lateral fibres, forming the zygomatic head, arise from the malar surface of the zygomatic bone immediately behind the zygomatico-maxillary suture and pass downward and medialward to the upper lip. The caninus, levator anguli oris, arises from the canine fossa, immediately below the infraorbital foramen. Its fibres are inserted into the angle of the mouth, intermingling with those of the zygomaticus, triangularis, and orbicularis oris. The zygomaticus major, arises from the zygomatic bone, in front of the zygomatico-temporal suture, and descending obliquely with a medial inclination, is inserted into the angle of the mouth, where it blends with the fibres of the caninus, orbicularis oris, and triangularis. Nerves. This group of muscles is supplied by the facial nerve. Actions. The quadratus labii superioris is the proper elevator of the upper lip, carrying it at the same time a little forward. Its angular head acts as a dilator of the nares. The infraorbital and zygomatic heads assist in forming the nasolabial furrow, which passes from the side of the nose to the upper lip and gives to the face an expression of sadness. When the whole muscle is in action, it gives to the countenance an expression of contempt and disdain. The quadratus labii superioris raises the angle of the mouth and assists the caninus in producing the nasolabial furrow. The zygomaticus draws the angle of the mouth backward and upward, as in laughing. The mentalis, levator menti, is a small conical fasciculus, situated at the side of the frenulum of the lower lip. It arises from the incisive fossa of the mandible, and descends to be inserted into the integument of the chin. The quadratus labii inferioris, depressor labii inferioris, quadratus menti, is a small quadrilateral muscle. It arises from the oblique line of the mandible, between the symphysis and the mental foramen. It passes upward and medialward, to be inserted into the integument of the lower lip, its fibres blending with the orbicularis oris and with those of its fellow of the opposite side. At its origin it is continuous with the fibres of the platysma. Much yellow fat is intermingled with the fibres of this muscle. The triangularis, depressor anguli oris, arises from the oblique line of the mandible, whence its fibres converge, to be inserted, by a narrow fasciculus, into the angle of the mouth. At its origin it is continuous with the platysma, and at its insertion with the orbicularis oris and risorius, some of its fibres are directly continuous with those of the caninus, and others are occasionally found crossing from the muscle of one side to that of the other. These latter fibres constitute the transversus menti. Nerves. This group of muscles is supplied by the facial nerve. Actions. The mentalis raises and protrudes the lower lip, and at the same time wrinkles the skin of the chin, expressing doubt or disdain. The quadratus labii inferioris draws the lower lip directly downward and a little lateralward, as in the expression of irony. The triangularis depresses the angle of the mouth, being the antagonist of the caninus and the zygomaticus. Acting with the caninus, it will draw the angle of the mouth medialward. The platysma, which retracts and depresses the angle of the mouth, belongs with this group. The buccinator is a thin quadrilateral muscle, occupying the interval between the maxilla and the mandible at the side of the face. It arises from the outer surfaces of the alveolar processes of the maxilla and mandible, corresponding to the 3 molar teeth, and behind from the anterior border of the pterygomandibular raphe, which separates it from the constrictor pharyngis superior. The fibres converge toward the angle of the mouth, where the central fibres intersect each other, those from below being continuous with the upper segment of the orbicularis oris, and those from above with the lower segment. The upper and lower fibres are continued forward into the corresponding lip without decussation. Relations. The buccinator is covered by the buccopharyngeal fascia, and is in relation by its superficial surface, behind, with a large mass of fat, which separates it from the ramus of the mandible, the masseter, and a small portion of the temporalis. This fat has been named the suctorial pad, because it is supposed to assist in the act of sucking. The parotid duct pierces the buccinator opposite the second molar tooth of the maxilla. The deep surface is in relation with the buccal glands and mucous membrane of the mouth. The pterygomandibular raphe, pterygomandibular ligament, is a tendinous band of the buccopharyngeal fascia, attached by one extremity to the hamulus of the medial pterygoid plate, and by the other to the posterior end of the mylohyoid line of the mandible. Its medial surface is covered by the mucous membrane of the mouth. Its lateral surface is separated from the ramus of the mandible by a quantity of adipose tissue. Its posterior border gives an attachment to the constrictor pharyngis superior, its anterior border to part of the buccinator. The orbicularis oris is not a simple sphincter muscle like the orbicularis oculi. It consists of numerous strata of muscular fibres surrounding the orifice of the mouth but having different direction. It consists partly of fibres derived from the other facial muscles, which are inserted into the lips, and partly of fibres proper to the lips. Of the former, a considerable number are derived from the buccinator and form the deeper stratum of the orbicularis. Some of the buccinator fibres, namely those near the middle of the muscle, decussate at the angle of the mouth, those arising from the maxilla passing to the lower lip, and those from the mandible to the upper lip. The uppermost and lowermost fibres of the buccinator pass across the lips from side to side without decussation. Superficial to this stratum is a second, formed on either side by the caninus and triangularis, which cross each other at the angle of the mouth, those from the caninus passing to the lower lip, and those from the triangularis to the upper lip, along which they run, to be inserted into the skin near the median line. In addition to these, there are fibres from the quadratus labii superioris, the zygomaticus, and the quadratus labii inferioris. These intermingle with the transverse fibres above described, and have principally an oblique direction. The proper fibres of the lips are oblique, and pass from the under surface of the skin to the mucous membrane through the thickness of the lip. Finally, there are fibres by which the muscle is connected with the maxillae and the septum of the nose above, and with the mandible below. In the upper lip these consist of two bands, lateral and medial, on either side of the middle line. The lateral band, musculus incisivus labii superioris, arises from the alveolar border of the maxilla, opposite the lateral incisor tooth, and arching lateralward it is continuous with the other muscles at the angle of the mouth. The medial band, musculus nasolabialis, connects the upper lip to the back of the septum of the nose. The interval between the two medial bands corresponds with a depression, called the philtrum, seen on the lip beneath the septum of the nose. The additional fibres for the lower lip constitute a slip, musculus incisivus labii inferioris, on either side of the middle line. This arises from the mandible, lateral to the mentalis, and intermingles with the other muscles at the angle of the mouth. The risorius arises in the fascia over the masseter and, passing horizontally forward, superficial to the platysma, is inserted into the skin at the angle of the mouth. It is a narrow bundle of fibres, broadest at its origin, but varies much in its size and its form. Variations. The zygomatic head of the quadratus labii superioris and risorius are frequently absent, and more rarely the zygomaticus. The zygomaticus and risorius may be doubled, or the latter greatly enlarged or blended with the platysma. Nerves. The muscles in this group are all supplied by the facial nerve. Actions. The orbicularis oris in its ordinary action affects the direct closure of the lips by its deep fibres. Assisted by the oblique ones, it closely applies the lips to the alveolar arch. The superficial part, consisting principally of the decussating fibres, brings the lips together and also protrudes them forward. The buccinators compress the cheeks, so that, during the process of mastication, the food is kept under the immediate pressure of the teeth. When the cheeks have been previously distended with air, the buccinator muscles expel it from between the lips, as in blowing a trumpet. Hence the name, buccina, a trumpet. The risorius retracts the angle of the mouth and produces an unpleasant grinning expression. For more extensive consideration of the facial muscles, see Charles Darwin, Expression of
Section 30 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by David Lawrence. Anatomy of the Human Body, Part 2, by Henry Gray. The muscles of mastication. The chief muscles of mastication are masseter, temporalis, pterygoides externus, and pterygoides internus. Parotidiomasseteric fascia. Masseteric fascia. Covering the masseter and firmly connected with it is a strong layer of fascia derived from the deep cervical fascia. Above, this fascia is attached to the lower border of the zygomatic arch, and behind it invests the parotid gland. The masseter is a thick, somewhat quadrilateral muscle consisting of two portions, superficial and deep. The superficial portion, the larger, arises by a thick, tendinous aponeurosis from the zygomatic process of the maxilla, and from the anterior 2/3 of the lower border of the zygomatic arch. Its fibers pass downward and backward, to be inserted into the angle and lower half of the lateral surface of the ramus of the mandible. The deep portion is much smaller and more muscular in texture. It arises from the posterior third of the lower border and from the whole of the medial surface of the zygomatic arch. Its fibers pass downward and forward, to be inserted into the upper half of the ramus and the lateral surface of the coronoid process of the mandible. The deep portion of the muscle is partially concealed, in front, by the superficial portion. Behind, it is covered by the parotid gland. The fibers of the two portions are continuous at their insertion. Temporal fascia. The temporal fascia covers the temporalis muscle. It is a strong, fibrous investment, covered laterally by the auricularis anterior and superior by the galea aponeurotica and by part of the orbicularis oculi. The superficial temporal vessels and the auriculotemporal nerve cross it from below upward. Above, it is a single layer attached to the entire extent of the superior temporal line, but below, where it is fixed to the zygomatic arch, it consists of two layers, one of which is inserted into the lateral, and the other into the medial border of the arch. A small quantity of fat, the orbital branch of the superficial temporal artery, and a filament from the zygomatic branch of the maxillary nerve, are contained between these two layers. It affords attachment by the deep surface to the superficial fibers of the temporalis. The temporalis, temporal muscle, is a broad radiating muscle situated at the side of the head. It arises from the whole of the temporal fossa, except that portion of it which is formed by the zygomatic bone, and from the deep surface of the temporal fascia. Its fibers converge as they descend and end in a tendon, which passes deep into the zygomatic arch and is inserted into the medial surface, apex, and anterior border of the coronoid process, and the anterior border of the ramus of the mandible nearly as far forward as the last molar tooth. The pterygoides externus, external pterygoid muscle, is a short, thick muscle, somewhat conical in form, which extends almost horizontally between the infratemporal fossa and the condyle of the mandible. It arises by two heads, an upper from the lower part of the lateral surface of the great wing of the sphenoid and from the infratemporal crest, a lower from the lateral surface of the lateral pterygoid plate. Its fibers pass horizontally backward and lateralward, to be inserted into a depression in front of the neck of the condyle of the mandible, and into the front margin of the anticular disc, of the temporomandibular articulation. The pterygoides internus, internal pterygoid muscle, is a thick quadrilateral muscle. It arises from the medial surface of the lateral pterygoid plate and the grooved surface of the pyramidal process of the palatine bone. It has a second slip of origin from the lateral surfaces of the pyramidal process of the palatine and tuberosity of the maxilla. Its fibers pass downward, lateralward, and backward, and are inserted by a strong tendinous lamina into the lower and back part of the medial surface of the ramus and angle of the mandible, as high as the mandibular foramen. Nerves. The muscles of mastication are supplied by the mandibular nerve. Actions. The temporalis, masseter, and pterygoides internus raise the mandible against the maxillae with great force. The pterygoides externus assists in opening the mouth, but its main action is to draw forward the condyle and articular disc so that the mandible is protruded and the inferior incisors projected in front of the upper. In this action it is assisted by the pterygoides internus. The mandible is retracted by the posterior fibers of the temporalis. If the pterygoidae internus and externus of one side act, the corresponding side of the mandible is drawn forward, while the opposite condyle remains comparatively fixed, and side-to-side movements, such as occur during the trituration of food, take place.
Section 31 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Leanne Howlett. Anatomy of the Human Body, Part 2, by Henry Gray. Superficial cervical muscle. 5. The fascia and muscles of the anterolateral region of the neck. A. The superficial cervical muscle. The anterolateral muscles of the neck may be arranged into the following groups. 1. Superficial cervical. 2. Lateral cervical. 3. Supra and infrahyoid. 4. Anterior vertebral. 5. Lateral vertebral. The superficial cervical muscle. Platysma. The superficial fascia of the neck is a thin lamina investing the platysma and is hardly demonstrable as a separate membrane. The platysma is a broad sheet arising from the fascia covering the upper parts of the pectoralis major and deltoideus. Its fibers cross the clavicle and proceed obliquely upward and medialward along the side of the neck. The anterior fibers interlace below and behind the symphysis mentae with the fibers of the muscle of the opposite side. The posterior fibers cross the mandible, some being inserted into the bone below the oblique line, others into the skin and subcutaneous tissue of the lower part of the face, many of these fibers blending with the muscles about the angle and lower part of the mouth. Sometimes fibers can be traced to the zygomaticus or to the margin of the orbicularis oculi. Beneath the platysma, the external jugular vein descends from the angle of the mandible to the clavicle. Variations occur in the extension over the face and over the clavicle and shoulder. It may be absent or interdigitate with the muscle of the opposite side in front of the neck. Attachment to clavicle, mastoid process, or occipital bone occurs. A more or less independent fasciculus, the occipitalis minor, may extend from the fascia over the trapezius to fascia over the insertion of the sternocleidomastoideus. Nerve. The platysma is supplied by the cervical branch of the facial nerve. Actions. When the entire platysma is in action, it produces a slight wrinkling of the surface of the skin of the neck in an oblique direction. Its anterior portion, the thickest part of the muscle, depresses the lower jaw. It also serves to draw down the lower lip and angle of the mouth in the expression of melancholy. 5b. The lateral cervical muscles. The lateral muscles are trapezius and sternocleidomastoideus. The fascia colli, deep cervical fascia. The fascia colli lies under cover of the platysma and invests the neck. It also forms sheaths for the carotid vessels and for the structures situated in front of the vertebral column. The investing portion of the fascia is attached behind to the ligamentum nuchae and to the spinous process of the seventh cervical vertebra. It forms a thin investment to the trapezius, and at the anterior border of this muscle is continued forward as a rather loose areolar layer covering the posterior triangle of the neck to the posterior border of the sternocleidomastoideus, where it begins to assume the appearance of a fascial membrane. Along the hinder edge of the sternocleidomastoideus it divides to enclose the muscle, and at the anterior margin again forms a single lamella, which covers the anterior triangle of the neck and reaches forward to the middle line, where it is continuous with the corresponding part from the opposite side of the neck. In the middle line of the neck it is attached to the symphysis mentae and the body of the hyoid bone. Above. The fascia is attached to the superior nuchal line of the occipital, to the mastoid process of the temporal, and to the whole length of the inferior border of the body of the mandible. Opposite the angle of the mandible, the fascia is very strong, and binds the anterior edge of the sternocleidomastoideus firmly to that bone. Between the mandible and the mastoid process it ensheaths the parotid gland. The layer which covers the gland extends upward under the name of the parotidiomasseteric fascia, and is fixed to the zygomatic arch. From the part which passes under the parotid gland a strong band extends upward to the styloid process, forming the stylomandibular ligament. Two other bands may be defined, the sphenomandibular and the pterygospinous ligaments. The pterygospinous ligament stretches from the upper part of the posterior border of the lateral pterygoid plate to the spinous process of the sphenoid. It occasionally ossifies, and in such cases, between its upper border and the base of the skull, a foramen is formed which transmits the branches of the mandibular nerve to the muscles of mastication. Below. The fascia is attached to the acromion, the clavicle, and the Manubrium sterni. Some little distance above the last it splits into two layers, superficial and deep. The former is attached to the anterior border of the Manubrium, the latter to its posterior border and to the interclavicular ligament. Between these two layers is a slit-like interval, the suprasternal space, space of Burns. It contains a small quantity of areolar tissue, the lower portions of the anterior jugular veins and their transverse connecting branch, the sternal heads of the sternocleidomastoidei, and sometimes a lymph gland. The fascia which lines the deep surface of the sternocleidomastoideus gives off the following processes. 1. A process envelops the tendon at the omohyoideus and binds it down to the sternum and first costal cartilage. 2. A strong sheath, the carotid sheath, encloses the carotid artery, internal jugular vein, and vagus nerve. 3. The prevertebral fascia extends medialward behind the carotid vessels, where it assists in forming their sheath, and passes in front of the prevertebral muscles. It forms the posterior limit of a fibrous compartment, which contains the larynx and trachea, the thyroid gland, and the pharynx and esophagus. The prevertebral fascia is fixed above to the base of the skull, and below is continued into the thorax in front of the longus colli muscles. Parallel to the carotid sheath and along its medial aspect, the prevertebral fascia gives off a thin lamina, the buccopharyngeal fascia, which closely invests the constrictor muscles of the pharynx and is continued forward from the constrictor pharyngeus superior onto the buccinator. It is attached to the prevertebral layer by loose connective tissue only, and thus an easily distended space, the retropharyngeal space, is found between them. This space is limited above by the base of the skull, while below it extends behind the esophagus into the posterior mediastinal cavity of the thorax. The prevertebral fascia is prolonged downward and lateralward behind the carotid vessels and in front of the scalenii, and forms a sheath for the brachial nerves and subclavian vessels in the posterior triangle of the neck. It is continued under the clavicle as the axillary sheath, and is attached to the deep surface of the coracoclavicular fascia. Immediately above and behind the clavicle, an areolar space exists between the investing layer and the sheath of the subclavian vessels, and in this space are found the lower part of the external jugular vein, the descending clavicular nerves, the transverse scapular and transverse cervical vessels, and the inferior belly of the omohyoideus muscle. This space is limited below by the fusion of the coracoclavicular fascia with the anterior wall of the axillary sheath. 4. The pretracheal fascia extends medially in front of the carotid vessels, and assists in forming the carotid sheath. It is continued behind the depressor muscles of the hyoid bone, and after enveloping the thyroid gland, is prolonged in front of the trachea to meet the corresponding layer of the opposite side. Above it is fixed to the hyoid bone, while below it is carried downward in front of the trachea and large vessels at the root of the neck, and ultimately blends with the fibrous pericardium. This layer is fused on either side with the prevertebral fascia, and with it completes the compartment containing the larynx and trachea, the thyroid gland, and the pharynx and esophagus. Footnote: F. G. Parsons, Journal of Anatomy and Physiology, Volume 44, regards the carotid sheath and the fascial planes in the neck as structures which are artificially produced by dissection. End of footnote. The sternocleidomastoideus, sternomastoid muscle, passes obliquely across the side of the neck. It is thick and narrow at its central part, but broader and thinner at either end. It arises from the sternum and clavicle by two heads. The medial or sternal head is a rounded fasciculus, tendinous in front, fleshy behind, which arises from the upper part of the anterior surface of the Manubrium sterni, and is directed upward, lateralward, and backward. The lateral or clavicular head, composed of fleshy and aponeurotic fibers, arises from the superior border and anterior surface of the medial third of the clavicle. It is directed almost vertically upward. The two heads are separated from one another at their origins by a triangular interval, but gradually blend, below the middle of the neck, into a thick, rounded muscle, which is inserted by a strong tendon into the lateral surface of the mastoid process, from its apex to its superior border, and by a thin aponeurosis into the lateral half of the superior nuchal line of the occipital bone. Variations. The sternocleidomastoideus varies much in the extent of its origin from the clavicle. In some cases the clavicular head may be as narrow as the sternal. In others it may be as much as 7.5 centimeters in breadth. When the clavicular origin is broad, it is occasionally subdivided into several slips, separated by narrow intervals. More rarely the adjoining margins of the sternocleidomastoideus and trapezius have been found in contact. The supraclavicularis muscle arises from the Manubrium behind the sternocleidomastoideus and passes behind the sternocleidomastoideus to the upper surface of the clavicle. Triangles of the neck. This muscle divides the quadrilateral area of the side of the neck into two triangles, an anterior and a posterior. The boundaries of the anterior triangle are, in front, the median line of the neck; above, the lower border of the body of the mandible, and an imaginary line drawn from the angle of the mandible to the sternocleidomastoideus. Behind, the anterior border of the sternocleidomastoideus. The apex of the triangle is at the upper border of the sternum. The boundaries of the posterior triangle are, in front, the posterior border of the sternocleidomastoideus; below, the middle third of the clavicle; behind, the anterior margin of the trapezius. The apex corresponds with the meeting of the sternocleidomastoideus and trapezius on the occipital bone. The anatomy of these triangles will be more fully described with that of the vessels of the neck. Nerves. The sternocleidomastoideus is supplied by the accessory nerve and branches from the anterior divisions of the second and third cervical nerves. Actions. When only one sternocleidomastoideus acts, it draws the head toward the shoulder of the same side, assisted by the splenius and the obliquus capitis inferior of the opposite side. At the same time it rotates the head so as to carry the face toward the opposite side. Acting together from their sternoclavicular attachments, the muscles will flex the cervical part of the vertebral column. If the head be fixed, the two muscles assist in elevating the thorax and force.
Section 32 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 2, by Henry Gray. Section 32. The supra- and infrahyoid muscles. The suprahyoid muscles are digastricus, stylohyoideus, mylohyoideus, geniohyoideus. The digastricus, digastric muscle, consists of two fleshy bellies united by an intermediate rounded tendon. It lies below the body of the mandible and extends in a curved form from the mastoid process to the symphysis mentae. The posterior belly, longer than the anterior, arises from the mastoid notch of the temporal bone and passes downward and forward. The anterior belly arises from a depression on the inner side of the lower border of the mandible, close to the symphysis, and passes downward and backward. The two bellies end in an intermediate tendon which perforates the stylohyoideus muscle and is held in connection with the side of the body and the greater cornu of the hyoid bone by a fibrous loop, which is sometimes lined by a mucous sheath. A broad aponeurotic layer is given off from the tendon of the digastricus on either side to be attached to the body and greater cornu of the hyoid bone. This is termed the suprahyoid aponeurosis. Variations are numerous. the posterior belly may arise partly or entirely from the styloid process, or may be connected by a slip to the middle or inferior constrictor. The anterior belly may be double, or extra slips from this belly may pass through the jaw, or mylohyoideus, or decussate with a similar slip on the opposite side. Anterior belly may be absent, and posterior belly inserted into the middle of the jaw or hyoid bone. The tendon may pass in front, more rarely behind, the stylohyoideus. The mentohyoideus muscle passes from the body of hyoid bone to chin. The digastricus divides the anterior triangle of the neck into 3 smaller triangles. 1, the submaxillary triangle, bounded above by the lower border of the body of the mandible, and a line drawn from its angle to the sternocleidomastoideus. Below by the posterior belly of the digastricus and the stylohyoideus, in front of the anterior belly of the digastricus. 2, the carotid triangle, bounded above by the posterior belly of the digastricus and stylohyoideus, behind by the sternocleidomastoideus, below by the omohyoideus. 3, the suprahyoid or submental triangle, bounded laterally by the anterior belly of the digastricus, medially by the middle line of the neck from the hyoid bone to the symphysis mentae, and inferiorly by the body of the hyoid bone. The stylohyoideus, stylohyoid muscle, is a slender muscle lying in front of and above the posterior belly of the digastricus. It arises from the back and lateral surface of the styloid process, near the base, and passing downward and forward is inserted into the body of the hyoid bone, at its junction with the greater cornu, and just above the omohyoideus. It is perforated near its insertion by the tendon of the digastricus. Variations. It may be absent or doubled, lie beneath the carotid artery, or be inserted into the omohyoideus, thyreohyoideus, or mylohyoideus. The stylohyoid ligament, ligamentum stylohyoideus. In connection with the stylohyoideus muscle, a ligamentous band, the stylohyoid ligament, may be described. It is a fibrous cord, which is attached to the tip of the styloid process of the temporal and the lesser cornu of the hyoid bone. It frequently contains a little cartilage in its center, is often partially ossified, and in many animals forms a distinct bone, the epihyal. The mylohyoideus, mylohyoid muscle, flat and triangular, is situated immediately above the anterior belly of the digastricus, and forms, with its fellow of the opposite side, a muscular floor for the cavity of the mouth. It arises from the whole length of the mylohyoid line of the mandible, extending from the symphysis in front to the last molar tooth behind. The posterior fibers pass medialward and slightly downward, to be inserted into the body of the hyoid bone. The middle and anterior fibers are inserted into a median fibrous raphe extending from the symphysis mentae to the hyoid bone, where they join at an angle with the fibers of the opposite muscle. This median raphe is sometimes wanting. The fibers of the two muscles are then continuous. Variations. It may be united to or replaced by the anterior belly of the digastricus. Accessory slips to other hyoid muscles are frequent. The geniohyoideus, geniohyoid muscle, is a narrow muscle situated above the medial border of the mylohyoideus. It arises from the inferior mental spine on the back of the symphysis mentae, and it runs backward and slightly downward to be inserted into the anterior surface of the body of the hyoid bone. It lies in contact with its fellow of the opposite side. Variations. It may be blended with the one on opposite side or double. Slips to greater cornu of hyoid bone and genioglossus occur. Nerves. The mylohyoideus and anterior belly of the digastricus are supplied by the mylohyoid branch of the inferior alveolar, the stylohyoideus and posterior belly of the digastricus by the facial, the geniohyoideus by the hypoglossal. Actions. These muscles perform two very important actions. During the act of glutition, they raise the hyoid bone, and with it the base of the tongue. When the hyoid bone is fixed by its depressors and those of the larynx, they depress the mandible. During the first act of deglutition, when the mass of food is being driven from the mouth into the pharynx, the hyoid bone, and with it the tongue, is carried upward and forward by the anterior bellies of the digastrocei, the mylohyoidii and geniohyoidii. In the second act, when the mass is passing through the pharynx, the direct elevation of the hyoid bone takes place by the combined action of all the muscles, and after the food has passed, the hyoid bone is carried upward and backward by the posterior bellies of the digastrocei and stylohyoidii, which assist in preventing the return of the food into the mouth. The infrahyoid muscles are sternohyoideus, sternothyreoideus, thyreohyoideus, omohyoideus. The sternohyoid muscle, is a thin, narrow muscle, which arises from the posterior surface of the medial end of the clavicle, the posterior sternoclavicular ligament, and the upper and posterior part of the Manubrium sterni. Passing upward and medialward, it is inserted by short tendinous fibers into the lower border of the body of the hyoid bone. Below, this muscle is separated from its fellow by a considerable interval, but the two muscles come into contact with one another in the middle of their course, and from this upward lie side by side. It sometimes presents immediately above its origin a transverse tendinous inscription. Variations: doubling, accessory slips, cleidohyoideus. Absence. The sternothyreoideus, sternothyroid muscle, is shorter and wider than the preceding muscle, beneath which it is situated. It arises from the posterior surface of the Manubrium sterni, below the origin of the sternohyoideus, and from the edge of the cartilage of the first rib, and sometimes that of the second rib. It is inserted into the oblique line on the lamina of the thyroid cartilage. This muscle is in close contact with its fellow at the lower part of the neck, but diverges somewhat as it ascends. It is occasionally traversed by a transverse or oblique tendinous inscription. Variations: doubling, absence, accessory slips of the thyreohyoideus, inferior constrictor, or carotid sheath. The thyreohyoideus, thyrohyoid muscle, is a small quadrilateral muscle appearing like an upward continuation of the sternothyreoideus. It arises from the oblique line on the lamina of the thyroid cartilage and is inserted into the lower border of the greater cornu of the hyoid bone. The omohyoideus, omohyoid muscle, consists of two fleshy bellies united by a central tendon. It arises from the upper border of the scapula and occasionally from the superior transverse ligament which crosses the scapular notch, its extent of attachment to the scapula varying from a few millimeters to 2.5 centimeters. From this origin, the inferior belly forms a flat, narrow fasciculus, which inclines forward and slightly upward across the lower part of the neck. Being bound down to the clavicle by a fibrous extension, it then passes behind the sternocleidomastoideus, becomes tendinous, and changes its direction, forming an obtuse angle. It ends in the superior belly, which passes almost vertically upward, close to the lateral border of the sternohyoideus, to be inserted into the lower border of the body of the hyoid bone, lateral to the insertion of the sternohyoideus. The central tendon of this muscle varies much in length and form, and is held in position by a process of the deep cervical fascia, which sheaths it, and is prolonged down to be attached to the clavicle and first rib. It is by this means that the angular form of the muscle is maintained. Variations: doubling, absence, origin from clavicle, absence or doubling of either belly. The inferior belly of the omohyoideus divides the posterior triangle of the neck into an upper or occipital triangle and a lower or subclavian triangle, while its superior belly divides the anterior triangle into an upper or carotid triangle and a lower or muscular triangle. Nerves. The infrahyoid muscles are supplied by branches from the first three cervical nerves. From the first two nerves the branch joins the hypoglossal trunk, runs with it some distance, and sends off a branch to the thyreohyoideus. It then leaves the hypoglossal, to form the descendens hypoglossae, and unites with the communicantis cervicalis from the second and third cervical nerves to form the ansa hypoglossae, from which nerves pass to the other infrahyoid muscles. Actions. These muscles depress the larynx and hyoid bone, after they have been drawn up with the pharynx in the act of deglutition. The omohyoidii not only depress the hyoid bone, but carry it backward and to one or the other side. They are concerned especially in prolonged inspiratory efforts, for by rendering the lower part of the cervical fascia tense, they lessen the inward suction of the soft parts, which would otherwise compress the great vessels and the apices of the lungs. The thyrohyoideus may act as an elevator of the thyroid cartilage when the hyoid bone ascends, drawing the thyroid cartilage up behind.
Section 33 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by David Lawrence. Anatomy of the Human Body, Part 2, by Henry Gray. The Anterior Vertebral Muscles. The anterior vertebral muscles are longus colli, longus capitis, rectus capitis anterior, rectus capitis lateralis. The longus colli is situated on the anterior surface of the vertebral column, between the atlas and the third thoracic vertebra. It is broad in the middle, narrow and pointed at either end, and consists of three portions: a superior oblique, an inferior oblique, and a vertical. The superior oblique portion arises from the anterior tubercles of the transverse processes of the third, fourth, and fifth cervical vertebrae, and, ascending obliquely with a medial inclination, is inserted by a narrow tendon into the tubercle on the anterior arch of the atlas. The inferior oblique portion, the smallest part of the muscle, arises from the front of the bodies of the first two or three thoracic vertebrae, and, ascending obliquely in a lateral direction, is inserted into the anterior tubercles of the transverse processes of the fifth and sixth cervical vertebrae. The vertical portion arises below from the front of the bodies of the upper three thoracic and lower three cervical vertebrae, and is inserted into the front of the bodies of the second, third, and fourth cervical vertebrae. The longus capitis, rectus capitis, anticus major, broad and thick above, narrow below, arises by four tendinous slips from the anterior tubercles of the transverse processes of the third, fourth, fifth, and sixth cervical vertebrae, and descends, converging toward its fellow of the opposite side, to be inserted into the inferior surface of the basilar part of the occipital bone. The rectus capitis anterior, rectus capitis anticus minor, is a short, flat muscle situated immediately behind the upper part of the longus capitis. It arises from the anterior surface of the lateral mass of the atlas, and from the root of its transverse process, and passing obliquely upward and medialward, is inserted into the inferior surface of the basilar part of the occipital bone immediately in front of the foramen magnum. The rectus capitis lateralis, a short flat muscle, arises from the upper surface of the transverse process of the atlas, and is inserted into the under surface of the jugular process of the occipital bone. Nerves. The rectus capitis anterior and the rectus capitis lateralis are supplied from the loop between the first and second cervical nerves. The longus capitis by branches from the first, second, and third cervical. The longus colli by the branches from the second to the seventh cervical nerves. Actions. The longus capitis and rectus capitis anterior are the direct antagonists of the muscles at the back of the neck, serving to restore the head to its natural position after it has been drawn backward. These muscles also flex the head, and from their obliquity rotate it, so as to turn the face to one or the other side. The rectus lateralis, acting on one side, bends the head laterally. The longus colli flexes and slightly rotates the cervical portion of the vertebral column. The lateral vertebral muscles. The lateral vertebral muscles are scalenus anterior, scalenus medius, scalenus posterior. The scalenus anterior, scalenus anticus, lies deeply at the side of the neck, behind the sternocleidomastoideus. It arises from the anterior tubercles of the transverse processes of the third, fourth, fifth, and sixth cervical vertebrae, and descending, almost vertically, is inserted by a narrow flat tendon into the scalene tubercle on the inner border of the first rib, and into the ridge on the upper surface of the rib in front of the subclavian groove. The scalenus medius, the largest and longest of the three scaleni, arises from the posterior tubercles of the transverse processes of the lower six cervical vertebrae, and descending along the surface of the vertebral column, is inserted by a broad attachment into the upper surface of the first rib, between the tubercle and the subclavian groove. The scalenus posterior, scalenus posticus, the smallest and most deeply seated of the three scaleni, arises, by two or three separate tendons, from the posterior tubercles of the transverse processes of the lower two or three cervical vertebrae, and is inserted by a thin tendon into the outer surface of the second rib, behind the attachment of the serratus anterior. It is occasionally blended with the scalenus medius. Variations. The scaleni muscles vary considerably in their attachments and in arrangement of their fibers. A slip from the scalenus anticus may pass behind the subclavian artery. The scalenus posticus may be absent or extend to the third rib. The scalenus pleuralis muscle extends from the transverse process of the seventh cervical vertebra to the fascia supporting the dome of the pleura and inner border of the first rib. Nerves. The scaleni are supplied by branches from the second to the seventh cervical nerves. Actions. When the scaleni act from above, they elevate the first and second ribs, and are, therefore, inspiratory muscles. Acting from below, they bend the vertebral column to one or the other side. If the muscles of both sides act, the vertebral column is slightly flexed.
Section 34 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 2, by Henry Gray. The fasciae and muscles of the trunk, the deep muscles of the back. The muscles of the trunk may be arranged in 6 groups. 1. Deep muscles of the back. 2. Suboccipital muscles. 3. Muscles of the thorax. 4. Muscles of the abdomen. 5. Muscles of the pelvis. 6. Muscles of the perineum. The deep muscles of the back. The deep or intrinsic muscles of the back consist of a complex group of muscles extending from the pelvis to the skull. They are splenius capitis, splenius cervicis, sacrospinalis, semispinalis, multifidus, rotatories, interspinalis, intertransversarii. The lumbodorsal fascia, fascia lumbodorsalis, lumbar aponeurosis, and vertebral fascia. The lumbodorsal fascia is a deep investing membrane which covers the deep muscles of the back of the trunk. Above, it passes in front of the serratus posterior superior and is continuous with a similar investing layer on the back of the neck, the nuchal fascia. In the thoracic region, the lumbodorsal fascia is a thin fibrous lamina which serves to bind down the extensor muscles of the vertebral column and to separate them from the muscles connecting the vertebral column to the upper extremity. It contains both longitudinal and transverse fibers, and is attached medially to the spinous processes of the thoracic vertebrae, laterally to the angles of the ribs. In the lumbar region, the fascia, lumbar aponeurosis, is in two layers, anterior and posterior. The posterior layer is attached to the spinous processes of the lumbar and sacral vertebrae and to the supraspinal ligament. The anterior layer is attached medially to the tips of the transverse processes of the lumbar vertebrae and to the intertransverse ligaments, below to the iliolumbar ligament, and above to the lumbocostal ligament. The two layers unite at the lateral margin of the sacrospinalis to form the tendon of origin of the transversus abdominis. The aponeurosis of origin of the serratus posterior inferior and the latissimus dorsi are intimately blended with the lumbodorsal fascia. The splenius capitis arises from the lower half of the ligamentum nuchae, from the spinous process of the seventh cervical vertebra, and from the spinous processes of the upper 3 or 4 thoracic vertebrae. The fibers of the muscle are directed upward and lateralward and are inserted under cover of the sternocleido mastoideus into the mastoid process of the temporal bone, and into the rough surface on the occipital bone just below the lateral third of the superior nuchal line. The splenius cervicis, splenius cali, arises by a narrow tendinous band from the spinous processes of the 3rd to the 6th thoracic vertebrae. It is inserted by tendinous fasciculi into the posterior tubercles of the transverse processes of the upper 2 or 3 cervical vertebrae. Variations. The origin is frequently moved up or down 1 or 2 vertebrae. Accessory slips are occasionally found. Nerves. The splenii are supplied by the lateral branches of the posterior divisions of the middle and lower cervical nerves. Actions. The splenii of the two sides, acting together, draw the head directly backward, assisting the trapezius and semispinalis capitis. Acting separately, they draw the head to one side and slightly rotate it, turning the face to the same side. They also assist in supporting the head in the erect position. The sacrospinalis, erector spinae, and its prolongations in the thoracic and cervical regions, lie in the groove on the side of the vertebral column. They are covered in the lumbar and thoracic regions by the lumbodorsal fascia, and in the cervical region by the nuchal fascia. This large muscular and tendinous mass varies in size and structure at different parts of the vertebral column. In the sacral region it is narrow and pointed, and at its origin chiefly tendinous in structure. In the lumbar region it is larger and forms a thick fleshy mass which, on being followed upward, is subdivided into 3 columns. These gradually diminish in size as they ascend, to be inserted into the vertebrae and ribs. The sacrospinalis arises from the anterior surface of a broad and thick tendon which is attached to the medial crest of the sacrum, to the spinous processes of the lumbar and the 11th and 12th thoracic vertebrae, and the supraspinal ligament, to the back part of the inner lip of the iliac crests, and to the lateral crest of the sacrum, where it blends with the sacrotuberous and posterior sacroiliac ligaments. Some of its fibers are continuous with the fibers of origin of the gluteus maximus. The muscular fibers form a large fleshy mass which splits in the upper lumbar region into 3 columns, viz. a lateral, the iliocostalis, an intermediate, the longissimus, and a medial, the spinalis. Each of these consists from below upward of 3 parts, as follows. Lateral column, iliocostalis. A. I lumborum. B. I dorsi. C. I cervicis. Intermediate column longissimus. A. L. dorsi. B. L. cervicis. C. L. capitis. Medial column spinalis. A. S. dorsi. B. S. cervicis. C. S. capitis. The iliocostalis lumborum, iliocostalis muscle, sacrolumbalis muscle, is inserted by 6 or 7 flattened tendons into the inferior borders of the angles of the lower 6 or 7 ribs. The iliocostalis dorsi, musculus accessorius, arises by flattened tendons from the upper borders of the angles of the lower 6 ribs medial to the tendons of insertion of the iliocostalis lumborum. These become muscular and are inserted into the upper borders of the angles of the upper 6 ribs, and into the back of the transverse process of the 7th cervical vertebra. The iliocostalis cervicis, cervicalis ascendens, arises from the angles of the 3rd, 4th, 5th, and 6th ribs, and is inserted into the posterior tubercles of the transverse processes of the 4th, 5th, and 6th cervical vertebrae. The longissimus dorsi is the intermediate and largest of the continuations of the sacrospinalis. In the lumbar region, where it is as yet blended with the iliocostalis lumborum, some of its fibers are attached to the whole length of the posterior surfaces of the transverse processes and the accessory processes of the lumbar vertebrae, and to the anterior layer of the lumbodorsal fascia. In the thoracic region it is inserted by rounded tendons into the tips of the transverse processes of all the thoracic vertebrae, and by fleshy processes into the lower 9 or 10 ribs between their tubercles and angles. The longissimus cervicis, transversalis cervicis, situated medial to the longissimus dorsi, arises by long thin tendons from the summits of the transverse processes of the upper 4 or 5 thoracic vertebrae, and is inserted by similar tendons into the posterior tubercles of the transverse processes of the cervical vertebrae, from the 2nd to the 6th inclusive. The longissimus capitis, tracheomastoid muscle, lies medial to the longissimus cervicis, between it and the semispinalis capitis. It arises by tendons from the transverse processes of the upper 4 or 5 thoracic vertebrae and the articular processes of the lower 3 or 4 cervical vertebrae, and is inserted into the posterior margin of the mastoid process beneath the splenius capitis and sternocleido mastoideus. It is almost always crossed by a tendinous intersection near its insertion. The spinalis dorsi, the medial continuation of the sacrospinalis, is scarcely separable as a distinct muscle. It is situated at the medial side of the longissimus dorsi and is intimately blended with it. It arises by 3 or 4 tendons from the spinous processes of the first 2 lumbar and the last 2 thoracic vertebrae. These uniting form a small muscle which is inserted by separate tendons into the spinous processes of the upper thoracic vertebrae, the number varying from 4 to 8. It is intimately united with the semispinalis dorsi, situated beneath it. The spinalis cervicis, spinalis colli, is an inconstant muscle which arises from the lower part of the ligamentum nuchae, the spinous process of the 7th cervical, and sometimes from the spinous processes of the 1st and 2nd thoracic vertebrae, and is inserted into the spinous process of the axis, and occasionally into the spinous processes of the 2 vertebrae below it. The spinalis capitis, biventer cervicis, is usually inseparably connected with the semispinalis capitis. See below. The semispinalis dorsi consists of thin, narrow, fleshy fasciculi interposed between tendons of considerable length. It arises by a series of small tendons from the transverse processes of the 6th to the 10th thoracic vertebrae, and is inserted by tendons into the spinous processes of the upper 4 thoracic and lower 2 cervical vertebrae. The semispinalis cervicis, semispinalis colli, thicker than the preceding, arises by a series of tendinous and fleshy fibers from the transverse processes of the upper 5 or 6 thoracic vertebrae, and is inserted into the cervical spinous processes from the axis to the 5th inclusive. The fasciculus connected with the axis is the largest and is chiefly muscular in structure. The semispinalis capitis, complexus, is situated at the upper and back part of the neck beneath the splenius and medial to the longissimus cervicis in capitis. It arises by a series of tendons from the tips of the transverse processes of the upper 6 or 7 thoracic and the 7th cervical vertebrae, and from the articular processes of the 3 cervical above this. The tendons, uniting, form a broad muscle which passes upward and is inserted between the superior and inferior nuchal lines of the occipital bone. The medial part, usually more or less distinct from the remainder of the muscle, is frequently termed the spinalis capitis. It is also named the biventer cervicis, since it is traversed by an imperfect tendinous inscription. The multifidus spinae, consists of a number of fleshy and tendinous fasciculi which fill up the groove on either side of the spinous processes of the vertebrae, from the sacrum to the axis. In the sacral region, these fasciculi arise from the back of the sacrum, as low as the 4th sacral foramen, from the aponeuroses of origin of the sacrospinalis, from the medial surface of the posterior superior iliac spine, and from the posterior sacroiliac ligaments. In the lumbar region, from all the mammillary processes, in the thoracic region, from all the transverse processes, and in the cervical region, from the articular processes of the lower 4 vertebrae. Each fasciculus, passing obliquely upward and medialward, is inserted into the whole length of the spinous process of one of the vertebrae above. These fasciculi vary in length. The most superficial, the longest, pass from one vertebra to the 3rd or 4th above. Those next in order run from one vertebra to the 2nd or 3rd above, while the deepest connect 2 contiguous vertebrae. The rotatories spinae, lie beneath the multifidus and are found only in the thoracic region. They are 11 in number on either side. Each muscle is small and somewhat quadrilateral in form. It arises from the upper and back part of the transverse process, and is inserted into the lower border and lateral surface of the lamina of the vertebra above, the fibers extending as far as the root of the spinous process. The first is found between the 1st and 2nd thoracic vertebrae, the last between the 11th and 12th. Sometimes the number of these muscles is diminished by the absence of one or more from the upper or lower end. The interspinales are short muscular fasciculi placed in pairs between the spinous processes of the contiguous vertebrae, one on either side of the interspinal ligament. In the cervical region they are most distinct and consist of 6 pairs, the first being situated between the axis and 3rd vertebra, and the last between the 7th cervical and the 1st thoracic. They are small narrow bundles attached above and below to the apices of the spinous processes. In the thoracic region they are found between the 1st and 2nd vertebrae, and sometimes between the 2nd and 3rd, and between the 11th and 12th. In the lumbar region there are 4 pairs, in the intervals between the 5 lumbar vertebrae. There is also occasionally one between the last thoracic and 1st lumbar, and one between the 5th lumbar and the sacrum. The extensor coccygeus is a slender muscular fasciculus which is not always present. It extends over the lower part of the posterior surface of the sacrum and coccyx. It arises by tendinous fibers from the last segment of the sacrum, or first piece of the coccyx, and passes downward to be inserted into the lower part of the coccyx. It is a rudiment of the extensor muscle of the caudal vertebrae of the lower animals. The intertransversales are small muscles placed between the transverse processes of the vertebrae. In the cervical region they are best developed, consisting of rounded muscular and tendinous fasciculi, and are placed in pairs passing between the anterior and the posterior tubercles, respectively, of the transverse processes of 2 contiguous vertebrae, and separated from one another by an anterior primary division of the cervical nerve, which lies in the groove between them. The muscles connecting the anterior tubercles are termed the intertransversarii anteriores, those between the posterior tubercles, the intertransversarii posteriores. Both sets are supplied by the anterior divisions of the spinal nerves. There are 7 pairs of these muscles, the first pair being between the atlas and axis, and the last pair between the 7th cervical and 1st thoracic vertebrae. In the thoracic region they are present between the transverse processes of the lower 3 thoracic vertebrae, and between the transverse processes of the last thoracic and the 1st lumbar. In the lumbar region they are arranged in pairs on either side of the vertebral column, one set occupying the entire interspace between the transverse processes of the lumbar vertebrae, the intertransversarii laterales, The other set, intertransversarii medialis, passing from the accessory process of one vertebra to the mammillary of the vertebra below. The intertransversarii lateralis are supplied by the anterior division.
Section 35 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 2, by Henry Gray. Suboccipital Muscles. The suboccipital group comprises rectus capitis posterior major, rectus capitis posterior minor, obliquus capitis inferior, obliquus capitis superior. The rectus capitis posterior major, rectus capitis posticus major, arises by a pointed tendon from the spinous process of the axis, and, becoming broader as it ascends, is inserted into the lateral part of the inferior nuchal line of the occipital bone and the surface of the bone immediately below the line. As the muscles of the two sides pass outward and lateralward, they leave between them a triangular space, in which the recti capitis posteriores minores are seen. The rectus capitis posterior minor, rectus capitis posticus minor, arises by a narrow pointed tendon from the tubercle on the posterior arch of the atlas, and, widening as it ascends, is inserted into the medial part of the inferior nuchal line of the occipital bone and the surface between it and the foramen magnum. The obliquus capitis inferior, the larger of the two oblique muscles, arises from the apex of the spinous process of the axis, and passes lateralward and slightly upward to be inserted into the lower and back part of the transverse process of the atlas. The obliquus capitis superior, narrow below, wide and expanded above, arises by tendinous fibres from the upper surface of the transverse process of the atlas, joining with the insertion of the preceding. It passes upward and medialward, and is inserted into the occipital bone between the superior and inferior nuchal lines, lateral to the semispinalis capitis. The suboccipital triangle. Between the oblique and the rectus capitis posterior major is the suboccipital triangle. It is bounded above and medially by the rectus capitis posterior major, above and laterally by the obliquus capitis superior, below and laterally by the obliquus capitis inferior. It is covered by a layer of dense fibro-fatty tissue, situated beneath the semispinalis capitis. The floor is formed by the posterior occipito-atlantal membrane and the posterior arch of the atlas. In the deep groove on the upper surface of the posterior arch of the atlas are the vertebral artery and the first cervical or suboccipital nerve. Nerves. The deep muscles of the back and the suboccipital muscles are supplied by the posterior primary divisions of the spinal nerves. Actions. The sacrospinalis and its upward continuations and the spinalis serve to maintain the vertebral column in the erect posture. They also serve to bend the trunk backward when it is required to counterbalance the influence of any weight at the front of the body, as for instance when a heavy weight is suspended from the neck, or when there is any great abdominal distension, as in pregnancy or dropsy. The peculiar gait under such circumstances depends upon the vertebral column being drawn backward by the counterbalancing action of the sacrospinalis. The muscles which form the continuation of the sacrospinalis onto the head and neck steady those parts and fix them in the upright position. If the iliocostalis lumborum and longissimus dorsi of one side act, they serve to draw down the chest and vertebral column to the corresponding side. The iliocostalis cervicis, taking their fixed points from the cervical vertebrae, elevate those ribs to which they are attached. Taking their fixed points from the ribs, both muscles help to extend the neck, while one muscle bends the neck to its own side. When both longissimi cervicis act from below, they bend the neck backward. When both longissimi capitis act from below, they bend the head backward, while, if only one muscle acts, the face is turned to the side on which the muscle is acting, and then the head is bent to the shoulder. The two recti draw the head backward. The rectus capitis posterior major, owing to its obliquity, rotates the skull, with the atlas, around the odontoid process, turning the face to the same side. The multifidus acts successively upon the different parts of the column, thus the sacrum furnishes a fixed point from which the fasciculi of this muscle acts upon the lumbar region, which in turn becomes the fixed point for the fasciculi moving the thoracic region, and so on throughout the entire length of the column. The multifidus also serves to rotate the column, so that the front of the trunk is turned to the side opposite to that from which the muscle acts, this muscle being assisted in its action by the obliquus externus abdominis. The obliquus capitis superior draws the head backward and to its own side. The obliquus inferior rotates the atlas, and with it the skull, around the odontoid process, turning the face to the same side. When the semispinales of the two sides act together, they help to extend the vertebral column. When the muscles of only one side act, they rotate the thoracic and cervical parts of the column, turning the body to the opposite side. The semispinales capitis draw the head directly backward if one muscle acts. It draws the head to one side and rotates it so that the face is turned to the opposite side. The interspinales, by approximating the spinous processes, help to extend the column. The intertransversarii approximate the transverse processes and help to bend the column to one side. The rotatores assist the multifidus to rotate. Section 36 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 2, by Henry Gray. Muscles of the Thorax, Part 1. 6c. The muscles of the thorax. The muscles belonging to this group are the intercostales externi, intercostales interni, subcostales, transversus thoracis, levatores costarum, serratus posterior superior, serratus posterior inferior, diaphragm. Intercostal fasciae. In each intercostal space, thin but firm layers of fascia cover the outer surface of the intercostalis externus and the inner surface of the intercostalis internus, and a third, more delicate layer, is interposed between the two planes of muscular fibres. They are best marked in those situations where the muscular fibres are deficient, as between the intercostalis externi and sternum in front, and between the intercostalis interni and vertebral column behind. The intercostales, intercostal muscles, are two thin planes of muscular and tendinous fibres occupying each of the intercostal spaces. They are named external and internal from their surface relations, the external being superficial to the internal. The intercostalis externi, external intercostals, are 11 in number on either side. They extend from the tubercles of the ribs behind to the cartilages of the ribs in front, where they end in thin membranes, the anterior intercostal membranes, which are continued forward to the sternum. Each arises from the lower border of a rib, and is inserted into the upper border of the rib below. In the two lower spaces they extend to the ends of the cartilages, and in the upper 2 or 3 spaces they do not quite reach the ends of the ribs. They are thicker than the intercostalis interni, and their fibres are directed, obliquely downward and lateralward on the back of the thorax, and downward, forward, and medialward on the front. Variations. Continuation with the obliquus externus or serratus anterior. A supracostalis muscle from the anterior end of the first rib down to the second, third, or fourth ribs occasionally occurs. The intercostalis interni, internal intercostals, are also 11 in number on either side. They commence anteriorly at the sternum, in the interspaces between the cartilages of the true ribs and the anterior extremities of the cartilages of the false ribs, and extend backward as far as the angles of the ribs, whence they are continued to the vertebral column by thin aponeuroses, the posterior intercostal membranes. Each arises from the ridge on the inner surface of a rib, as well as from the corresponding costal cartilage, and is inserted into the upper border of the rib below. Their fibres are also directed obliquely, but pass in a direction opposite to those of the intercostalis externi. The subcostales, infracostales, consist of muscular and aponeurotic fasciculi, which are usually well developed only in the lower part of the thorax. Each arises from the inner surface of one rib near its angle, and is inserted into the inner surface of the second or third rib below. Their fibres run in the same direction as those of the intercostalis interni. The transversus thoracis, triangularis sterni, is a thin plate of muscular and tendinous fibres situated upon the inner surface of the front wall of the chest. It arises on either side from the lower third of the posterior surface of the body of the sternum, from the posterior surface of the xiphoid process, and from the sternal ends of the costal cartilages of the lower 3 or 4 true ribs. Its fibres diverge upward and lateralward, to be inserted by slips into the lower borders and inner surfaces of the costal cartilages of the 2nd, 3rd, 4th, 5th, and 6th ribs. The lowest fibres of this muscle are horizontal in their direction, and are continuous with those of the transversus abdominis. The intermediate fibres are oblique, while the highest are almost vertical. This muscle varies in its attachments, not only in different subjects, but on opposite sides of the same subject. The levatores costarum, 12 in number on either side, are small tendinous and fleshy bundles, which arise from the ends of the transverse processes of the 7th cervical and upper 11 thoracic vertebrae. They pass obliquely downward and lateralward, like the fibres of the intercostalis externi, and each is inserted into the outer surface of the rib immediately below the vertebra from which it takes origin, between the tubercle and the angle, levatores costarum breves. Each of the 4 lower muscles divides into 2 fasciculae, one of which is inserted as above described, the other passes down to the second rib below its origin, levatores costarum longi. The serratus posterior superior, serratus posticus superior, is a thin quadrilateral muscle situated at the upper and back part of the thorax. It arises by a thin and broad aponeurosis from the lower part of the ligamentum nuchae, from the spinous processes of the 7th cervical and upper 2 or 3 thoracic vertebrae, and from the supraspinal ligament. Inclining downward and lateralward it becomes muscular, and is inserted, by 4 fleshy digitations, into the upper borders of the 2nd, 3rd, 4th, and 5th ribs, a little beyond their angles. Variations. Increase or decrease in size and number of slips, or entire absence. The serratus posterior inferior, serratus posticus inferior, is situated at the junction of the thoracic and lumbar regions. It is of an irregularly quadrilateral form, broader than the preceding, and separated from it by a wide interval. It arises by a thin aponeurosis from the spinous processes of the lower 2 thoracic and upper 2 or 3 lumbar vertebrae, and from the supraspinal ligament. Passing obliquely upward and lateralward, it becomes fleshy, and divides into 4 flat digitations, which are inserted into the inferior borders of the lower 4 ribs, a little beyond their angles. The thin aponeurosis of origin is intimately blended with the lumbar dorsal fascia, and aponeurosis of the latissimus dorsi. Variations. Increase or decrease in size and number of slips, or entire absence. Nerves. The muscles of this group are supplied by the intercostal nerves. The diaphragm is a dome-shaped muscular fibrous septum which separates the thoracic from the abdominal cavity, its convex upper surface forming the floor of the former, and its concave under surface the roof of the latter. Its peripheral part consists of muscular fibres which take origin from the circumference of the thoracic outlet and converge to be inserted into a central tendon. The muscular fibres may be grouped according to their origins into three parts: sternal, costal, and lumbar. The sternal part arises by two fleshy slips from the back of the xiphoid process, the costal part from the inner surfaces of the cartilages and adjacent portions of the lower 6 ribs on either side, interdigitating with the transversus abdominis, and the lumbar part from the aponeurotic arches, named the lumbocostal arches, and from the lumbar vertebrae by 2 pillars or crura. There are 2 lumbocostal arches, a medial and a lateral on either side. The medial lumbocostal arch, arcus lumbocostalis medialis, Haleri, internal arcuate ligament, is a tendinous arch in the fascia covering the upper part of the psoas major. Medially it is continuous with the lateral tendinous margin of the corresponding crus, and is attached to the side of the body of the first or second lumbar vertebra. Laterally it is fixed to the front of the transverse process of the first and sometimes also to that of the second lumbar vertebra. The lateral lumbocostal arch, arcus lumbocostalis lateralis, Haleri, external arcuate ligament, arches across the upper part of the quadratus lumborum, and is attached, medially, to the front of the transverse process of the first lumbar vertebra, and, laterally, to the tip and lower margin of the 12th rib. The crura. At their origins the crura are tendinous in structure, and blend with the anterior longitudinal ligament of the vertebral column. The right crus, larger and longer than the left, arises from the anterior surfaces of the bodies and intervertebral fibrocartilages of the upper 3 lumbar vertebrae, while the left crus arises from the corresponding parts of the upper 2 only. The medial tendinous margins of the crura pass forward and medialward, and meet in the middle line to form an arch across the front of the aorta. This arch is often poorly defined. From this series of origins, the fibres of the diaphragm converge to be inserted into the central tendon. The fibres arising from the xiphoid process are very short, and occasionally aponeurotic. Those from the medial and lateral lumbocostal arches, and more especially those from the ribs and their cartilages, are longer, and describe marked curves as they ascend and converge to their insertion. The fibres of the crura diverge as they ascend, the most lateral being directed upward and lateralward to the central tendon. The medial fibres of the right crus ascend on the left side of the esophageal hiatus, and occasionally a fasciculus of the left crus crosses the aorta and runs obliquely through the fibres of the right crus toward the vena cava foramen. The central tendon. The central tendon of the diaphragm is a thin but strong aponeurosis situated near the centre of the vault formed by the muscle, but somewhat closer to the front than to the back of the thorax, so that the posterior muscular fibres are the longer. It is situated immediately below the pericardium, with which it is partially blended. It is shaped somewhat like a trefoil leaf, consisting of 3 divisions or leaflets separated from one another by slight indentations. The right leaflet is the largest, the middle directed towards the xiphoid process, the next in size, and the left the smallest. In structure the tendon is composed of several planes of fibres, which intersect one another at various angles and unite into straight or curved bundles. Section 37 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 2, by Henry Gray. Muscles of the Thorax, Part 2. Openings in the diaphragm. The diaphragm is pierced by a series of apertures to permit of the passage of structures between the thorax and the abdomen. 3 large openings, the aortic, the esophageal, and the vena cava, and a series of smaller ones are described. The aortic hiatus is the lowest and most posterior of the large apertures. It lies at the level of the 12th thoracic vertebra. Strictly speaking, it is not an aperture in the diaphragm, but an osseo-aponeurotic opening between it and the vertebral column, and therefore behind the diaphragm. Occasionally some tendinous fibres, prolonged across the bodies of the vertebrae from the medial part of the lower ends of the crura, pass behind the aorta, and thus convert the hiatus into a fibrous ring. The hiatus is situated slightly to the left of the middle line, and is bounded in front by the crura, and behind by the body of the first lumbar vertebra. Through it pass the aorta, the azygos vein, and the thoracic duct. Occasionally the azygos vein is transmitted through the right crus. The esophageal hiatus is situated in the muscular part of the diaphragm at the level of the 10th thoracic vertebra, and is elliptical in shape. It is placed above, in front, and a little to the left of the aortic hiatus, and transmits the esophagus, the vagus nerves, and some small esophageal arteries. The vena cava foramen is the highest of the 3, and is situated about the level of the fibrocartilage between the 8th and 9th thoracic vertebrae. It is quadrilateral in form, and is placed at the junction of the right and middle leaflets of the central tendon, so that its margins are tendinous. It transmits the inferior vena cava, the wall of which is adherent to the margins of the opening, and some lesser branches of the right phrenic nerve. Of the lesser apertures, 2 in the right crus transmit the greater and lesser right splanchnic nerves. 3 in the left crus give passage to the greater and lesser left splanchnic nerves and the hemiazygos vein. The gangliated trunks of the sympathetic usually enter the abdominal cavity behind the diaphragm under the medial lumbocostal arches. On either side 2 small intervals exist at which the muscular fibres of the diaphragm are deficient and are replaced by areolar tissue. One between the sternal and costal parts transmits the superior epigastric branch of the internal mammary artery, and some lymphatics from the abdominal wall and convex surface of the liver. The other, between the fibres springing from the medial and lateral lumbocostal arches, is less constant. When this interval exists, the upper and back part of the kidney is separated from the pleura by areolar tissue only. Variations. The sternal portion of the muscle is sometimes wanting, and more rarely defects occur in the lateral part of the central tendon or adjoining muscle fibres. Nerves. The diaphragm is supplied by the phrenic and lower intercostal nerves. Actions. The diaphragm is the principal muscle of inspiration, and presents the form of a dome concave towards the abdomen. The central part of the dome is tendinous, and the pericardium is attached to its upper surface. The circumference is muscular. During inspiration, the lowest ribs are fixed, and from these and the crura the muscular fibres contract and draw downward and forward the central tendon with the attached pericardium. In this movement the curvature of the diaphragm is scarcely altered, the dome moving downward nearly parallel to its original position and pushing before it the abdominal viscera. The descent of the abdominal viscera is permitted by the elasticity of the abdominal wall, but the limit of this is soon reached. The central tendon applied to the abdominal viscera then becomes a fixed point for the action of the diaphragm, the effect of which is to elevate the lower ribs and through them to push forward the body of the sternum and the upper ribs. The right cupula of the diaphragm, lying on the liver, has a greater resistance to overcome than the left, which lies over the stomach, but to compensate for this the right crus and the fibres of the right side generally are stronger than those of the left. In all expulsive acts the diaphragm is called into action to give additional power to each expulsive effort. Thus, before sneezing, coughing, laughing, crying, or vomiting, and previous to the expulsion of urine or faeces, or of the fetus from the uterus, a deep inspiration takes place. The height of the diaphragm is constantly varying during respiration. It also varies with the degree of distension of the stomach and intestines and with the size of the liver. After a forced expiration, the right cupula is on a level in front with the fourth costal cartilage, at the side with the fifth, sixth, and seventh ribs, and behind with the eighth rib. The left cupula is a little lower than the right. Hall's-Daly, Journal of Anatomy and Physiology, 1908, volume XLIII, states that the absolute range of movement between deep inspiration and deep expiration averages in the male and female 30 mm on the right side and 28 mm on the left. In quiet respiration, the average movement is 12.5 mm on the right side and 12 mm on the left. Skiography shows that the height of the diaphragm in the thorax varies considerably with the position of the body. It stands highest when the body is horizontal and the patient on his back, and in this position it performs the largest respiratory excursions with normal breathing. When the body is erect, the dome of the diaphragm falls, and its respiratory movements become smaller. The dome falls still lower when the sitting posture is assumed, and in this position its respiratory excursions are smallest. These facts may, perhaps, explain why it is that patients suffering from severe dyspnea are most comfortable and least short of breath when they sit up. When the body is horizontal and the patient on his side, the two halves of the diaphragm do not behave alike. The uppermost half sinks to a level lower even than when the patient sits, and moves little with respiration. The lower half rises higher in the thorax than it does when the patient is supine, and its respiratory excursions are much increased. In unilateral disease of the pleura or lungs, analogous interference with the position or movement of the diaphragm can generally be observed skiographically. It appears that the position of the diaphragm in the thorax depends upon three main factors, viz. 1. The elastic retraction of the lung tissue tending to pull it upward. 2. The pressure exerted on its undersurface by the viscera. This naturally tends to be a negative pressure, or downward suction, when the patient sits or stands, and positive, or an upward pressure, when he lies. 3. The intra-abdominal tension due to the abdominal muscles. These are in a state of contraction in the standing position and not in the sitting, hence the diaphragm, when the patient stands, is pushed up higher than when he sits. The intercostales interni and externi have probably no action in moving the ribs. They contract simultaneously and form strong elastic supports which prevent the intercostal spaces being pushed out or drawn in during respiration. The anterior portions of the intercostales interni probably have an additional function in keeping the sternocostal and intercondral joint surfaces in apposition. The posterior parts of the intercostales externi performing a similar function for the costovertebral articulations. The levatores costarum being inserted near the fulcra of the ribs can have little action on the ribs. They act as rotators and lateral flexors of the vertebral column. The transversus thoracis draws down the costal cartilages, and is therefore a muscle of expiration. The serrati are respiratory muscles. The serratus posterior superior elevates the ribs and is therefore an inspiratory muscle. The serratus posterior inferior draws the lower ribs downward and backward, and thus elongates the thorax. It also fixes the lower ribs, thus assisting the inspiratory action of the diaphragm and resisting the tendency it has to draw the lower ribs upward and forward. It must therefore be regarded as a muscle of inspiration. Mechanism of respiration. The respiratory movements must be examined during a. Quiet respiration, and b. Deep respiration. Quiet respiration. The first and second pairs of ribs are fixed by the resistance of the cervical structures, the last pair, and through it the 11th, by the quadratus lumborum. The other ribs are elevated so that the first two intercostal spaces are diminished while the others are increased in width. It has already been shown that elevation of the third, fourth, fifth, and sixth ribs leads to an increase in the antero-posterior and transverse diameters of the thorax. The vertical diameter is increased by the descent of the diaphragmatic dome so that the lungs are expanded in all directions except backward and upward. Elevation of the 8th, 9th, and 10th ribs is accompanied by a lateral and backward movement, leading to an increase in the transverse diameter of the upper part of the abdomen. The elasticity of the anterior abdominal wall allows a slight increase in the antero-posterior diameter of this part, and in this way the decrease in the vertical diameter of the abdomen is compensated and space provided for its displaced viscera. Expiration is effected by the elastic recoil of its walls and by the action of the abdominal muscles, which push back the viscera displaced downward by the diaphragm. Deep respiration. All the movements of quiet respiration are here carried out, but to a greater extent. In deep inspiration the shoulders and the vertebral borders of the scapulae are fixed and the limb muscles, trapezius, serratus anterior, pectoralis and latissimus dorsi are called into play. The scaleni are in strong action, and the sternocleidomastoideae also assist when the head is fixed by drawing up the sternum and by fixing the clavicles. The first rib is therefore no longer stationary, but, with the sternum, is raised. With it all the other ribs except the last are raised to a higher level. In conjunction with the increased descent of the diaphragm, this provides for a considerable augmentation of all the thoracic diameters. The anterior abdominal muscles come into action so that the umbilicus is drawn upward and backward, but this allows the diaphragm to exert a more powerful influence on the lower ribs. Transverse diameter of the upper part of the abdomen is greatly increased and the subcostal angle opened out. The deeper muscles of the back, e.g. the serrati posteriores superiores and the sacrospinalis and their continuations, are also brought into action. The thoracic curve of the vertebral column is partially straightened, and the whole column, above the lower lumbar vertebrae, drawn backward. This increases the antero-posterior diameters of the thorax and upper part of the abdomen and widens the intercostal spaces. Deep expiration is effected by the recoil of the walls and by the contraction of the anterolateral muscles of the abdominal wall, and the serrati posteriores inferiores and transversus thoracis. Hall's-Daly, of Cit, gives the following figures as representing the average changes which occurred during deepest possible respiration. The Manubrium sterni moves 30 mm in an upward and 14 mm in a forward direction. The width of the subcostal angle, at a level of 30 mm below the articulation between the body of the sternum and the xiphoid process, is increased by 26 mm.
Section 38 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. To find out more information or to volunteer, please visit LibriVox.org. Recording by Rebecca Case. Anatomy of the Human Body, Part 2, by Henry Gray. Muscles and Fascia of the Abdomen, Part 1. The muscles of the abdomen may be divided into two groups. 1. The anterolateral muscles. 2. The posterior muscles. 1. The anterolateral muscles of the abdomen. The muscles of this group are obliquus externus, obliquus internus, transversus, rectus, pyramidalis. The superficial fascia. The superficial fascia of the abdomen consists, over the greater part of the abdominal wall, of a single layer containing a variable amount of fat, but near the groin it is easily divisible into two layers, between which are found the superficial vessels and nerves and the superficial inguinal lymph glands. The superficial layer, fascia of Camper, is thick, areolar in texture, and contains in its meshes a varying quantity of adipose tissue. Below, it passes over the inguinal ligament and is continuous with the superficial fascia of the thigh. In the male, Camper's fascia is continued over the penis and outer surface of the spermatic cord to the scrotum, where it helps to form the dartos. As it passes to the scrotum, it changes its characteristics, becoming thin, destitute of adipose tissue, and of a pale reddish color. And in the scrotum it acquires some involuntary muscular fibers. From the scrotum it may be traced backward into continuity with the superficial fascia of the perineum. In the female, Camper's fascia is continued from the abdomen into the labia majora. The deep layer, fascia of Scarpa, is thinner and more membranous in character than the superficial, and contains a considerable quantity of yellow elastic fibers. It is loosely connected by areolar tissue to the aponeuroses of the obliquus externus abdominis, but in the middle line it is more intimately adherent to the linea alba and to the pubic symphysis, and is prolonged onto the dorsum of the penis, forming the fundiform ligament. Above, it is continuous with the superficial fascia over the rest of the trunk. Below and laterally, it blends with the fascia lata of the thigh a little below the inguinal ligament. Medially and below, it is continued over the penis and spermatic cord to the scrotum, where it helps to form the dartos. From the scrotum it may be traced backward into continuity with the deep layer of the superficial fascia of the perineum, fascia of Colles. In the female it is continued into the labia majora and thence to the fascia of Colles. The obliquus externus abdominis, external or descending oblique muscle, situated on the lateral and anterior parts of the abdomen, is the largest and the most superficial of the three flat muscles in this region. It is broad, thin, and irregularly quadrilateral, its muscular portion occupying the side, its aponeurosis the anterior wall of the abdomen. It arises by 8 fleshy digitations from the external surfaces and inferior borders of the lower 8 ribs. These digitations are arranged in an oblique line which run downward and backward, the upper ones being attached close to the cartilages of the corresponding ribs, the lowest to the apex of the cartilage of the last rib, the intermediate ones to the ribs at some distance from their cartilages. The 5 superior serrations increase in size from above downward and are received between corresponding processes of the serratus anterior. The 3 lower ones diminish in size from above downward and receive between them corresponding processes from the latissimus dorsi. From these attachments the fleshy fibers proceed in various directions. Those from the lowest ribs pass nearly vertically downward and are inserted into the anterior half of the outer lip of the iliac crest. The middle and upper fibers, directed downward and forward, end in an aponeurosis, opposite a line drawn from the prominence of the 9th costal cartilage to the anterior superior iliac spine. The aponeurosis of the obliquus externus abdominis is a thin but strong membranous structure, the fibers of which are directed downward and medialward. It is joined with that of the opposite muscle along the middle line and covers the whole of the front of the abdomen. Above, it is covered by and gives origin to the lower fibers of the pectoralis major. Below, its fibers are closely aggregated together and extend obliquely across from the anterior superior iliac spine to the pubic tubercle and the pectineal line. In the middle line, it interlaces with the aponeurosis of the opposite muscle, forming the linea alba, which extends from the xiphoid process to the symphysis pubis. That portion of the aponeurosis which extends between the anterior superior iliac spine and the pubic tubercle is a thick band, folded inward and continuous below with the fascia lata. It is called the inguinal ligament. The portion which is reflected from the inguinal ligament at the pubic tubercle is attached to the pectineal line and is called the lacunar ligament. From the point of attachment of the latter to the pectineal line, a few fibers pass upward and medialward behind the medial crus of the subcutaneous inguinal ring to the linea alba. They diverge as they ascend and form a thin triangular fibrous band which is called the reflected inguinal ligament. In the aponeurosis of the obliquus externus, immediately above the crest of the pubis, is a triangular opening, the cutaneous inguinal ring, formed by a separation of the fibers of the aponeurosis in this situation. The following structures require further description, viz., the subcutaneous inguinal ring, the intracrural fibers and fascia, and the inguinal, lacunar, and reflected inguinal ligaments. The subcutaneous inguinal ring, annulus inguinus subcutaneous, external abdominal ring. The subcutaneous inguinal ring is an interval in the aponeurosis of the obliquus externus, just above and lateral to the crest of the pubis. The aperture is oblique in direction, somewhat triangular in form, and corresponds with the course of the fibers of the aponeurosis. It usually measures from base to apex about 2.5 centimeters, and transversely about 1.25 centimeters. It is bounded below by the crest of the pubis, on either side by the margins of the opening in the aponeurosis, which are called the crura of the ring, and above by a series of curved intercrural fibers. The inferior crus, external pillar, is the stronger and is formed by that portion of the inguinal ligament which is inserted into the pubic tubercle. It is curved so as to form a kind of groove, upon which, in the male, the spermatic cord rests. The superior crus, or internal pillar, is a broad, thin, flat band attached to the front of the symphysis pubis and interlacing with its fellow on the opposite side. The subcutaneous inguinal ring gives passage to the spermatic cord and ilioinguinal nerve in the male, and to the round ligament of the uterus and the ilioinguinal nerve in the female. It is much larger in men than in women, on account of the large size of the spermatic cord. The intracrural fibers, fibrae intracruralis, intercolumnar fibers. The intracrural fibers are a series of curved tendinous fibers which arch across the lower part of the aponeurosis of the obliquus externus, describing curves with the convexities downward. They have received their name from stretching across between the two crura of the subcutaneous inguinal ring, and they are much thicker and stronger at the inferior crus, where they are connected to the inguinal ligament, than superiorly, where they are inserted into the linea alba. The intracrural fibers increase the strength of the lower part of the aponeurosis and prevent the divergence of the crura from one another. They are more strongly developed in the male than in the female. As they pass across the subcutaneous inguinal ring, they are connected together by delicate fibrous tissue, forming a fascia, called the intracrural fascia. This intracrural fascia is continued down as a tubular prolongation around the spermatic cord and testes, and encloses them in a sheath. Hence it is also called the external spermatic fascia. The subcutaneous inguinal ring is seen as a distinct aperture only after the intracrural fascia has been removed. The inguinal ligament, ligamentum inguinale, Poparte, or Popart's ligament. The inguinal ligament is the lower border of the aponeurosis of the obliquus externus, and extends from the anterior superior iliac spine to the pubic tubercle. From this latter point it is reflected backward and lateralward to be attached to the pectineal line for about 1.25 centimeters, forming the lacunar ligament. Its general direction is convex downward toward the thigh, where it is continuous with the fascia lata. Its lateral half is rounded and oblique in direction. Its medial half gradually widens at its attachment to the pubis, and is more horizontal in direction, and lies beneath the spermatic cord. The lacunar ligament, ligamentum lacunar, Gimbernati, Gimbernaut's ligament. The lacunar ligament is that part of the aponeuroses of the obliquus externus which is reflected backward and lateralward and is attached to the pectineal line. It is about 1.25 centimeters long, larger in the male than in the female, almost horizontal in direction in the erect posture, and of a triangular form with the base directed lateralward. Its base is concave, thin, and sharp, and forms the medial boundary of the femoral ring. Its apex corresponds to the pubic tubercle. Its posterior margin is attached to the pectineal line, and is continuous with the pectineal fascia. Its anterior margin is attached to the inguinal ligament. Its surfaces are directed upward and downward. The reflected inguinal ligament, ligamentum inguinale reflexum, Colesi, triangular fascia. The reflected inguinal ligament is a layer of tendinous fibers of a triangular shape, formed by an expansion from the lacunar ligament and the inferior crus of the subcutaneous inguinal ring. It passes medialward behind the spermatic cord and expands into a somewhat fan-shaped band lying behind the superior crus of the subcutaneous inguinal ring and in front of the inguinal aponeurotic falx, and interlaces with the ligament on the other side of the linea alba. Ligament of Cooper. This is a strong fibrous band which was first described by Sir Astley Cooper. It extends lateralward from the base of the lacunar ligament along the pectineal line to which it is attached. It is strengthened by the pectineal fascia and by a lateral expansion from the lower attachment of the linea alba. Ad maniculum lineae albae. Variations. The obliquus externus may show decrease or doubling of its attachments to the ribs. Addition slips from lumbar aponeurosis. Doubling between lower ribs and ilium or inguinal ligament. Rarely tendinous inscriptions occur. The obliquus internus abdominis, internal or ascending oblique muscle, thinner and smaller than the obliquus externus, beneath which it lies, is of an irregularly quadrilateral form, and situated at the lateral and anterior parts of the abdomen. It arises, by fleshy fibers, from the lateral half of the grooved upper surface of the inguinal ligament, from the anterior 2/3 of the middle lip of the iliac crest, and from the posterior lamina of the lumbodorsal fascia. From this origin the fibers diverge. Those from the inguinal ligament, few in number and paler in color than the rest, arch downward and medialward across the spermatic cord in the male, and the round ligament of the uterus in the female, and, becoming tendinous, are inserted, conjointly with those of the transversus, into the crest of the pubis and medial part of the pectineal line behind the lacunar ligament, forming what is known as the inguinal aponeurotic falx. Those from the anterior third of the iliac origin are horizontal in their direction and, becoming tendinous along the lower fourth of the linea semilunaris, pass in front of the rectus abdominis to be inserted into the linea alba. Those arising from the middle third of the iliac origin run obliquely upward and medialward and end in an aponeurosis. This divides at the lateral border of the rectus into two laminae, which are continued forward, one in front of and the other behind this muscle, to the linea alba. The posterior lamina has an attachment to the cartilages of the 7th, 8th, and 9th ribs. The most posterior fibers pass almost vertically upward to be inserted into the inferior borders of the cartilages of the lower 3 ribs, being continuous with the intercostalis interni. Variations. Occasionally, tendinous inscriptions occur from the tips of the 10th or 11th cartilages or even from the ninth. An additional slip to the ninth cartilage is sometimes Section 39 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. To find out more information or to volunteer, please visit LibriVox.org. Recording by Rebecca Case. Anatomy of the Human Body, Part 2, by Henry Gray. Muscles and Fascia of the Abdomen, Part 2. The cremaster is a thin muscular layer composed of a number of fasciculi which arise from the middle of the inguinal ligament, where its fibers are continuous with those of the obliquus internus, and also occasionally with the transversus. It passes along the lateral side of the spermatic cord, descends with it through the subcutaneous inguinal ring upon the front and sides of the cord, and forms a series of loops which differ in thickness and length in different subjects. At the upper part of the cord the loops are short, but they become in succession longer and longer, the longest reaching down as low as the testis, where a few are inserted into the tunica vaginalis. These loops are united together by areolar tissue and form a thin covering over the cord and testis, the cremasteric fascia. The fibers ascend along the medial side of the cord and are inserted by a small pointed tendon into the tubercle and crest of the pubis, and into the front of the sheath of the rectus abdominis. The transversus abdominis, transversalis muscle, so called from the direction of its fibers, is the most internal of the flat muscles of the abdomen, being placed immediately beneath the obliquus internus. It arises, by fleshy fibers, from the lateral third of the inguinal ligament, from the anterior 3/4 of the inner lip of the iliac crest, from the inner surfaces of the cartilages of the lower 6 ribs, interdigitating with the diaphragm, and from the lumbo-dorsal fascia. The muscle ends in front in a broad aponeurosis, the lower fibers of which curve downward and medialward, and are inserted, together with those of the obliquus internus, into the crest of the pubis and pectineal line, forming the inguinal aponeurotic falx. Throughout the rest of its extent the aponeurosis passes horizontally to the middle line, as inserted into the linea alba. Its upper 3/4 lie behind the rectus and blend with the posterior lamina of the aponeurosis of the obliquus internus. Its lower fourth is in front of the rectus. Variations. It may be more or less fused with the obliquus internus or absent. The spermatic cord may pierce its lower border. Slender muscle slips from the iliopectineal line to transversalis fascia, the aponeurosis of the transversus abdominis, or the outer end of the linea semicircularis, and other slender slips are occasionally found. The inguinal aponeurotic falx, falx aponeurotica inguinalis, conjoined tendon of internal oblique and transversalis muscle, of the obliquus internus and transversus, is mainly formed by the lower part of the tendon of the transversus, and is inserted into the crest of the pubis and pectineal line immediately behind the subcutaneous inguinal ring, serving to protect what would otherwise be a weak point in the abdominal wall. Lateral to the falx is a ligamentous band connected with the lower margin of the transversus and extending down in front of the inferior epigastric artery to the superior ramus of the pubis. It is termed the interfoveolar ligament of Hasselbeck and sometimes contains a few muscular fibers. The rectus abdominis is a long, flat muscle which extends along the whole length of the front of the abdomen and is separated from its fellow on the opposite side by the linea alba. It is much broader, but thinner, above than below, and arises by 2 tendons. The lateral or larger is attached to the crest of the pubis, The medial interlaces with its fellow of the opposite side, and is connected with the ligaments covering the front of the symphysis pubis. The muscle is inserted by 3 portions of unequal size into the cartilages of the 5th, 6th, and 7th ribs. The upper portion, attached principally to the cartilage of the 5th rib, usually has some fibers of insertion into the anterior extremity of the rib itself. Some fibers are occasionally connected with the costoxiphoid ligaments and the side of the xiphoid process. The rectus is crossed by fibrous bands, 3 in number, which are named the tendinous inscriptions. One is usually situated opposite the umbilicus, one at the extremity of the xiphoid process, and the third about midway between the xiphoid process and the umbilicus. These inscriptions pass transversely or obliquely across the muscle in a zigzag course. They rarely extend completely through its substance, and may pass only halfway across it. They are intimately adherent in front to the sheath of the muscle. Sometimes 1 or 2 additional inscriptions, generally incomplete, are present below the umbilicus. The rectus is enclosed in a sheath formed by the aponeuroses of the obliqui and transversus, which are arranged in the following manner. At the lateral margin of the rectus, the aponeuroses of the obliquus internus divides into 2 laminae, one of which passes in front of the rectus, blending with the aponeuroses of the obliquus externus, the other behind it, blending with the aponeuroses of the transversus, and these, joining again at the medial border of the rectus, are inserted into the linea alba. This arrangement of the aponeuroses exists from the costal margin to midway between the umbilicus and the symphysis pubis, where the posterior wall of the sheath ends in a thin curved margin, the linea semicircularis, the concavity of which is directed downward. Below this level the aponeurosis of all 3 muscles passes in front of the rectus. The rectus, in the situation where its sheath is deficient below, is separated from the peritoneum by the transversalis fascia. Since the tendons of the obliquus internus and transversus only reach as high as the costal margin, it follows that above this level the sheath of the rectus is deficient behind, the muscle resting directly on the cartilages of the ribs, and being covered merely by the tendon of the obliquus externus. The pyramidalis is a small triangular muscle placed at the lower part of the abdomen in front of the rectus and contained in the sheath of that muscle. It arises by tendinous fibers from the front of the pubis and the anterior pubic ligament. The fleshy portion of the muscle passes upward, diminishing in size as it ascends, and ends by a pointed extremity which is inserted into the linea alba, midway between the umbilicus and pubis. This muscle may be wanting on one or both sides. The lower end of the rectus then becomes proportionately increased in size. Occasionally it is double on one side, and the muscles of the 2 sides are sometimes of unequal size. It may extend higher than the level stated. Beside the rectus and pyramidalis, the sheath of the rectus contains the superior and inferior epigastric arteries and the lower intercostal nerves. Variations. The rectus may insert as high as the 4th or 3rd rib, or may fail to reach the 5th. Fibers may spring from the lower part of the linea alba. Nerves. The abdominal muscles are supplied by the lower intercostal nerves. The obliquus internus and transversus also receive filaments from the anterior branch of the iliohypogastric and sometimes from the ilioinguinal. The cremaster is supplied by the external spermatic branch of the genitofemoral and the pyramidalis usually by the 12th thoracic. The linea alba. The linea alba is a tendinous raphe in the middle line of the abdomen, stretching between the xiphoid process and the symphysis pubis. It is placed between the medial borders of the recti and is formed by the blending of the aponeurosis of the obliqui and transversi. It is narrow below, corresponding to the linear interval existing between the recti, but broader above, where these muscles diverge from one another. At its lower end, the linea alba has a double attachment, its superficial fibers passing in front of the medial heads of the recti to the symphysis pubis, while its deeper fibers form a triangular lamina, attached behind the recti to the posterior lip of the crest of the pubis, and named the admeniculum lineae albae. It presents apertures for the passage of vessels and nerves. The umbilicus, which in the fetus exists as an aperture and transmits the umbilical vessels, is closed in the adult. The lineae semilunaris. The lineae seminularis are two curved tendinous lines placed one on either side of the linea alba. Each corresponds with the lateral border of the rectus, extends from the cartilage of the ninth rib to the pubic tubercle, and is formed by the aponeuroses of the obliquus internus at its line of division to enclose the rectus, reinforced in front by that of the obliquus externus and behind by that of the transversus. Actions. When the pelvis and thorax are fixed, the abdominal muscles compress the abdominal viscera by constricting the cavity of the abdomen, in which action they are materially assisted by the descent of the diaphragm. By these means assistance is given in expelling the feces from the rectum, the urine from the bladder, the fetus from the uterus, and the contents of the stomach in vomiting. If the pelvis and the vertebral column be fixed, these muscles compress the lower part of the thorax, materially assisting expiration. If the pelvis alone be fixed, the thorax is bent directly forward when the muscles of both sides act. When the muscles of only one side contract, the trunk is bent toward that side and rotated toward the opposite side. If the thorax be fixed, the muscles, acting together, draw the pelvis upward, as in climbing, or, acting singly, they draw the pelvis upward and bend the vertebral column to one side or the other. The recti, acting from below, depress the thorax and consequently flex the vertebral column. When acting from above, they flex the pelvis upon the vertebral column. The pyramidalis are tensors of the linea alba. The transversalis fascia. The transversalis fascia is a thin aponeurotic membrane which lies between the inner surface of the transversus and the extraperitoneal fat. It forms part of the general layer of fascia lining the abdominal parodes and is directly continuous with the iliac and pelvic fasciae. In the inguinal region, the transversalis fascia is thick and dense in structure and is joined by fibers from the aponeuroses of the transversus, but it becomes thin as it ascends to the diaphragm and blends with the fascia covering the undersurface of this muscle. Behind, it is lost in the fat which covers the posterior surfaces of the kidney. Below, it has the following attachments. Posteriorly, to the whole length of the iliac crest, between the attachments of the transversus and iliacus, between the anterior superior iliac spine and the femoral vessels, it is connected to the posterior margin of the inguinal ligament, and is there continuous with the iliac fascia. Medial to the femoral vessels, it is thin and attached to the pubis and pectineal line, behind the inguinal aponeurotic falx, with which it is united. It descends in front of the femoral vessels to form the anterior wall of the femoral sheath. Beneath the inguinal ligament it is strengthened by a band of fibrous tissue, which is only loosely connected to the ligament, and is specialized as a deep crural arch. The spermatic cord in the male and the round ligament of the uterus in the female pass through the transversalis fascia at a spot called the abdominal inguinal ring. This opening is not visible externally, since the transversalis fascia is prolonged on these structures as the infundibuliform fascia. The abdominal inguinal ring. Annulus inguinalis abdominis, internal or deep abdominal ring. The abdominal inguinal ring is situated in the transversalis fascia, midway between the anterior superior iliac spine and the symphysis pubis, and about 1.25 centimeters above the inguinal ligament. It is of an oval form, the long axis of the oval being vertical. It varies in size in different subjects, and is much larger in the male than in the female. It is bounded, above and laterally, by the arched lower margins of the transversus, below and medially by the inferior epigastric vessels. It transmits the spermatic cord in the male and the round ligament of the uterus in the female. From its circumference, a thin funnel-shaped membrane, the infundibuliform fascia, is continued around the cord and the testis, enclosing them in a distinct covering. The inguinal canal, Canalus inguinalis, spermatic canal. The inguinal canal contains the spermatic cord and the ilioinguinal nerve in the male, and the round ligament of the uterus and the ilioinguinal nerve in the female. It is an oblique canal about 4 centimeters long, slanting downward and medialward, and placed parallel with and a little above the inguinal ligament. It extends from the abdominal inguinal ring to the subcutaneous inguinal ring. It is bounded in front by the integument and superficial fascia, by the aponeuroses of the obliquus externus throughout its whole length, and by the obliquus internus in its lateral third. Behind, by the reflected inguinal ligament, the inguinal aponeurotic falx, the transversalis fascia, the extraperitoneal connective tissue, and the peritoneum. Above, by the arched fibers of the obliquus internus and the transversus abdominis. Below, by the union of the transversalis fascia with the inguinal ligament, and at its medial end by the lacunar ligament. Extraperitoneal connective tissue. Between the inner surface of the general layer of the fascia, which lines the interior of the abdominal and pelvic cavities, and the peritoneum, there is a considerable amount of connective tissue termed the extraperitoneal or subperitoneal connective tissue. The parietal portion lines the cavity in varying quantities in different situations. It is especially abundant on the posterior wall of the abdomen, and particularly around the kidneys, where it contains much fat. On the anterior wall of the abdomen, except in the pubic region, and on the lateral wall above the iliac crest, it is scanty, and here the transversalis fascia is more closely connected with the peritoneum. There is a considerable amount of extraperitoneal connective tissue in the pelvis. The visceral portion follows the course of the branches of the abdominal aorta between the layers of the mesenterics and other folds of the peritoneum which connect the various viscera to the abdominal wall. The two portions are directly continuous with each other. The deep crural arch. Curving over the external iliac vessels at the spot where they become femoral, on the abdominal side of the inguinal ligaments and loosely connected with it, is a thickened band of fibers called the deep crural arch. It is apparently a thickening of the transversalis fascia joined laterally to the center of the lower margin of the inguinal ligament, and arching across the front of the femoral sheath to be inserted by a broad attachment into the pubic tubercle and pectineal line, behind the inguinal aponeurotic falx. In some subjects this structure is not very prominently marked, and not infrequently it is altogether wanting. 2. The posterior muscles of the abdomen. Psoas major, psoas minor, iliacus, quadratus lumborum. The psoas major, the psoas minor, and the iliacus, with the fasciae covering them, will be described with the muscles of the lower extremity. See page 466. The fasciae covering the quadratus lumborum. This is a thin layer attached medially to the bases of the transverse processes of the lumbar vertebrae, below to the iliolumbar ligament, above to the apex and lower border of the last rib. The upper margin of this fascia, which extends from the transverse process of the first lumbar vertebra to the apex and lower border of the last rib, constitutes the lateral lumbocostal arch, page 405. Laterally, it blends with the lumbodorsal fascia, the anterior layer of which intervenes between the quadratus lumborum and the sacrospinalis. The quadratus lumborum, page 398, is irregularly quadrilateral in shape and broader above than below. It arises by aponeurotic fibers from the iliolumbar ligament and the adjacent portion of the iliac crest for about 5 centimeters, and is inserted into the lower border of the last rib for about half its length, and by 4 small tendons into the apices of the transverse processes of the upper 4 lumbar vertebrae. Occasionally, a second portion of this muscle is found in front of the preceding. It arises from the upper borders of the transverse processes of the lower 3 or 4 lumbar vertebrae, and is inserted into the lower margin of the last rib. In front of the quadratus lumborum are the colon, the kidney, the psoas major and minor, and the diaphragm. Between the fascia and the muscle are the 12th thoracic, iliolinguinal, and iliohypogastric nerves. Variations. The number of attachments to the vertebrae and the extent of its attachment to the last rib vary. Nerve supply. The 12th thoracic and 1st and 2nd lumbar nerves supply this muscle. Actions. The quadratus lumborum draws down the last rib and acts as a muscle of inspiration by helping to fix the origin of the diaphragm. If the thorax and vertebral column are fixed, it may act upon the pelvis, raising it toward its own side when only one muscle is put in action, and when
Section 40 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Ann Walden. Anatomy of the Human Body, Part 2, by Henry Gray. The muscles and fascia of the pelvis. Obturator internus, piriformis, levator ani, coccygeus. The muscles within the pelvis may be divided into 2 groups. 1. The obturator internus and the piriformis, which are muscles of the lower extremity, and will be described with these. 2. The levator ani and the coccygeus, which together form the pelvic diaphragm, and are associated with the pelvic viscera. The classification of the 2 groups under a common heading is convenient in connection with the fascia investing the muscles. These fascia are closely related to one another and to the deep fascia of the perineum, and in addition have special connections with the fibrous coverings of the pelvic viscera. It is customary, therefore, to describe them together under the term pelvic fascia. Pelvic fascia. The fascia of the pelvis may be resolved into a. The fascial sheaths of the obturator internus, piriformis, and pelvic diaphragm. B. The fascia associated with the pelvic viscera. The fascia of the obturator internus covers the pelvic surface of, and is attached around, the margin of the origin of the muscle. Above, it is loosely connected to the back part of the arcuate line, and here it is continuous with the iliac fascia. In front of this, as it follows the line of origin of the obturator internus, it gradually separates from the iliac fascia, and the continuity between the 2 is retained only through the periosteum. It arches beneath the obturator vessels and nerve, completing the obturator canal, and at the front of the pelvis is attached to the back of the superior ramus of the pubis. Below, the obturator fascia is attached to the falciform process of the sacrotuberous ligament, and to the pubic arch, where it becomes continuous with the superior fascia of the urogenital diaphragm. Behind, it is prolonged into the gluteal region. The internal pudendal vessels and pudendal nerve cross the pelvic surface of the obturator internus and are enclosed in a special canal, Alcock's canal, formed by the obturator fascia. The fascia of the piriformis is very thin, and is attached to the front of the sacrum and the sides of the greater sciatic foramen. It is prolonged on the muscle into the gluteal region. At its sacral attachment around the margins of the anterior sacral foramina, it comes into intimate association with and ensheathes the nerves emerging from these foramina. Hence, the sacral nerves are frequently described as lying behind the fascia. The internal iliac vessels and their branches, on the other hand, lie in the subperitoneal tissue in front of the fascia, and the branches to the gluteal region emerge in special sheaths of this tissue, above and below the piriformis muscle. The diaphragmatic part of the pelvic fascia covers both surfaces of the levatores ani. The inferior layer is known as the anal fascia. It is attached above to the obturator fascia along the line of origin of the levator ani, while below it is continuous with the superior fascia of the urogenital diaphragm and with the fascia on the sphincter ani internus. The layer covering the upper surface of the pelvic diaphragm follows, above, the line of origin of the levator ani, and is therefore somewhat variable. In front, it is attached to the back of the symphysis pubis, about 2 centimeters above its lower border. It can then be traced laterally across the back of the superior ramus of the pubis for a distance of about 1.25 centimeters, when it reaches the obturator fascia. It is attached to this fascia along a line which pursues a somewhat irregular course to the spine of the ischium. The irregularity of this line is due to the fact that the origin of the levator ani, which in lower forms is from the pelvic brim, is in man lower down, on the obturator fascia. Tendinous fibers of origin of the muscle are therefore often found extending up toward, and in some cases reaching, the pelvic brim, and on these the fascia is carried. It will be evident that the fascia covering that part of the obturator internus which lies above the origin of the levator ani is a composite fascia, and includes the following: a. The obturator fascia. b. The fascia of the levator ani. c. Degenerated fibers of origin of the levator ani. The lower margin of the fascia covering the upper surface of the pelvic diaphragm is attached along the line of insertion of the levator ani. At the level of a line extending from the lower part of the symphysis pubis to the spine of the ischium is a thickened whitish band in this upper layer of the diaphragmatic part of the pelvic fascia. It is termed the tendinous arch, or white line of the pelvic fascia, and marks the line of attachment of the special fascia, pars endopelvina fascia pelvis, which is associated with the pelvic viscera. The endopelvic part of the pelvic fascia is continued over the various pelvic viscera to form for them fibrous coverings which will be described later. See section on splanknology. It is attached to the diaphragmatic part of the pelvic fascia along the tendinous arch, and has been subdivided in accordance with the viscera to which it is related. Thus its anterior part, known as the vesical layer, forms the anterior and lateral ligaments of the bladder. Its middle part crosses the floor of the pelvis between the rectum and vesiculae seminales as the recto-vesical layer. In the female this is perforated by the vagina. Its posterior portion passes to the side of the rectum. It forms a loose sheath for the rectum, but is firmly attached around the anal canal. This portion is known as the rectal layer. The levator ani is a broad, thin muscle situated on the side of the pelvis. It is attached to the inner surface of the side of the lesser pelvis, and unites with its fellow of the opposite side to form the greater part of the floor of the pelvic cavity. It supports the viscera in this cavity, and surrounds the various structures which pass through it. It arises, in front, from the posterior surface of the superior ramus of the pubis lateral to the symphysis, behind from the inner surface of the spine of the ischium, and between these 2 points from the obturator fascia. Posteriorly, this fascial origin corresponds, more or less closely, with the tendinous arch of the pelvic fascia, but in front the muscle arises from the fascia at a varying distance above the arch, in some cases reaching nearly as high as the canal for the obturator vessels and nerve. The fibers pass downward and backward to the middle line of the floor of the pelvis. The most posterior are inserted into the side of the last two segments of the coccyx. Those placed more anteriorly unite with the muscle of the opposite side, in a median fibrous raphe, anococcygeal raphe, which extends between the coccyx and the margin of the anus. The middle fibers are inserted into the side of the rectum, blending with the fibers of the sphincter muscles. Lastly, the anterior fibers descend upon the side of the prostate, to unite beneath it with the muscle of the opposite side, joining with the fibers of the sphincter ani externus and transversus perineai, at the central tendinous point of the perineum. The anterior portion is occasionally separated from the rest of the muscle by connective tissue. From this circumstance, as well as from its peculiar relation with the prostate, which it supports as in a sling, it has been described as a distinct muscle under the name of levator prostatae. In the female, the anterior fibers of the levator ani descend upon the side of the vagina. The levator ani may be divided into iliococcygeal and pubococcygeal parts. The iliococcygeus arises from the ischial spine and from the posterior part of the tendinous arch of the pelvic fascia, and is attached to the coccyx and anococcygeal raphe. It is usually thin, and may fail entirely, or be largely replaced by fibrous tissue. An accessory slip at its posterior part is sometimes named the iliosacralis. The pubococcygeus arises from the back of the pubis and from the anterior part of the obturator fascia, and is directed backward almost horizontally along the side of the anal canal toward the coccyx and sacrum, to which it finds attachment. Between the termination of the vertebral column and the anus, the two pubococcygeal muscles come together and form a thick fibromuscular layer lying on the raphe formed by the iliococcygeae. Peter Thompson. The greater part of this muscle is inserted into the coccyx and into the last one or two pieces of the sacrum. This insertion into the vertebral column is, however, not admitted by all observers. The fibers which form a sling for the rectum are named the puborectalis, or sphincter recti. They arise from the lower part of the symphysis pubis, and from the superior fascia of the urogenital diaphragm. They meet with the corresponding fibers of the opposite side around the lower part of the rectum, and form for it a strong sling. Nerve supply. The levator ani is supplied by a branch from the fourth sacral nerve, and by a branch which is sometimes derived from the perineal, sometimes from the inferior hemorrhoidal division of the pudendal nerve. The coccygeus is situated behind the preceding. It is a triangular plane of muscular and tendinous fibers, arising, by its apex, from the spine of the ischium and sacrospinous ligament, and inserted, by its base, into the margin of the coccyx, and into the side of the lowest piece of the sacrum. It assists the levator ani and piriformis in closing in the back part of the outlet of the pelvis. Nerve supply. The coccygeus is supplied by a branch from the fourth and fifth sacral nerves. Actions. The levatores ani constrict the lower end of the rectum and vagina. They elevate and invert the lower end of the rectum after it has been protruded and everted during the expulsion of the feces. They are also muscles of forced expiration. The coccygeae pull forward and support the coccyx after it has been pressed backward during defecation or parturition. The levatores Section 41 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Ann Walden. Anatomy of the Human Body, Part 2, by Henry Gray. The muscles and fascia of the perineum. The perineum corresponds to the outlet of the pelvis. Its deep boundaries are, in front, the pubic arch and the arcuate ligament of the pubis, behind, the tip of the coccyx, and on either side the inferior rami of the pubis and ischium, and the sacrotuberous ligament. The space is somewhat lozenge-shaped, and is limited on the surface of the body by the scrotum in front, by the buttocks behind, and laterally by the medial side of the thigh. A line drawn transversely across in front of the ischial tuberosities divides the space into two portions. The posterior contains the termination of the anal canal, and is known as the anal region. The anterior, which contains the external urogenital organs, is termed the urogenital region. The muscles of the perineum may therefore be divided into two groups. 1. Those of the anal region. 2. Those of the urogenital region, A in the male, B in the female. 1. The muscles of the anal region. Corrugator cutis ani, sphincter ani externus, sphincter ani internus. The superficial fascia. The superficial fascia is very thick, areolar in texture, and contains much fat in its meshes. On either side a pad of fatty tissue extends deeply between the levator ani and obturator internus into a space known as the ischiorectal fossa. The deep fascia. The deep fascia forms the lining of the ischiorectal fossa. It comprises the anal fascia and the portion of the obturator fascia below the origin of levator ani. Ischiorectal fossa. Fossa ischiorectalis. The fossa is somewhat prismatic in shape, with its base directed to the surface of the perineum and its apex at the line of meeting of the obturator and anal fascia. It is bounded medially by the sphincter ani externus and the anal fascia, laterally by the tuberosity of the ischium and the obturator fascia, anteriorly by the fascia of Colles, covering the transversus perinei superficialis, and by the inferior fascia of the urogenital diaphragm, posteriorly by the gluteus maximus and the sacrotuberous ligament. Crossing the space transversely are the inferior hemorrhoidal vessels and nerves. At the back part are the perineal and perforating cutaneous branches of the pudendal plexus, while from the fore part the posterior scrotal or labial vessels and nerves emerge. The internal pudendal vessels and pudendal nerve lie in Alcock's canal on the lateral wall. The fossa is filled with fatty tissue, across which numerous fibrous bands extend from side to side. The corrugator cutis ani. Around the anus is a thin stratum of involuntary muscular fiber which radiates from the orifice. Medially the fibers fade off into the submucous tissue, while laterally they blend with the true skin. By its contraction it raises the skin into ridges around the margin of the anus. The sphincter ani externus, external sphincter ani, is a flat plane of muscular fibers, elliptical in shape, and intimately adherent to the integument surrounding the margin of the anus. It measures about 8 to 10 centimeters in length, from its anterior to its posterior extremity, and is about 2.5 centimeters broad, opposite the anus. It consists of two strata, superficial and deep. The superficial, constituting the main portion of the muscle, arises from a narrow tendinous band, the anococcygeal raphe, which stretches from the tip of the coccyx to the posterior margin of the anus. It forms two flattened planes of muscular tissue, which encircle the anus and meet in front to be inserted into the central tendinous point of the perineum, joining with the transversus perineae superficialis, the levator ani, and the bulbo cavernosus. The deeper portion forms a complete sphincter to the anal canal. Its fibers surround the canal, closely applied to the sphincter ani internus, and in front blend with the other muscles at the central point of the perineum. In a considerable proportion of cases, the fibers decussate in front of the anus, and are continuous with the transversi perineae superficiales. Posteriorly they are not attached to the coccyx, but are continuous with those of the opposite side behind the anal canal. The upper edge of the muscle is ill defined, since fibers are given off from it to join the levator ani. Nerve supply. A branch from the fourth sacral and twigs from the inferior hemorrhoidal branch of the pudendal supply the muscle. Actions. The action of this muscle is peculiar. 1. It is, like other muscles, always in a state of tonic contraction, and having no antagonistic muscle, it keeps the anal canal and orifice closed. 2. It can be put into a condition of greater contraction under the influence of the will, so as more firmly to occlude the anal aperture in expiratory efforts unconnected with defecation. 3. Taking its fixed point at the coccyx, it helps to fix the central point of the perineum, so that the bulbo cavernosus may act from this fixed point. The sphincter ani internus, internal sphincter ani, is a muscular ring which surrounds about 2.5 centimeters of the anal canal. Its inferior border is in contact with, but quite separate from, the sphincter ani externus. It is about 5 millimeters thick, and is formed by an aggregation of the involuntary circular fibers of the intestine. Its lower border is about 6 millimeters from the orifice of the anus. Actions. Its action is entirely involuntary. It helps the sphincter ani externus to occlude the anal aperture and aids in the expulsion of the feces. 2. A. The muscles of the urogenital region in the male. Transversus perineae superficialis, bulbo cavernosus, ischio cavernosus, transversus perineae profundus, sphincter urethrae membranaceae. Superficial fascia. The superficial fascia of this region consists of two layers, superficial and deep. The superficial layer is thick, loose, areolar in texture, and contains in its meshes much adipose tissue, the amount of which varies in different subjects. In front it is continuous with the dartose tunic of the scrotum, behind with the subcutaneous areolar tissue surrounding the anus, and on either side with the same fascia on the inner sides of the thigh. In the middle line it is adherent to the skin on the raphe and to the deep layer of the superficial fascia. The deep layer of superficial fascia, fascia of Colles, is thin, aponeurotic in structure, and of considerable strength, serving to bind down the muscles of the root of the penis. It is continuous in front with the dartose tunic, the deep fascia of the penis, the fascia of the spermatic cord, and Scarpa's fascia upon the anterior wall of the abdomen. On either side it is firmly attached to the margins of the rami of the pubis and ischium, lateral to the crus penis, and as far back as the tuberosity of the ischium. Posteriorly it curves around the transversi perineae superficialis, to join the lower margin of the inferior fascia of the urogenital diaphragm. In the middle line it is connected with the superficial fascia and with the median septum of the bulbo cavernosus. This fascia not only covers the muscles in this region, but at its back part sends upward a vertical septum from its deep surface, which separates the posterior portion of the subjacent space into two. the central tendinous point of the perineum. This is a fibrous point in the middle line of the perineum between the urethra and anus, and about 1.25 centimeters in front of the latter. At this point 6 muscles converge and are attached, that is, the sphincter ani externus, the bulbo cavernosus, the 2 transversi perinei superficialis, and the anterior fibers of the levatorius ani. The transversus perinei superficialis, transversus perinei, superficial transverse perineal muscle, is a narrow muscular slip which passes more or less transversely across the perineal space in front of the anus. It arises by tendinous fibers from the inner and fore part of the tuberosity of the ischium, and, running medialward, is inserted into the central tendinous point of the perineum, joining in this situation with the muscle of the opposite side, with the sphincter ani externus behind, and with the bulbo cavernosus in front. In some cases the fibers of the deeper layer of the sphincter ani externus decussate in front of the anus and are continued into this muscle. Occasionally it gives off fibers which join with the bulbo cavernosus of the same side. Variations are numerous. It may be absent or double, or insert into the bulbo cavernosus or external sphincter. Actions. The simultaneous contraction of the 2 muscles serves to fix the central tendinous point of the perineum. The bulbo cavernosus, ejaculator urinae, accelerator urinae, is placed in the middle line of the perineum, in front of the anus. It consists of 2 symmetrical parts, united along the median line by a tendinous raphe. It arises from the central tendinous point of the perineum and from the median raphe in front. Its fibers diverge like the barbs of a quill pen. The most posterior form a thin layer, which is lost on the inferior fascia of the urogenital diaphragm. The middle fibers encircle the bulb and adjacent parts of the corpus cavernosum urethrae, and join with the fibers of the opposite side on the upper part of the corpus cavernosum urethrae, in a strong aponeurosis. The anterior fibers spread out over the side of the corpus cavernosum penis, to be inserted partly into that body, anterior to the ischiocavernosus, occasionally extending to the pubis, and partly ending in a tendinous expansion which covers the dorsal vessels of the penis. The latter fibers are best seen by dividing the muscle longitudinally, and reflecting it from the surface of the corpus cavernosum urethrae. Actions. This muscle serves to empty the canal of the urethra after the bladder has expelled its contents. During the greater part of the act of micturition its fibers are relaxed, and it only comes into action at the end of the process. The middle fibers are supposed by Krause to assist in the erection of the corpus cavernosum urethrae by compressing the erectile tissue of the bulb. The anterior fibers, according to Terrell, also contribute to the erection of the penis by compressing the deep dorsal vein of the penis as they are inserted into, and continuous with, the fascia of the penis. The ischiocavernosus, erector penis, covers the crus penis. It is an elongated muscle, broader in the middle than at either end, and situated on the lateral boundary of the perineum. It arises by tendinous and fleshy fibers from the inner surface of the tuberosity of the ischium behind the crus penis, and from the rami of the pubis and ischium on either side of the crus. From these points fleshy fibers succeed and end in an aponeurosis which is inserted into the sides and undersurface of the crus penis. Action. The ischiocavernosus compresses the crus penis and retards the return of the blood through the veins, and thus serves to maintain the organ erect. Between the muscles just examined a triangular space exists, bounded medially by the bulbo cavernosus, laterally by the ischiocavernosus, and behind by the transversus perinei superficialis. The floor is formed by the inferior fascia of the urogenital diaphragm. Running from behind forward in the space are the posterior scrotal vessels and nerves, and the perineal branch of the posterior femoral cutaneous nerve. The transverse perineal artery courses along its posterior boundary on the transversus perinei superficialis. The deep fascia. The deep fascia of the urogenital region forms an investment for the transversus perinei profundus and the sphincter urethrae membranaceae, but within it lie also the deep vessels and nerves of this part, the whole forming a transverse septum, which is known as the urogenital diaphragm. From its shape it is usually termed the triangular ligament, and is stretched almost horizontally across the pubic arch, so as to close, in the front part, the outlet of the pelvis. It consists of two dense membranous laminae, which are united along their posterior borders, but are separated in front by intervening structures. The superficial of these two layers, the inferior fascia of the urogenital diaphragm, is triangular in shape and about 4 centimeters in depth. Its apex is directed forward, and is separated from the arcuate pubic ligament by an oval opening for the transmission of the deep dorsal vein of the penis. Its lateral margins are attached on either side to the inferior rami of the pubis and ischium, above the crus penis. Its base is directed toward the rectum, and connected to the central tendinous point of the perineum. It is continuous with the deep layer of the superficial fascia behind the transversus perinei superficialis, and with the inferior layer of the diaphragmatic part of the pelvic fascia. It is perforated, about 2.5 centimeters below the symphysis pubis, by the urethra, the aperture for which is circular and about 6 millimeters in diameter, by the arteries to the bulb and the ducts of the bulbourethral glands close to the urethral orifice, by the deep arteries of the penis, one on either side, close to the pubic arch, and about halfway along the attached margin of the fascia, by the dorsal arteries and nerves of the penis near the apex of the fascia. Its base is also perforated by the perineal vessels and nerves, while between its apex and the arcuate pubic ligament, the deep dorsal vein of the penis passes upward into the pelvis. If the inferior fascia of the urogenital diaphragm be detached on either side, the following structures will be seen between it and the superior fascia: the deep dorsal vein of the penis, the membranous portion of the urethra, the transversus perinei profundus and sphincter urethrae membranaceae muscles, the bulbourethral glands and their ducts, the pudendal vessels and dorsal nerves of the penis, the arteries and nerves of the urethral bulb, and a plexus of veins. The superior fascia of the urogenital diaphragm is continuous with the obturator fascia and stretches across the pubic arch. If the obturator fascia be traced medially after leaving the obturator internus muscle, it will be found attached by some of its deeper or anterior fibers to the inner margin of the pubic arch, while its superficial or posterior fibers pass over this attachment to become continuous with the superior fascia of the urogenital diaphragm. Behind, this layer of the fascia is continuous with the inferior fascia and with the fascia of Colles. In front it is continuous with the fascial sheath of the prostate, and is fused with the inferior fascia to form the transverse ligament of the pelvis. The transversus perinei profundus arises from the inferior rami of the ischium and runs to the median line, where it interlaces in a tendinous raphe with its fellow of the opposite side. It lies in the same plane as the sphincter urethrae membranaceae. Formerly the two muscles were described together as the constrictor urethrae. The sphincter urethrae membranaceae surrounds the whole length of the membranous portion of the urethra, and is enclosed in the fascia of the urogenital diaphragm. Its external fibers arise from the junction of the inferior rami of the pubis and ischium to the extent of 1.25 to 2 centimeters, and from the neighboring fascia. They arch across the front of the urethra and bulbourethral glands, pass around the urethra, and behind it unite with the muscle of the opposite side by means of a tendinous raphe. Its innermost fibers form a continuous circular investment for the membranous urethra. Nerve supply. The perineal branch of the pudendal nerve supplies this group of muscles. Actions. The muscles of both sides act together as a sphincter, compressing the membranous portion of the urethra. During the transmission of fluids, they, like the bulbocavernosus, are relaxed, and only come into action at the end of the process to eject the last drops of the fluid. 2b. The muscles of the urogenital region in the female. Transversus perineae superficialis, bulbocavernosus, ischiocavernosus, transversus perineae profundus, sphincter urethrae membranaceae. The transversus perineae superficialis, transversus perineae, superficial transverse perineal muscle, in the female is a narrow muscular slip, which arises by a small tendon from the inner and fore part of the tuberosity of the ischium, and is inserted into the central tendinous point of the perineum, joining in this situation with the muscle of the opposite side, the sphincter ani externus behind, and the bulbocavernosus in front. Action. The simultaneous contraction of the two muscles serves to fix the central tendinous point of the perineum. The bulbocavernosus, sphincter vaginae, surrounds the orifice of the vagina. It covers the lateral parts of the vestibular bulbs, and is attached posteriorly to the central tendinous point of the perineum, where it blends with the sphincter ani externus. Its fibers pass forward on either side of the vagina to be inserted into the corpora cavernosa clitoridis, a fasciculus crossing over the body of the organ so as to compress the deep dorsal vein. Actions. The bulbocavernosus diminishes the orifice of the vagina. The anterior fibers contribute to the erection of the clitoris, as they are inserted into and are continuous with the fascia of the clitoris, compressing the deep dorsal vein during the contraction of the muscle. The ischiocavernosus, erector clitoridis, is smaller than the corresponding muscle in the male. It covers the unattached surface of the crus clitoridis. It is an elongated muscle, broader at the middle than at either end, and situated on the side of the lateral boundary of the perineum. It arises by tendinous and fleshy fibers from the inner surface of the tuberosity of the ischium, behind the crus clitoridis, from the surface of the crus, and from the adjacent portion of the ramus of the ischium. From these points fleshy fibers succeed and end in an aponeurosis, which is inserted into the sides and under surface of the crus clitoridis. Actions. The ischiocavernosus compresses the crus clitoridis and retards the return of blood through the veins, and thus serves to maintain the organ erect. The fascia of the urogenital diaphragm in the female is not so strong as in the male. It is attached to the pubic arch, its apex being connected with the arcuate pubic ligament. It is divided in the middle line by the aperture of the vagina, with the external coat of which it becomes blended, and in front of this is perforated by the urethra. Its posterior border is continuous, as in the male, with the deep layer of the superficial fascia around the transversus perineae superficialis. Like the corresponding fascia in the male, it consists of 2 layers, between which are to be found the following structures: the deep dorsal vein of the clitoris, a portion of the urethra and the constrictor urethra muscle, the larger vestibular glands and their ducts, the internal pudendal vessels, and the dorsal nerves of the clitoris, the arteries and nerves of the bulbi vestibuli, and a plexus of veins. The transversus perineae profundus arises from the inferior rami of the ischium, and runs across to the side of the vagina. The sphincter urethrae membranaceae, constrictor urethrae, like the corresponding muscle on the male, consists of external and internal fibers. The external fibers arise on either side from the margin of the inferior ramus of the pubis. They are directed across the pubic arch in front of the urethra, and pass around it to blend with the muscular fibers of the opposite side, between the urethra and vagina. The innermost fibers encircle the lower end of the urethra.
Section 42 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Selena Arter. Anatomy of the Human Body, Part 2, by Henry Gray. 7. The fascia and muscles of the upper extremity. A. The muscles connecting the upper extremity to the vertebral column. The muscles of this group are trapezius, latissimus dorsi, rhomboideus major, rhomboideus minor, levator scapulae. Superficial fascia. The superficial fascia of the back forms a layer of considerable thickness and strength, and contains a quantity of granular fat. It is continuous with the general superficial fascia. Deep fascia. The deep fascia is a dense fibrous layer attached above to the superior nuchal line of the occipital bone. In the middle line it is attached to the ligamentum nuchae and supraspinal ligament, and to the spinous processes of all the vertebrae below the seventh cervical. Laterally, in the neck, it is continuous with the deep cervical fascia. Over the shoulder, it is attached to the spine of the scapula and to the acromion, and is continued downward over the deltoideus to the arm. On the thorax, it is continuous with the deep fascia of the axilla and chest, and on the abdomen with that covering the abdominal muscles. Below, it is attached to the crest of the ilium. The trapezius is a flat, triangular muscle covering the upper and back part of the neck and shoulders. It arises from the external occipital protuberance and the medial third of the superior nuchal line of the occipital bone, from the ligamentum nuchae, the spinous process of the seventh cervical, and the spinous processes of all the thoracic vertebrae, and from the corresponding portion of the supraspinal ligament. From this origin, the superior fibers proceed downward and lateralward, the inferior upward and lateralward, and the middle horizontally. The superior fibers are inserted into the posterior border of the lateral third of the clavicle, the middle fibers into the medial margin of the acromion, and into the superior lip of the posterior border of the spine of the scapula. The inferior fibers converge near the scapula and end in an aponeurosis, which glides over the smooth triangular surface on the medial end of the spine to be inserted into a tubercle at the apex of the smooth triangular surface. At its occipital origin, the trapezius is connected to the bone by a thin fibrous lamina, firmly adherent to the skin. At the middle, it is connected to the spinous processes by a broad, semi-elliptical aponeurosis, which reaches from the sixth cervical to the third thoracic vertebrae and forms, with that of the opposite muscle, a tendinous ellipse. The rest of the muscle arises by numerous short tendinous fibers. The two trapezius muscles together resemble a trapezium, or diamond-shaped quadrangle. Two angles corresponding to the shoulders, a third to the occipital protuberance, and the fourth to the spinous process of the 12th thoracic vertebra. Variations. The attachments to the dorsal vertebrae are often reduced, and the lower ones are often wanting. The occipital attachment is often wanting. Separation between cervical and dorsal portions is frequent. Extensive deficiencies and complete absence occur. The clavicular insertion of this muscle varies in extent. It sometimes reaches as far as the middle of the clavicle, and occasionally may blend with the posterior edge of the sternocleidomastoideus or overlap it. The latissimus dorsi is a triangular, flat muscle which covers the lumbar region and the lower half of the thoracic region, and is generally contracted into a narrow fasciculus at its insertion into the humerus. It arises by tendinous fibers from the spinous processes of the lower 6 thoracic vertebrae and from the posterior layer of the lumbodorsal fascia, by which it is attached to the spines of the lumbar and sacral vertebrae, to the supraspinal ligament, and to the posterior part of the crest of the ilium. It also arises by muscular fibers from the external lip of the crest of the ilium, lateral to the margin of the sacrospinalis, and from the 3 or 4 lower ribs by fleshy digitations, which are interposed between similar processes of the obliquus abdominis externus. From this extensive origin the fibers pass in different directions, the upper ones horizontally, the middle obliquely upward, and the lower vertically upward, so as to converge and form a thick fasciculus, which crosses the inferior angle of the scapula and usually receives a few fibers from it. The muscle curves around the lower border of the teres major, and is twisted upon itself so that the superior fibers become at first posterior and then inferior, and the vertical fibers at first anterior and then superior. It ends in a quadrilateral tendon, about 7 centimeters long, which passes in front of the tendon of the teres major and is inserted into the bottom of the intertubercular groove of the humerus. Its insertion extends higher on the humerus than that of the tendon of the pectoralis major. The lower border of its tendon is united with that of the teres major, the surfaces of the two being separated near their insertions by a bursa. Another bursa is sometimes interposed between the muscle and the inferior angle of the scapula. The tendon of the muscle gives off an expansion to the deep fascia of the arm. Variations. The number of dorsal vertebrae to which it is attached vary from 4 to 7 or 8. The number of costal attachments varies. Muscle fibers may or may not reach the crest of the ilium. A muscular slip, the axillary arch, varying from 7 to 10 centimeters in length and from 5 to 15 millimeters in breadth, occasionally springs from the upper edge of the latissimus dorsi about the middle of the posterior fold of the axilla, and crosses the axilla in front of the axillary vessels and nerves, to join the undersurface of the tendon of the pectoralis major, the coracobrachialis, or the fascia over the biceps brachii. This axillary arch crosses the axillary artery, just above the spot usually selected for the application of a ligature, and may mislead the surgeon during the operation. It is present in about 7% of subjects and may be easily recognized by the transverse direction of its fibers. A fibrous slip usually passes from the lower border of the tendon of the latissimus dorsi, near its insertion, to the long head of the triceps brachii. This is occasionally muscular, and is the representative of the dorso-epitrochlearis brachii of apes. The lateral margin of the latissimus dorsi is separated below from the obliquus externus abdominis by a small triangular interval, the lumbar triangle of Petit, the base of which is formed by the iliac crest, and its floor by the obliquus internus abdominis. Another triangle is situated behind the scapula. It is bounded above by the trapezius, below by the latissimus dorsi, and laterally by the vertebral border of the scapula. The floor is partly formed by the rhomboideus major. If the scapula be drawn forward by folding the arms across the chest and the trunk bent forward, parts of the 6th and 7th ribs and the interspace between them become subcutaneous and available for osculation. The space is therefore known as the triangle of osculation. Nerves. The trapezius is supplied by the accessory nerve, and by branches from the 3rd and 4th cervical nerves, the latissimus dorsi by the 6th, 7th, and 8th cervical nerves through the thoracodorsal, long subscapular, nerve. The rhomboideus major arises by tendinous fibers from the spinous processes of the 2nd, 3rd, 4th, and 5th thoracic vertebrae and the supraspinal ligament, and is inserted into a narrow tendinous arch, attached above to the lower part of the triangular surface at the root of the spine of the scapula, below to the inferior angle, the arch being connected to the vertebral border by a thin membrane. When the arch extends, as it occasionally does, only a short distance, the muscular fibers are inserted directly into the scapula. The rhomboideus minor arises from the lower part of the ligamentum nuchae, and from the spinous processes of the 7th cervical and 1st thoracic vertebrae. It is inserted into the base of the triangular smooth surface at the root of the spine of the scapula, and is usually separated from the rhomboideus major by a slight interval, but the adjacent margins of the two muscles are occasionally united. Variations. The vertebral and scapular attachments of the two muscles vary in extent. A small slip from the scapula to the occipital bone close to the minor occasionally occurs. The rhomboideus occipitalis muscle. The levator scapulae, levator anguli scapulae, is situated at the back and side of the neck. It arises by tendinous slips from the transverse processes of the atlas and axis, from the posterior tubercles of the transverse processes of the 3rd and 4th cervical vertebrae. It is inserted into the vertebral border of the scapula, between the medial angle and the triangular smooth surface at the root of the spine. Variations. The number of vertebral attachments varies. A slip may extend to the occipital or mastoid, to the trapezius, scalene, or serratus anterior, or to the 1st or 2nd rib. The muscle may be subdivided into several distinct parts from origin to insertion. Levator claviculae, from the transverse processes of 1 or 2 upper cervical vertebrae to the outer end of the clavicle, corresponds to a muscle of lower animals, more or less union with the serratus anterior. Nerves. The rhomboidei are supplied by the dorsal scapular nerve from the 5th cervical, the levator scapulae by the 3rd and 4th cervical nerves, and frequently by a branch from the dorsal scapular. Actions. The movements effected by the preceding muscles are numerous, as may be conceived from their extensive attachments. When the whole trapezius is in action, it retracts the scapula and braces back the shoulder. If the head be fixed, the upper part of the muscle will elevate the point of the shoulder, as in supporting weights. When the lower fibers contract, they assist in depressing the scapula. The middle and lower fibers of the muscle rotate the scapula, causing elevation of the acromion. If the shoulders be fixed, the trapezii acting together will draw the head directly backward, or if only one act, the head is drawn to the corresponding side. When the latissimus dorsi acts upon the humerus, it depresses and draws it backward, and at the same time rotates it inward. It is the muscle which is principally employed in giving a downward blow, as in felling a tree or in saber practice. If the arm be fixed, the muscle may act in various ways upon the trunk. Thus, it may raise the lower ribs and assist in forcible inspiration. Or, if both arms be fixed, the two muscles may assist the abdominal muscles and pectoralis in suspending and drawing the trunk forward, as in climbing. If the head be fixed, the levator scapulae raises the medial angle of the scapula. If the shoulder be fixed, the muscle inclines the neck to the corresponding side and rotates it in the same direction. The rhomboidai carry the inferior angle backward and upward, thus producing a slight rotation of the scapula upon the side of the chest. The rhomboideus major acting especially on the inferior angle of the scapula, through the tendinous arch by which it is inserted. The rhomboidai acting together with the middle and inferior fibers of the Section 43 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Selena Arter. Anatomy of the Human Body, Part 2, by Henry Gray. The muscles connecting the upper extremity to the anterior and lateral thoracic walls. The muscles of the anterior and lateral thoracic regions are pectoralis major, pectoralis minor, subclavius, serratus anterior, superficial fascia. The superficial fascia of the anterior thoracic region is continuous with that of the neck and upper extremity above, and of the abdomen below. It encloses the mamma and gives off numerous septa which pass into the gland, supporting its various lobes. From the fascia over the front of the mamma, fibrous processes pass forward to the integument and papilla. These were called by Sir A. Cooper the ligamenta suspensoria. Pectoral fascia. The pectoral fascia is a thin lamina covering the surface of the pectoralis major and sending numerous prolongations between its fasciculi. It is attached, in the middle line, to the front of the sternum, above to the clavicle. Laterally and below it is continuous with the fascia of the shoulder, axilla, and thorax. It is very thin over the upper part of the pectoralis major, but thicker in the interval between it and the latissimus dorsi, where it closes in the axillary space and forms the axillary fascia. It divides at the lateral margin of the latissimus dorsi into two layers, one of which passes in front of and the other behind it. These proceed as far as the spinous processes of the thoracic vertebrae to which they are attached. As the fascia leaves the lower edge of the pectoralis major to cross the floor of the axilla, it sends a layer upward under cover of the muscle. This lamina splits to envelop the pectoralis minor, at the upper edge of which it is continuous with the corticoclavicular fascia. The hollow of the armpit, seen when the arm is abducted, is produced mainly by the traction of this fascia on the axillary floor, and hence the lamina is sometimes named the suspensory ligament of the axilla. At the lower part of the thoracic region, the deep fascia is well developed, and is continuous with the fibrous sheaths of the recti abdominis. The pectoralis major is a thick, fan-shaped muscle situated at the upper and forepart of the chest. It arises from the anterior surface of the sternal half of the clavicle, from half the breadth of the anterior surface of the sternum, as low down as the attachment of the cartilage of the 6th or 7th rib, from the cartilages of all the true ribs, with the exception frequently of the 1st or 7th, or both, and from the aponeuroses of the obliquus externus abdominis. From this extensive origin the fibers converge toward their insertion. Those arising from the clavicle pass obliquely downward and lateralward, and are usually separated from the rest by a slight interval. Those from the lower part of the sternum, and the cartilages of the lower true ribs, run upward and lateralward, while the middle fibers pass horizontally. They all end at a flat tendon, about 5 centimeters broad, which is inserted into the crest of the greater tubercle of the humerus. This tendon consists of 2 laminae, placed one in front of the other, and usually blended together below. The anterior lamina, the thicker, receives the clavicular and the uppermost sternal fibers. They are inserted in the same order as that in which they arise, that is to say, the most lateral of the clavicular fibers are inserted at the upper part of the anterior lamina. The uppermost sternal fibers pass down to the lower part of the lamina, which extends as low as the tendon of the deltoideus and joins with it. The posterior lamina of the tendon receives the attachment of the greater part of the sternal portion and the deep fibers, i.e., those from the costal cartilages. These deep fibers, and particularly those from the lower costal cartilages, ascend the higher, turning backwards successively behind the superficial and upper ones, so that the tendon appears to be twisted. The posterior lamina reaches higher on the humerus than the anterior one, and from it an expansion is given off, which covers the intertubercular groove, and blends with the capsule of the shoulder joint. From the deepest fibers of this lamina at its insertion an expansion is given off, which lines the intertubercular groove, while from the lower border of the tendon a third expansion passes downward to the fascia of the arm. Variations. The more frequent variations are greater or less extent of attachment to the ribs and sternum, varying size of the abdominal part or its absence, greater or less extent of separation of sternocostal and clavicular parts, fusion of clavicular part with deltoid, decussation in front of the sternum. Deficiency or absence of the sternocostal part is not uncommon. Absence of the clavicular part is less frequent. Rarely the whole muscle is wanting. Costocoracoideus is a muscular band occasionally found arising from the ribs or aponeuroses of the external oblique between the pectoralis major and latissimus dorsi and inserted into the coracoid process. Chondroepitroclearis is a muscular slip, occasionally found arising from the costal cartilages or from the aponeuroses of the external oblique below the pectoralis major or from the pectoralis major itself. The insertion is variable on the inner side of the arm to fascia, intermuscular septum, or internal condyle. Sternalis. In front of the sternal end of the pectoralis major, parallel to the margin of the sternum. It is supplied by the anterior thoracic nerves and is probably a misplaced part of the pectoralis. Coracoclavicular fascia. Fascia coracoclavicularis, costocoracoid membrane, clavipectoral fascia. The coracoclavicular fascia is a strong fascia situated under cover of the clavicular portion of the pectoralis major. It occupies the interval between the pectoralis minor and subclavius, and protects the axillary vessels and nerves. Traced upward, it splits to enclose the subclavius, and its 2 layers are attached to the clavicle, one in front of and the other behind the muscle. The latter layer fuses with the deep cervical fascia and with the sheath of the axillary vessels. Medially, It blends with the fascia covering the first two intercostal spaces, and is attached also to the first rib medial to the origin of the subclavius. Laterally it is very thick and dense, and is attached to the coracoid process. The portion extending from the first rib to the coracoid process is often whiter and denser than the rest, and is sometimes called the costocoracoid ligament. Below this it is thin, and at the upper border of the pectoralis minor it splits into two layers to invest the muscle. From the lower border of the pectoralis minor it is continued downward to join the axillary fascia, and lateralward to join the fascia over the short head of the biceps brachii. The coracoclavicular fascia is pierced by the cephalic vein, thoracoacromial artery and vein, and external anterior thoracic nerve. The pectoralis minor is a thin, triangular muscle situated at the upper part of the thorax, beneath the pectoralis major. It arises from the upper margins and outer surfaces of the third, fourth, and fifth ribs, near their cartilage, and from the aponeuroses covering the intercostalis. The fibers pass upward and lateralward and converge to form a flat tendon, which is inserted into the medial border and upper surface of the coracoid process of the scapula. Variations. Origin from second, third, and fourth or fifth ribs. The tendon of insertion may extend over the coracoid process to the greater tubercle, may be split into several parts. Absence rare. Pectoralis minimus. First rib cartilage to coracoid process. Rare. The subclavius is a small triangular muscle placed between the clavicle and the first rib. It arises by a short, thick tendon from the first rib and its cartilage at their junction, in front of the costoclavicular ligament. The fleshy fibers proceed obliquely upward and lateralward to be inserted into the groove on the under surface of the clavicle between the costoclavicular and conoid ligaments. Variations. Insertion into coracoid process instead of clavicle or into both clavicle and coracoid process. Sternoscapular fasciculus to the upper border of scapula. Sternoclavicularis from Manubrium to clavicle between pectoralis major and coracoclavicular fascia. The serratus anterior, serratus magnus, is a thin muscular sheet situated between the ribs and the scapula at the upper and lateral part of the chest. It arises by fleshy digitations from the outer surfaces and superior borders of the upper 8 or 9 ribs, and from the aponeuroses covering the intervening intercostales. Each digitation, except the first, arises from the corresponding rib. The first springs from the first and second ribs, and from the fascia covering the first intercostal space. From this extensive attachment the fibers pass backward, closely applied to the chest wall, and reach the vertebral border of the scapula, and are inserted into its ventral surface in the following manner. The first digitation is inserted into a triangular area on the ventral surface of the medial angle. The next 2 digitations spread out to form a thin, triangular sheet, the base of which is directed backward and is inserted into nearly the whole length of the ventral surface of the vertebral border. The lower 5 or 6 digitations converge to form a fan-shaped mass, the apex of which is inserted, by muscular and tendinous fibers, into a triangular impression on the ventral surface of the inferior angle. The lower 4 slips interdigitate at their origins with the upper 5 slips of the obliquus externus abdominis. Variations. Attachment to 10th rib. Absence of attachments to first rib, to one or more of the lower ribs. Division into 3 parts. Absence or defect of middle part. Union with levator scapulae. External intercostals or external oblique. Nerves. The pectoralis major is supplied by the medial and lateral anterior thoracic nerves. Through these nerves, the muscle receives filaments from all the spinal nerves entering into the formation of the brachial plexus. The pectoralis minor receives its fibers from the 8th cervical and 1st thoracic nerves through the medial anterior thoracic nerve. The subclavius is supplied by a filament from the 5th and 6th cervical nerves. The serratus anterior is supplied by the long thoracic, which is derived from the 5th, 6th, and 7th cervical nerves. Actions. If the arm has been raised by the deltoideus, the pectoralis major will, conjointly with the latissimus dorsi and teres major, depress it to the side of the chest. If acting alone, it adducts and draws forward the arm, bringing it across the front of the chest, and at the same time rotates it inward. The pectoralis minor depresses the point of the shoulder, drawing the scapula downward and medialward toward the thorax, and throwing the inferior angle backward. The subclavius depresses the shoulder, carrying it downward and forward. When the arms are fixed, all 3 of these muscles act upon the ribs, drawing them upward and expanding the chest, and thus becoming very important agents in forced inspiration. The serratus anterior, as a whole, carries the scapula forward and at the same time raises the vertebral border of the bone. It is therefore concerned in the action of pushing. Its lower and stronger fibers move forward the lower angle and assist the trapezius in rotating the bone at the sternoclavicular joint, and thus assist this muscle in raising the acromion and supporting weights upon the shoulder. It is also an assistant to the deltoideus in raising the arm, inasmuch as during the action of this latter muscle it fixes the scapula and so steadies the glenoid cavity on which the head of the humerus rotates. After the deltoideus has raised the arm to a right angle with the trunk, the serratus anterior and the trapezius, by rotating the scapula, raise the arm into an almost vertical position. It is possible that when the shoulders are fixed, the lower fibers of the serratus anterior may assist in raising and everting the ribs, but it is
Section 44 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 2, by Henry Gray. The muscles and fasciae of the shoulder. In this group are included deltoideus, subscapularis, supraspinatus, infraspinatus, teres minor, teres major. Deep fascia. The deep fascia covering the deltoideus invests the muscle and sends numerous septa between its fasciculi. In front it is continuous with the fascia covering the pectoralis major, behind, where it is thick and strong, with that covering the infraspinatus. Above it is attached to the clavicle, the acromion, and the spine of the scapula. Below it is continuous with the deep fascia of the arm. The deltoideus, deltoid muscle, is a large, thick, triangular muscle which covers the shoulder joint in front, behind, and laterally. It arises from the anterior border and upper surface of the lateral third of the clavicle, from the lateral margin and upper surface of the acromion, and from the lower lip of the posterior border of the spine of the scapula, as far back as the triangular surface at its medial end. From this extensive origin the fibers converge toward their insertion, the middle passing vertically, the anterior obliquely backward and lateralward, the posterior obliquely forward and lateralward. They unite in a thick tendon which is inserted into the deltoid prominence on the middle of the lateral side of the body of the humerus. At its insertion, the muscle gives off an expansion to the deep fascia of the arm. This muscle is remarkably coarse in texture, and the arrangement of its fibers is somewhat peculiar. The central portion of the muscle, that is to say, the part arising from the acromion, consists of oblique fibers. These arise in a bipeniform manner from the sides of the tendinous intersections, generally 4 in number, which are attached above to the acromion and pass downward parallel to one another in the substance of the muscle. The oblique fibers thus formed are inserted into similar tendinous intersections, generally 3 in number, which pass upward from the insertion of the muscle and alternate with the descending septa. The portions of the muscle arising from the clavicle and spine of the scapula are not arranged in this manner, but are inserted into the margins of the inferior tendon. Variations. Large variations uncommon. More or less splitting common. Continuation into the trapezius, fusion with the pectoralis major, additional slips from the vertebral border of the scapula, infraspinous fascia and axillary border of scapula not uncommon. Insertion varies in extent or rarely is prolonged to origin of brachioradialis. Nerves. The deltoideus is supplied by the 5th and 6th cervical through the axillary nerve. Actions. The deltoideus raises the arm from the side so as to bring it at right angles with the trunk. Its anterior fibers, assisted by the pectoralis major, draw the arm forward, and its posterior fibers, aided by the teres major and latissimus dorsi, draw it backward. Subscapular fascia. Fascia subscapularis. The subscapular fascia is a thin membrane attached to the entire circumference of the subscapular fossa, and affording attachment by its deep surface to some of the fibers of the subscapularis. The subscapularis is a large triangular muscle which fills the subscapular fossa and arises from its medial 2/3 and from the lower 2/3 of the groove on the axillary border of the bone. Some fibers arise from tendinous laminae which intersect the muscle and are attached to ridges on the bone, others from an aponeurosis which separates the muscle from the teres major and the long head of the triceps brachii. The fibers pass lateralward and, gradually converging, end in a tendon which is inserted into the lesser tubercle of the humerus and the front of the capsule of the shoulder joint. The tendon of the muscle is separated from the neck of the scapula by a large bursa which communicates with the cavity of the shoulder joint through an aperture in the capsule. Nerves. The subscapularis is supplied by the 5th and 6th cervical nerves through the upper and lower subscapular nerves. Actions. The subscapularis rotates the head of the humerus inward. When the arm is raised, it draws the humerus forward and downward. It is a powerful defense to the front of the shoulder joint, preventing displacement of the head of the humerus. Supraspinatus fascia. Fascia supraspinata. The supraspinatus fascia completes the osteofibrous case in which the supraspinatus muscle is contained. It affords attachment by its deep surface to some of the fibers of the muscle. It is thick medially but thinner laterally under the coracoacromial ligament. The supraspinatus occupies the whole of the supraspinatus fossa, arising from its medial 2/3 and from the strong supraspinatus fascia. The muscular fibers converge to a tendon which crosses the upper part of the shoulder joint and is inserted into the highest of the 3 impressions on the greater tubercle of the humerus. The tendon is intimately adherent to the capsule of the shoulder joint. Infraspinatus fascia, fascia infraspinata. The infraspinatus fascia is a dense fibrous membrane covering the infraspinatus muscle and fixed to the circumference of the infraspinatus fossa. It affords attachment by its deep surface to some fibers of that muscle. It is intimately attached to the deltoid fascia along the overlapping border of the deltoideus. The infraspinatus is a thick triangular muscle which occupies the chief part of the infraspinatus fossa. It arises by fleshy fibers from its medial 2/3 and by tendinous fibers from the ridges on its surface. It also arises from the infraspinatus fascia which covers it and separates it from the teres major and minor. The fibers converge to a tendon which glides over the lateral border of the spine of the scapula, and passing across the posterior part of the capsule of the shoulder joint, is inserted into the middle impression on the greater tubercle of the humerus. The tendon of this muscle is sometimes separated from the capsule of the shoulder joint by a bursa, which may communicate with the joint cavity. The teres minor is a narrow, elongated muscle which arises from the dorsal surface of the axillary border of the scapula for the upper two-thirds of its extent, and from two aponeurotic laminae, one of which separates it from the infraspinatus, the other from the teres major. Its fibers run obliquely upward and lateralward. The upper ones end in a tendon which is inserted into the lowest of the three impressions on the greater tubercle of the humerus. The lowest fibers are inserted directly into the humerus immediately below this impression. The tendon of this muscle passes across and is united with the posterior part of the capsule of the shoulder joint. Variations. It is sometimes inseparable from the infraspinatus. The teres major is a thick but somewhat flattened muscle, which arises from the oval area on the dorsal surface of the inferior angle of the scapula, and from the fibrous septa interposed between the muscle and the teres minor and infraspinatus. The fibers are directed upward and lateralward, and end in a flat tendon about 5 centimeters long, which is inserted into the crest of the lesser tubercle of the humerus. The tendon at its insertion lies behind that of the latissimus dorsi, from which it is separated by a bursa, the two tendons being, however, united along their lower borders for a short distance. Nerves. The supraspinatus and infraspinatus are supplied by the 5th and 6th cervical nerves through the suprascapular nerve, the teres minor by the 5th cervical through the axillary, and the teres major by the 5th and 6th cervical through the lowest subscapular. Actions. The supraspinatus assists the deltoideus in raising the arm from the side of the trunk, and fixes the head of the humerus in the glenoid cavity. The infraspinatus and teres minor rotate the head of the humerus outward. They also assist in carrying the arm backward. One of the most important uses of these three muscles is to protect the shoulder joint, the supraspinatus supporting it above, and the infraspinatus and teres minor behind. The teres major assists the latissimus dorsi in drawing the previously raised humerus downward and backward, and in rotating it inward. When the arm is fixed, it may assist the pec.
Section 45 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Anatomy of the Human Body, Part 2, by Henry Gray. Muscles and fascia of the arm. The muscles of the arm are coracobrachialis, brachialis, biceps brachii, triceps brachii. Brachial fascia, fascia brachii, deep fascia of the arm. The brachial fascia is continuous with that covering the deltoides and the pectoralis major, by means of which it is attached above to the clavicle, acromion, and spine of the scapula. It forms a thin, loose, membranous sheath for the muscles of the arm, and sends septa between them. It is composed of fibres disposed in a circular or spiral direction, and connected together by vertical and oblique fibres. It differs in thickness at different parts, being thin over the biceps brachii, but thicker where it covers the triceps brachii, and over the epicondyles of the humerus. It is strengthened by fibrous aponeuroses, derived from the pectoralis major and latissimus dorsi medially, and from the deltoideus laterally. On either side it gives off a strong intermuscular septum, which is attached to the corresponding supracondylar ridge and epicondyle of the humerus. The lateral intramuscular septum extends from the lowest part of the crest of the greater tubercle along the lateral supracondylar ridge to the lateral epicondyle. It is blended with the tendon of the deltoideus, gives attachment to the triceps brachii behind, to the brachialis, brachioradialis, and extensor carpi radialis longus in front, and is perforated by the radial nerve and profunda branch of the branchial artery. The medial intermuscular septum, thicker than the preceding, extends from the lower part of the crest of the lesser tubercle of the humerus below the teres major, along the medial supracondylar ridge to the medial epicondyle. It is blended with the tendon of the coracobrachialis, and affords attachment to the triceps brachii behind and the brachialis in front. It is perforated by the ulnar nerve, the superior ulnar collateral artery, and the posterior branch of the inferior ulnar collateral artery. At the elbow, the deep fascia is attached to the epicondyles of the humerus and the olecranon of the ulna, and is continuous with the deep fascia of the forearm. Just below the middle of the arm, on its medial side, is an oval opening in the deep fascia, which transmits the basilic vein and some lymphatic vessels. The coracobrachialis, the smallest of the three muscles in this region, is situated at the upper and medial part of the arm. It arises from the apex of the coracoid process, in common with the short head of the biceps brachii, and from the intermuscular septum between the two muscles. It is inserted by means of a flat tendon into an impression at the middle of the medial surface and border of the body of the humerus, between the origins of the triceps brachii and brachialis. It is perforated by the muscular cutaneous nerve. Variations. A bony head may reach the medial epicondyle. A short head, more rarely found, may insert into the lesser tubercle. The biceps brachii, biceps flexocubiti, is a long fusiform muscle placed on the front of the arm and arising by two heads, from which circumstance it has received its name. The short head arises by a thick flattened tendon from the apex of the coracoid process, in common with the coracobrachialis. The long head arises from the supraglenoid tuberosity at the upper margin of the glenoid cavity, and is continuous with the glenoidal labrum. This tendon, enclosed in a special sheath of the synovial membrane of the shoulder joint, arches over the head of the humerus. It emerges from the capsule through an opening close to the humeral attachment of the ligament, and descends into the intertubercular groove. It is retained in the groove by the transverse humeral ligament, and by a fibrous prolongation from the tendon of the pectoralis major. Each tendon is succeeded by an elongated muscular belly, and the two bellies, although closely applied to each other, can readily be separated until within about 7.5 centimetres of the elbow joint. Here they end in a flattened tendon, which is inserted into the rough posterior portion of the tuberosity of the radius, a bursa being interposed between the tendon and the front part of the tuberosity. As the tendon of the muscle approaches the radius, it is twisted upon itself, so that its anterior surface becomes lateral and is applied to the tuberosity of the radius at its insertion. Opposite the bend of the elbow, the tendon gives off, from its medial side, a broad aponeurosis, the lacutus fibrosus, bicipital fascia, which passes obliquely downward and medialward across the brachial artery, and is continuous with the deep fasciae covering the origins of the flexor muscles of the forearm. Variations. A third head, 10%, to the biceps brachii is occasionally found, arising at the upper and medial part of the brachialis, with the fibres of which it is continuous, and inserted into the lacetus fibrosus and medial side of the tendon of the muscle. In most cases, this additional slip lies behind the brachial artery in its course down the arm. In some instances, the third head consists of two slips, which pass down, one in front and the other behind the artery, concealing the vessel in the lower half of the arm. More rarely, a fourth head occurs, arising from the outer side of the humerus, from the intertubercular groove, or from the greater tubercle. Other heads are occasionally found. Slips sometimes pass from the inner border of the muscle over the brachial artery to the medial intermuscular septum, or the media epicondyle, more rarely to the pronator teres or brachialis. The long head may be absent or arise from the intertubercular groove. The brachialis, brachialis anticus, covers the front of the elbow joint and the lower half of the humerus. It arises from the lower half of the front of the humerus, commencing above at the insertion of the deltoideus, which it embraces by two angular processes. Its origin extends below to within 2.5 centimetres of the margin of the articular surface. It also arises from the intermuscular septa, but more extensively from the medial than the lateral. It is separated from the lateral below by the brachioradialis and extensor carpi radialis longus. Its fibres converge to a thick tendon, which is inserted into the tuberosity of the ulna and the rough depression on the anterior surface of the coronoid process. Variations. Occasionally doubled. Additional slip to the supinator, pronator teres, biceps, lacutus fibrosus, or radius are more rarely found. Nerves. The choriobrachialis, biceps brachii, and brachialis are supplied by the musculocutaneous nerve. The brachialis usually receives an additional filament from the radial. The coracobrachialis receives its supply primarily from the seventh cervical, the biceps brachii and the brachialis from the fifth and sixth cervical nerves. Actions. The choriobrachialis draws the humerus forward and medialward, and at the same time assists in retaining the head of the bone in contact with the glenoid cavity. The biceps brachii is a flexor of the elbow, and to a lesser extent of the shoulder. It is also a powerful supinator, and serves to render tense the deep fasciae of the forearm by means of the lacetus fibrosus given off from its tendon. The brachialis is a flexor of the forearm, and forms an important defence to the elbow joint. When the forearm is fixed, the biceps brachii and brachialis flex the arm upon the forearm, as in efforts of climbing. The triceps brachii, triceps extensor cubiti, is situated on the back of the arm, extending the entire length of the dorsal surface of the humerus. It is of a large size, and arises by three heads, long, lateral, and medial, hence its name. The long head arises by a flattened tendon from the infraglenoid tuberosity of the scapula, being blended at its upper part with the capsule of the shoulder joint. The muscular fibres pass downward between the two other heads of the muscle, and join with them in the tendon of insertion. The lateral head arises from the posterior surface of the body of the humerus, between the insertion of the teres minor and the upper part of the groove for the radial nerve, and from the lateral border of the humerus and the lateral intermuscular septum. The fibres from this origin converge towards the tendon of insertion. The medial head arises from the posterior surface of the body of the humerus, below the groove for the radial nerve. It is narrow and pointed above, and extends from the insertion of the teres major to within 2.5 centimetres of the trochlea. It also arises from the medial border of the humerus, and from the back of the whole length of the medial intramuscular septum. Some of the fibres are directed downward to the olecranon, while others converge to the tendon of insertion. The tendon of the triceps brachii begins about the middle of the muscle. It consists of two aponeurotic laminae, one of which is subcutaneous and covers the back of the lower half of the muscle. The other is more deeply seated in the substance of the muscle. After receiving the attachment of the muscular fibres, the two lamellae join together above the elbow and are inserted, for the most part, into the posterior portion of the upper surface of the olecranon. A band of fibres is, however, continued downward on the lateral side over the anconeus to blend with the deep fasciae of the forearm. The long head of the triceps brachii descends between the teres minor and teres major, dividing the triangular space between these two muscles and the humerus into two smaller spaces, one triangular, the other quadrangular. The triangular space contains the scapular circumflex vessels. It is bounded by the teres minor above, the teres major below, and the scapular head of the triceps laterally. The quadrangular space transmits the posterior humeral circumflex vessels and the axillary nerve. It is bounded by the teres minor and capsule of the shoulder joint above, the teres major below, the long head of the triceps brachii medially, and the humerus laterally. Variations. A fourth head from the inner part of the humerus, a slip between triceps and latimus dorsi corresponding to the dorso-epitrocularis. The subanconius is the name given to a few fibres which spring from the deep surface of the lower part of the triceps brachii and are inserted into the posterior ligament and synovial membrane of the elbow joint. Nerves. The triceps brachii is supplied by the 7th and 8th cervical nerves through the radial nerve. Actions. The triceps brachii is the great extensor muscle of the forearm and is the direct antagonist of the biceps brachii and brachialis. When the arm is extended, the long head of the muscle may assist the teres major and latissimus dorsi in drawing the humerus backward and in abducting it to the thorax. The long head supports the under part of the shoulder joint. The
Section 46 of Gray's Anatomy, Part 2. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Bologna Times. Anatomy of the Human Body, Part 2, by Henry Gray. The muscles and fascia of the forearm. The muscles and fascia of the forearm. Antebrachial fascia, fascia antebrachii, deep fascia of the forearm. The antebrachial fascia, continuous above with the brachial fascia, is a dense membranous investment, which forms a general sheath for the muscles in this region. It is attached behind to the olecranon and dorsal border of the ulna, and gives off from its deep surface numerous intermuscular septa, which enclose each muscle separately. Over the flexor tendons, as they approach the wrist, it is especially thickened, and forms the volar carpal ligament. This is continuous with the transverse carpal ligament, and forms a sheath for the tendon of the palmaris longus, which passes over the transverse carpal ligament to be inserted into the palmar Aponeuroses. Behind, near the wrist joint, it is thickened by the addition of many transverse fibers, and forms the dorsal carpal ligament. It is much thicker on the dorsal than on the volar surface, and at the lower than at the upper part of the forearm, and is strengthened above by tendinous fibers derived by the biceps brachii in front, and from the triceps brachii behind. It gives origin to muscular fibers, especially at the upper part of the medial and lateral sides of the forearm, and forms the boundaries of a series of cone-shaped cavities in which the muscles are contained. Besides the vertical septa separating the individual muscles, transverse septa are given off both on the volar and dorsal surfaces of the forearm, separating the deep from the superficial layers of muscles. Apertures exist in the fascia for the passage of vessels and nerves. One of these apertures, of large size, situated at the front of the elbow, serves for the passage of a communicating branch between the superficial and deep veins. The antebrachial or forearm muscles may be divided into a volar and a dorsal group. The volar antebrachial muscles. These muscles are divided for convenience of description into two groups, superficial and deep. The superficial group: pronator teres, palmaris longus, flexor carpi radialis, flexor carpi ulnaris, flexor digitorum sublimis. The muscles of this group take origin from the media epicondyle of the humerus by a common tendon. They receive additional fibers from the deep fascia of the forearm near the elbow, and from the septa, which pass from this fascia between the individual muscles. The pronator teres has two heads of origin, humeral and ulnar. The humeral head, the larger and more superficial, arises immediately above the medial epicondyle and from the tendon common to the origin of the other muscles, also from the intermuscular septum between it and the flexor carpi radialis, and from the antebrachial fascia. The ulnar head is a thin fasciculus which arises from the medial side of the coronoid process of the ulna, and joins the preceding at an acute angle. The median nerve enters the forearm between the two heads of the muscle, and is separated from the ulnar artery by the ulnar head. The muscle passes obliquely across the forearm, and ends in a flat tendon, which is inserted into a rough impression at the middle of the lateral surface of the body of the radius. The lateral border of the muscle forms the medial boundary of a triangular hollow situated in front of the elbow joint, and containing the brachial artery, median nerve, and tendon of the biceps brachii. Variations: absence of ulnar head, additional slips from the medial intermuscular septum, from the biceps, and from the brachialis anticus occasionally occur. The flexor carpi radialis lies on the medial side of the preceding muscle. It arises from the medial epicondyle by the common tendon, from the fascia of the forearm, and from the intermuscular septa between it and the pronator teres laterally, the palmaris longus medially, and the flexor digitorum sublimis beneath. Slender and aponeurotic in structure at its commencement, it increases in size and ends in a tendon which forms rather more than the lower half of its length. This tendon passes through a canal in the lateral part of the transverse carpal ligament and runs through a groove on the greater multangular bone. The groove is converted into a canal by fibrous tissue and lined by a mucous sheath. The tendon is inserted into the base of the second metacarpal bone and sends a slip to the base of the third metacarpal bone. The radial artery in the lower part of the forearm lies between the tendon and this muscle and the brachioradialis. Variations. Slips from the tendon of the biceps, the lacertus fibrosus, the coronoid, and the radius have been found. Its insertion often varies and may be mostly into the annular ligament, the trapezium, or the fourth metacarpal, as well as the second or third. The muscle may be absent. The palmaris longus is a slender, fusiform muscle lying on the medial side of the preceding. It arises from the medial epicondyle of the humerus by the common tendon, from the intermuscular septa between it and the adjacent muscles, and from the antebrachial fascia. It ends in a slender, flattened tendon, which passes over the upper part of the transverse carpal ligament, and is inserted into the central part of the transverse carpal ligament and lower part of the palmar aponeuroses, frequently sending a tendinous slip to the short muscles of the thumb. Variations. One of the most variable muscles in the body. This muscle is often absent about 10% and is subject to many variations. It may be tendinous above and muscular below, or it may be muscular in the center with a tendon above and below, or it may be present two muscular bundles with a central tendon, or finally it may consist solely of a tendinous band. The muscle may be double. Slips of origin from the coronoid process or from the radius have been seen. Partial or complete insertion into the fascia of the forearm, into the tendon of the flexor carpi ulnaris and pisiform bone, into the navicular, and into the muscles of the little finger have been observed. The flexor carpi ulnaris lies along the ulnar side of the forearm. It arises by two heads, humeral and ulnar, connected by a tendinous arch, beneath which the ulnar nerve and posterior ulnar recurrent artery pass. The humeral head arises from the media epicondyle of the humerus by the common tendon. The ulnar head arises from the medial margin of the olecranon and from the upper two-thirds of the dorsal border of the ulna by an aponeurosis common to it, and the extensor carpi ulnaris and flexor digitorum profundus, and from the intermuscular septum between it and the flexor digitorum sublimis. The fibers end in a tendon which occupies the anterior part of the lower half of the muscle and is inserted into the pisiform bone. It is prolonged from this to the hamate and fifth metacarpal bones by the pisohamate and pisometacarpal ligaments. It is also attached by a few fibers to the transverse carpal ligament. The ulnar vessels and nerve lie on the lateral side of the tendon of this muscle, in the lower two-thirds of the forearm. Variations. Slips of origin from the coronoid. The epitrocleo anoconeus, a small muscle often present, runs from the back of the inner condyle to the olecranon over the ulnar nerve. The flexor digitorum sublimis is placed beneath the previous muscle. It is the largest of the muscles of the superficial group, and arises by three heads, humeral, ulnar, and radial. The humeral head arises from the medial epicondyle of the humerus by the common tendon, from the ulnar collateral ligament of the elbow joint, and from the intermuscular septa between it and the preceding muscles. The ulnar head arises from the medial side of the coronoid process, above the ulnar origin of the pronator teres. The radial head arises from the oblique line of the radius, extending from the radial tuberosity to the insertion of the pronator teres. The muscle speedily separates into two planes of muscular fibers, superficial and deep. The superficial plane divides into two parts which end in tendons for the middle and ring fingers. The deep plane gives off a muscular slip to join the portion of the superficial plane which is associated with the tendon of the ring finger, and then divides into two parts, which end in tendons for the index and little fingers. As the four tendons thus formed pass beneath the transverse carpal ligament into the palm of the hand, they are arranged in pairs, the superficial pair going to the middle and ring fingers, the deep pair to the index and little fingers. The tendons diverge from one another in the palm and form dorsal relations to the superficial volar arch and digital branches of the median and ulnar nerves. Opposite the bases of the first phalanges, each tendon divides into two slips to allow of the passage of the corresponding tendon of the flexor digitorum profundus. The two slips then reunite and form a grooved channel for the reception of the accompanying tendon of the flexor digitorum profundus. Finally, the tendon divides and is inserted into the sides of the second phalanx about its middle. Variations: absence of radial head, of little finger portion. Accessory slips from ulnar tuberosity to the index and middle finger portions, from the inner head to the flexor profundus, from the ulnar to annular ligament to the little finger. The deep group: flexor digitorum profundus, flexor pollicis longus, pronator quadratus. The flexor digitorum profundus is situated on the ulnar side of the forearm, immediately beneath the superficial flexors. It arises from the upper 3/4 of the volar and medial surfaces of the body of the ulna, embracing the insertion of brachialis above, and extending below to within a short distance of the pronator quadratus. It also arises from a depression on the medial side of the coronoid process, by an aponeuroses from the upper 3/4 of the dorsal border of the ulna, in common with the flexor and extensor carpi ulnaris, and from the ulnar half of the interosseous membrane. The muscle ends in four tendons which run under the transverse carpal ligament dorsal to the tendons of the flexor digitorum sublimis. Opposite the first phalanges, the tendons pass through the openings in the tendons of the flexor digitorum sublimis and are finally inserted into the bases of the last phalanges. The portion of the muscle for the index finger is usually distinct throughout, but the tendons for the middle, ring, and little fingers are connected together by areolar tissue and tendinous slips as far as the palm of the hand. Fibrous sheaths of the flexor tendons. After leaving the palm, the tendons of the flexorus digitorum sublimis and profundus lie in osseo-aponeurotic canals, formed behind the phalanges and in front by strong fibrous bands, which arch across the tendons, and are attached on either side to the margins of the phalanges. Opposite the middle of the proximal and second phalanges, the bands, digital vaginal ligaments, are very strong, and the fibers are transverse, but opposite the joints they are much thinner, and consist of annular and cruciate ligamentous fibers. Each canal contains a mucous sheath, which is reflected on the contained tendons. Within each canal The tendons of the flexorus digitorum sublimis and profundus are connected to each other, and to the phalanges by slender tendinous bands called vincula tendina. There are two sets of these: a. The vincula brevia, which are 2 in number in each finger, and consist of triangular bands of fibers, one connecting the tendon of the flexor digitorum sublimis to the front of the first interphalangeal joint and head of the first phalanx, and the other the tendon of the flexor digitorum profundus to the front of the second interphalangeal joint and head of the second phalanx. B. The vincula longa, which connect the undersurfaces of the tendons of the flexor digitorum profundus to those of the subjacent flexor sublimis after the tendons of the former have passed through the latter. Variations. The index finger portion may arise partly from the upper part of the radius. Slips from the inner head of the flexor sublimis, medial epicondyle, or the coronoid are found. Connection with the flexor pollicis longus. 4 small muscles, the lombricals, are connected with the tendons of the flexor profundus in the palm. They will be described with the muscles of the hand. The flexor pollicis longus is situated on the radial side of the forearm, lying in the same plane as the preceding. It arises from the grooved volar surface of the body of the radius, extending from immediately below the tuberosity and oblique line to within a short distance of the pronator quadratus. It arises also from the adjacent part of the interosseous membrane, and generally by a fleshy slip from the medial border of the coronoid process, or from the medial epicondyle of the humerus. The fibers end in a flattened tendon, which passes beneath the transverse carpal ligament, is then lodged between the lateral head of the flexor pollicis brevis and the oblique part of the adductor pollicis, and entering an osseo-aponeurotic canal, similar to those for the flexor tendons of the fingers, is inserted into the base of the distal phalanx of the thumb. The volar interosseous nerve and vessels pass downward on the front of the interosseous membrane between the flexor pollicis longus and flexor digitorum profundus. Variations. Slips may connect with flexor sublimis or profundus or pronator teres. An additional tendon to the index finger is sometimes found. The pronator quadratus is a small flat quadrilateral muscle extending across the front of the lower parts of the radius and ulna. It arises from the pronator ridge on the lower part of the volar surface of the body of the ulna, from the medial part of the volar surface of the lower fourth of the ulna, and from a strong aponeuroses which covers the medial third of the muscle. The fibers pass lateralward and slightly downward to be inserted into the lower fourth of the lateral border and the volar surface of the body of the radius. The deeper fibers of the muscle are inserted into the triangular area above the ulnar notch of the radius, an attachment comparable with the origin of the supinator from the triangular area below the radial notch of the ulna. Variations. Rarely absent. Split into 2 or 3 layers. Increased attachment upward or downward. Nerves. All the muscles of the superficial layer are supplied by the median nerve, excepting the flexor carpi ulnaris, which is supplied by the ulnar. The pronator teres, the flexor carpi radialis, and the palmaris longus derive their supply primarily from the 6th cervical nerve, the flexor digitorum sublimis from the 7th and 8th cervical and 1st thoracic nerves, and the flexor carpi ulnaris from the 8th cervical and 1st thoracic. Of the deep layer, the flexor digitorum profundus is applied by the 8th cervical and 1st thoracic through the ulnar and the volar interosseous branch of the median. The flexor pollicis longus and pronator quadratus are supplied by the 8th cervical and 1st thoracic through the volar interosseous branch of the median. Actions. These muscles act upon the forearm, the wrist, and hand. The pronator teres rotates the radius upon the ulna, rendering the hand prone. When the radius is fixed, it assists in flexing the forearm. The flexor carpi radialis is a flexor and abductor of the wrist. It also assists in pronating the hand and in bending the elbow. The flexor carpi ulnaris is a flexor and adductor of the wrist. It also assists in bending the elbow. The palmaris longus is a flexor of the wrist joint. It also assists in flexing the elbow. The flexor digitorum sublimis flexes first the middle and then the proximal phalanges, It also assists in flexing the wrist and elbow. The flexor digitorum profundus is one of the flexors of the phalanges. After the flexor sublimis has bent the second phalanx, the flexor profundus flexes the terminal one, but it cannot do so until after the contraction of the superficial muscle. It also assists in flexing the wrist. The flexor pollicis longus is a flexor of the phalanges of the thumb. When the thumb is fixed, it assists in flexing the wrist. The pronator quadratus rotates the radius upon the ulna, rendering the hand prone. End of section 46. Recording by Bologna